Dr. Mahesh Desai, sir, Dr. N.P. Gupta, sir, and Dr. Anand Kumar, sir. Please join. Thank you.
Yeah, good morning, Prokar. Can you start, please?
Good morning, everyone. May I acknowledge, there's some sound going on. May I acknowledge that it's a great privilege for me to share the stage this morning with two great friends. The first is Alan McNeil, who is about to speak after me, the chair of the BJUI, and the second is none other than the most influential urologist in the whole of Europe. Guy's and St. Thomas's is one of the oldest hospitals in the United Kingdom with this amazing view. The two together are 1,000 years old. That's why the GSTT lecture. I pay homage here to the late John Wickham, the first robotic surgeon in the world. This is the two of them. Can I please request you to talk about fish, etc., some other time? John Wickham was the first robotic surgeon on earth. This is him 10 years ago at the opening of the King's Fatiguti Institute, and the first 30 cases of prostatectomy with a robot, a TUR vaporization, was done at Guy's. Take a look at the data from the Royal College of Surgeons of England. This is the legacy data. 20 years ago, when we started, we were the only people doing robotic prostatectomy in the whole of UK. 20 years later, that number is 94%. So we have completely changed the way this operation is performed on the small island. If you look at the graph, third along on top from the left, that is cystectomy, and that remains at about 50-50, with some doing open, some doing robotic, and a few doing laparoscopic. So it hasn't quite caught on for cystectomy. Just last month, we celebrated over 10,000 cases at Guy's and St. Thomas's. Even during the pandemic, you will notice that we had done over 700 cases, and last year nearly 1,700 cases. So there are 9 machines within this organization, so we have really grown. It's fully multidisciplinary, and over 10,000 Da Vinci cases now done in a 20-year period. So what have we learned over these 20 years? Declan Murphy was, at that time, my fellow. You will know him as the professor of urology in Melbourne. He followed Tony Costello into the job. And this is the diagram from the first paper that Declan published on robotic prostatectomy in the Platinum Journal. You will notice the patient has got his legs on yellowfin stirrups. The yellowfins were because we were trying to reduce the risk of compartment syndrome. If you just put them on Lloyd Davis stirrups, the problem would be that you would get compartment syndrome, because the cases were taking 7-8 hours. In those days, no one knew how to do anything. The W configuration of the ports on the right side is now standard of care. It took us a while to figure this out. And the robot, the original Da Vinci, used to be docked in the middle of the legs. But this is the port positioning now. Look at this. The patient is lying flat. The robot is docked from the side. And the most important image in this is the human being. That is Harold Umana, who is actually a surgical care practitioner, a nurse. So all our robotic cases are now assisted by surgical care practitioners. This is something you've had in India for a long time. In the UK, this is now 10 years old. When we started, we used to be assisted by our fellows who would rather sit at the console, but now they do get to sit at the console rather than assist at the patient side. The other thing that has changed now is I operate at a low pressure pneumoperitoneum of 8 millimeters of mercury. This is with an air seal device which keeps the pneumoperitoneum at a fixed airway pressure. And this was driven by COVID because we could either stop operating or we could carry on at low pressure. And now this for us has become standard of care because it causes less pain to the patient post-operatively. This diagram is from 20 years ago with additions. In those days, we used to either go trans or extraperitoneal. Then came the Rexia sparing, the Italian modification, which you can only perform robotic. The issue being that you have quicker continence, but the margins go up because the space is restricted. And then you see these other two ways of doing it by the single port. This is driven by Jihad Kauk, either suprapubic or transperineal single port. We don't yet have this technology in Europe. And you dock the robot directly into the bladder. 90% plus of Jihad's patients are now done as a day case, single port transfer cycle. Can you believe it? This paper is now 13 years old, 2010. And what this is showing you is not just the anatomy, but the fact that this is the first time you can fly in the MRI scan of the patient into the operative field. So this is the first demonstration of image-guided robotic surgery. You see a large anterior tumor in this patient, and this was done by Steve Thompson, who was my PhD student at the time, an engineer who subsequently got poached by industry and is doing quite well in the liver world doing image-guided robotic surgery. If you haven't read this paper had all the big names in anatomy at the time. You heard one of them yesterday, Mani Menon. It had Tony Costello. This came out when Khurshid was in Menon's lab. You will see here, it shows you that the sphincter muscle is deficient at the back. This is anatomical principles. It has got Bob Myers's APCs from the Mayo Clinic. And this is the reason why when I operate, I look at the apex first from the right and then from the left, because I don't want to cut across the apex. I don't want to get a positive margin. I teach this all the time to my students. And the fact that the sphincter is weak at the back will become important as a technical step in a few minutes. Yesterday, you saw Dr. Menon demonstrate the hammock method of how the nerves grow out, with the prostate literally, embryologically sitting in the hammock, just like that lady is on a beach in Hawaii. This is not a figment of imagination. If you look at cadaveric studies, the hammock does indeed exist, but you can't see it. So you can only see the hammock on the right side in a cadaver. You can't see it in real life because the hammock is covered by layers of tissue. The problem is these interconnecting nerves between the neurovascular bundles on the two sides are always removed because we go behind the prostate when we are trying to do a robotic prostatectomy. In my own practice, it is very rare now to be able to do an intrafacial nerve spare. Majority are interfacial because over half my patients have T3 disease. So in those patients, we go wider on that side, just like we have here. But the small volume Gleason 6s are really all given active monitoring. So the intrafacial nerve sparing with a glistening surface on the back of the prostate is now rare in my practice. The nerve supply is controversial. This is important. This paper is from Tony Costello, exactly 20 years old, and his view is that the real nerves are just like Patrick Walsh described, which are here, and the nerves along the veil are either going to the levator ani or intraprostatic. So we believed this from Tony's work. He had a number of PhD students in the lab working on this, and we believed that this was the way the nerves were. On the left, you see the classic Walsh description of the nerves, again posterolateral here. And this was Dr. Menon's description, which I was questioning him about, where he believes that at the apex, if you do celloidin staining and track the nerves, at the apex, the neurovascular bundles split. Half go anterior and the other half posterior. It means that if you cut the dorsal vein complex or you put a suture across it, you will get half the nerves, whatever you do at the back. So this causes me considerable concern, but we can't change the human anatomy. So we are still, after all these years, learning about the nerve supply to the penis. This is again Declan's original description. Over the years, we go transperitoneal. We hold this catheter with the fourth arm. I certainly do not use a stitch like this through the tip of the catheter. We dissect the seminal vesicles at the tip by using a clip. We never use any diathermy here. We dissect the seminals medially. And then, as I said, I toggle the prostate from side to side, particularly at the apex, to try and preserve as much of the sphincter muscle as possible and not get a positive margin at the apex. The Rocco stitch failed to recruit. A randomized trial by Bernardo Rocco in Italy, an international trial, failed to recruit. So we do not know whether this causes earlier continence, but it certainly reduces the hematoma behind the prostate and behind the bladder, and it certainly makes the anastomosis a lot easier. So this is how we do it. This is a video which was shown at the Vatiquity Foundation. You will see the Vatiquity logo on the right side. Let me orientate you. The symphysis pubis is at the top. The prostate is in the middle, so everything is reversed, as you know. This is how we find the catheter, by tugging on it. We also pinch the prostate from side to side, and that is the point at which the fat does not come off the prostate anymore. You will see the left hand does a lot of work. It goes inside the prostate like a Millin's retractor. So it goes inside the bladder, we open it up like a Millin's retractor, and the tissue at the back is found by making this maneuver. This is the vas on the left side, which we clip. You will now see what is called the flip maneuver, where the vas is held by the assistant and is pulled back, and then you dissect the seminal vesicle medially, just like you see here in the picture. So the seminal has to be dissected medially first. This is where the hammer gets destroyed, because this is the posterior part of the dissection. Yep. This is where you find the fat. Clearly, if you have an advanced tumor, then you have to stay wider. This is the nerve spare on the right side. You will see this is the incremental nerve spare keeping some of the tissue on the prostate, because this is T2 disease on that side. This is the left nerve spare. This is much closer to the prostate, because on MRI scan we have found that there is no disease on this side of the gland. Not that we can see on MRI anyway, and on the transperineal biopsies that we have performed. So here we are able to do a veil-like dissection, although, as I said, it's controversial as to whether these nerves indeed go into the penis as supplying the cavernous area. Once we have done that, the fourth arm holds the prostate back. The dorsal vein complex is cut cold. I used to stitch it, but I stopped stitching it and then cutting it. This bleeds a bit more. This is simply because if I put a stitch across it, I'm worried that I would take those anterior nerves. And this way, I get the maximum urethral length. You will notice that I am moving the prostate very soon from side to side, as I said. Look, I'm moving it to the right so that I look at the left apex, and I'll do the same on the other side. So here are the two neurovascular bundles. The left side is clearly preserved much better than on the right side, but then the disease is palpable on the right side as T2. We use a V-lock suture to stitch the dorsal vein complex at this point. Notice that the assistant does not suck the blood, so you have to take a bit of bleeding, although when you measure it, it is not much more than 100 ml. Once you've done this, you will see that I'll try to put a Rocco stitch. This is the posterior reconstruction, and this is where the deficiency of the sphincter at the back, where it is a horseshoe, is important, and I put a deep stitch at the 5 o'clock position to stabilize the sphincter. The science behind that will become obvious by the end of this talk. So let's see what data we have from all these variations of technique. There is only a single randomized trial comparing open and robotic prostatectomy from Australia. It was published in The Lancet. All the others, Coral, Razor, and IROC, are cystectomy trials. Coral is our own trial, which was mentioned yesterday, the only one comparing open robotic and laparoscopic cystectomy. The trials tell us that the outcome depends on the surgeon, not on the technology. Unfortunately, 20 years of trials have shown that we all are different as artists, and the patient has to find the right artist to operate on them. So that's what the trials tell us. Slightly sad, but that's what they tell us. So what are the things that haven't changed, you may ask, in this time period? The one thing that hasn't changed is counseling of the patients about continence and erections before we touch them with a knife. This was done by one of our specialist nurses. This was a quasi-randomized study. You will see that blue curve on top. That is called a HAD score, or anxiety and depression score. If you do not counsel the patient, they regret the operation more than they do if you counsel them. When we started the first program in Eastern India, I said to Amit, please be sure that your patients are counseled beforehand, because once you've operated on them, the bird has flown. It's too late. You can't manage their expectations. And this is one thing that hasn't changed despite changes in techniques and artists. The other thing that has changed is cost. I went around the world saying for many years that robotics was really cost inefficient. We combined the data from King's with data from Quoctin and Harvard and came up with two important papers, both published in the Journal of the American Medical Association, showing that the out-of-pocket cost or the societal cost of robotic surgery for most cancers, including radical prostatectomy, are cheaper than open prostatectomy. This is an American paper, as I said, between King's and Harvard. The second paper was an NHS paper showing that even in a socialist system, we finally have data to show that we did not sell off the National Health Service. Which brings us to the assessment of newer devices. I call this the supermarket effect. Say you go to a supermarket, you have expensive crisps, you have less expensive crisps, and you have the supermarket crisps. If the supermarket crisps taste as good as the most expensive crisps, I know what I'm going to buy. But you have to make sure that those crisps are as good as the most expensive crisps. The way we do it is follow the ideal framework. I've been talking about this for a number of years. This is from Balliol College in Oxford, where stage 1 is an idea, stage 2A is developing that idea, i.e. small series. Stage 2B is then exploring it at multiple sites. Then stage 3 are randomized trials, and stage 4 is long-term monitoring. So this is the ideal stage 1, 2A of the Versius robot. You will see it here in the next room. The CMR team are here. And the primary outcome was to make sure that we could feasibly do this without conversion or causing the patient a Clavien-Dindo complication grade 2 or above. And the secondary outcomes are operative time, margin status, and early continence. This is the CMR robot. The first time it was launched in the world was in Lata Mangeshkar's hospital in Pune, but that was not in urology. So the first urology paper actually comes out of Guy's and St. Thomas's. You will see this is a modular open console. All the controls are in the hands of the surgeon. You can't do anything with your feet, even if you stamp them. The controls are entirely in the hands. It's an open console, so it's kinder to your neck. This has really been a team effort for us during the pandemic. This is never a one-man show. You have to undergo a number of hours of virtual reality training, and I urge anyone going on to a new robot, just because you've used the Da Vinci doesn't mean you'll be good at a new system. So you have to do your time and do the VR training on any new machine that you purchase. What CMR have now done is develop what is called a metaverse like virtual reality training. So these are headsets which you can use. You have little hand controls, you have a headset, and you can train your entire team in a virtual world or a metaverse as to how to dock the robot. And this is absolutely new. It's just been launched for prime time. So you can do this at home. You don't even have to go into an operating room, and you can do team training in a virtual environment. This is the video of the first ideal stage 0 in a cadaver, which was shown before the pandemic at the ERAS meeting in Marseille. You'll see the nerve sparing is pretty good. These are stage 1 instruments. So these are the early needle drivers, not quite as good as the needle drivers now, but this is an ideal stage 0 where you show that it is successful in a cadaver. This is the first robotic prostatectomy done in the UK. You will see that I have put a suture on the dorsal vein complex because I was told 2 days before that the needle drivers were perhaps not as good as I was expecting. The problem is this was a gynecologist, a friend who had come specifically to be operated on by me, and I had to tell Mark Slack, who is the CMO of the company, that despite his reservations, we had to go ahead with the operation. But you'll see here, the urethral length is excellent, and I'm actually correcting the cut behind because you see there's a bit of a lip of prostate extending at the back. I'm cutting beyond it. So this is the first result, and you can see these are version 2 needle drivers, and already we are now into version 3 needle drivers for CMR. This was the first paper on CMR in urology in the world. It was published last year. This was the ideal stage 1/2A evaluation showing that the operation was feasible and safe with a single complication and no positive margins. It was followed a week later by this paper in the Journal of Robotic Surgery from the SIUT, which has now completed over 1,500 procedures with the Versius robot. So this is now the most prolific Versius center in the world. Please don't photograph this and put it on Twitter because it's currently being considered by the BMJ. This is the stage 2B where 5 centers, including Allen's Center, have collaborated on the CMR data. And again, you will see that here we have had 1 device failure with conversion to laparoscopy, 1 converted to open, 11% Clavien-Dindo class 3-4 complications, and 1 positive margin. All the patients who had robotic prostatectomy were continent at 1 year. So this is how we are progressing from a stage 0, stage 1/2A to a stage 2B. And then comes yet another new machine, the Hugo. We have the first 2 Hugo robots within the UK at Guy's and Tommy's. So again, we do the same thing. This is a stage 1/2A, same team, same assistant, same anesthetist, same theater. The only one change is the robot. You will see my colleague Ben Chalakam and I, we have always done these cases jointly just to support each other, despite having worked together for 20 years. I think it's good to have a buddy with you. This is the port positioning. The right-hand side has a single arm, and the other arms, including the camera, are all on the left side. Now see how this video completely changes, because over 20 years we have done something that is completely different. We now do surgical data science, whereby we record the entire environment. See this? We record the entire environment to see if we can do human factors and reduce complications. So you see, this labeling by an augmented reality platform called Proximie is completely automatic. It is an intelligent device which can read the phases of the operation and therefore reduce complications and improve outcomes. So it is not just one video, but it is 4 videos running at the same time, because this is an augmented reality platform. Here is the data in the first 20 patients that we have done. We don't have a single positive margins in a phase 1/2A study. And these are patients with T3B disease, T3A disease. So this is not us choosing the small volume Gleason 6s. Unfortunately, we've had 2 complications, Clavien-Dindo 1, 2 complications, Clavien-Dindo 3, and 3 irrecoverable device failures, 2 arm failures where we operated with 3 arms, and 1 monitor failure where we had the Proximie monitor and therefore did not need to convert. So where am I today with all this? Where is the future for me? The future is artificially intelligent. The first AI fringe has already happened with Rishi Sunak just a month ago. I was lucky to be there, and the future for us is investment in AI. This is where all the magic happens, in a lab in the basement of St. Thomas's Hospital opposite the Houses of Parliament, where we have the fastest computer system today in the world, which is NVIDIA from Cambridge One. We have computational monitoring, we have smart probes, we even have the ability to use AI to volumize images from CT and MRI to generate a 3D print. So you see, this is a 2D image which is being volumized in an automated fashion, even for the heart or the lungs. And you get a 3D print, you take it into the operating room, and then you use it to plan your operation. This is the stage 1 study, which was published in 2018, showing that in T3 disease, you can reduce, using this kind of a 3D print, the positive margins from 35 to 10%. This is currently being investigated in a study called TIGERS, or Touch and Image Guided Robotic Surgery, where we have 3 arms. One is standard practice, the second is a 3D print, as you see in the middle, and the third is a startup, where you have a 3D image on a laptop or a computer attached to the robot, but you don't actually have a 3D print. So the difference between a 3D print and a 3D image on the inner side is that you don't have the sense of touch. And we are looking at positive margins and functional outcomes. The other thing that is happening is the Mastery study, where you take a surgical video, put it into a black box, you measure the movements of the instruments and systems events data, and this is called automated performance metrics. We have noticed from Andrew Hunt's work that that 5 o'clock stitch at the back, if it is put deeper, leads to better earlier continence, based on the fact that the box sees that movement. The challenge is, can we teach that gesture to the next generation of surgeons? In the training world, we have adopted something called the MARS project. This was a 5-center European, pan-European evaluation, which was Nick Raison's PhD thesis. One of the outcomes from the MARS project was that if you train the brain just like you do in sports, you can perform better. So there's a randomized trial. On the left, you see in blue the patients who had surgery by surgeons who just turned up and operated, and in red, those who are using mental imagery, showing that the technical skills measured are better. So the higher the score on the y-axis, the better is the performance. And this happens because if you measure the function of the brain with MRI, you can actually see more activation, just like you do in sports people in the frontal lobe. So now we have added to the training pathway cognitive training after virtual reality TriLab, and modular training in a lab. Finally, AI has changed to just being technical to being socio-technical. This is a book from Google's DeepMind, released last week at the AI Fringe, which is talking about the changing landscape of AI, lessons from a year of policy discovery. So it's not just we can do something, is it right for society? And that's where AI is going. This is a major grant where we are looking at automation. Can we automate certain parts of an operation, such as suturing? Yes, we can. But we certainly cannot operate today entirely in an automated fashion. Guess what? We are going to keep our jobs as surgeons because each of our patients is slightly different from the other. Thank you very much indeed for having me. It's a pleasure to address you.
Thank you, Prokar. And we really enlightened with your lecture and to see what the new is coming up. Thank you very much. Can we go?
With this, we invite Dr. Alan McNeil. He is going to give us BJUI lecture, Surgical Management of High Risk and Oligometastatic Prostate Cancer in the Robotic Age. Sir.
Thank you, Chairman. With the permission of the organising chairman, I've changed the topic of my talk because I noticed there's quite a lot on oligometastatic or high-risk prostate cancer in the rest of the programme today. So I'm going to talk to you about the management of a positive surgical margin following a radical prostatectomy and how we have adapted our PSA follow-up programme in Lothian in Scotland. It's a great honour to be here, as I said yesterday, and I feel humbled to be speaking between Prokar and Arnulf, who are sort of two giants of urology. So I shall do my best to live up to the opportunity. So could I have the slides? Thank you. So, as you heard yesterday, I'm chairman of the board of trustees of the BJUI, and that's the main declaration of interest I have to make. I'm a founding shareholder in a company called IntelliPalp that has plans to commercialise a device called Prostapalp to measure the stiffness of prostate with the hope that that will aid in early diagnosis. And I've received honoraria from a few pharmaceutical companies. The BJUI is a family. It was, as you know, the BJUI, a British Journal of Urology, and then it became BJUI International. And the international is really important to us now. We've expanded the journals when Prokar was editing to include BJUI Compass, which is an open access journal that's growing steadily formerly under the editorship of John Davis, and now under the editorship of Michael Gorin, who's in New York. And then there's BJUI Knowledge, which we're very proud of. This is developed and published in-house by the BJUI team, whereas the journals are currently published by Wiley. BJUI Knowledge, as I said yesterday, it's an online learning platform, over 450 e-learning modules. There are videos, quick checks, bite-sized modules, podcasts. And as a charity with a mission to aid education in urology, we made the decision to make this free to access for all urological trainees. And we're delighted when Amit goes approached us, and we've collaborated with the section to give all members access through the section. So I hope you enjoy using it. The main content of the talk, I'm going to probably tell you how to suck eggs a little, in that I'll just run through the pathological process very briefly of assessing a post-prostatectomy specimen and what defines a positive surgical margin. We'll talk about the significance of R1 or positive surgical margin post-prostatectomy, what steps we can take to avoid a positive surgical margin, how we manage these patients, and I'll tell you about our PSA follow-up program in this digital age. And I'm sure with the IT skills that exist in India, you will be able to do better than we have done, but I hope I give you some food for thought and ideas to develop. So I believe, and I'm sure I'm correct in this, that the processing of a prostate post-prostatectomy is now standardized according to the International Society of Urological Pathology, which published this consensus statement in 2010. And the approach has been adopted and recommended by the College of American Pathologists and the Royal College of Pathologists in the UK. And as you know, the prostate is dipped in ink before being sliced horizontally, with the apical and basal slices being sliced longitudinally. And a positive surgical margin is defined as there being ink in contact with prostate cancer cells at the edge of the specimen. Positive surgical margin is reported in up to 31% of radical prostatectomy specimens, and of course the rate of that will depend on a number of things: the experience of the surgeon, age of the patient, higher tumour volume, grade and stage. It's significant because a positive surgical margin, or R1 state, is associated with an increased risk of PSA relapse within 5 years. As you can see, it doubles from approximately 5% to almost 11%. The site of the positive surgical margin affects the risk of PSA relapse, as is shown in this figure, which I borrowed from Alberto Briganti. And essentially, the apical positive surgical margin has the lowest risk of PSA relapse, with radial and basal margins having a higher risk. And we've looked at our own patient series and confirmed this, that a focal apical positive margin behaves almost the same way as a negative surgical margin with respect to PSA relapse rates. Now, how can we reduce the risk of a positive margin? And all of us who've done prostatectomy and any operation will recognize that through repetition and through listening and learning from colleagues, you will learn and adapt your technique, and you'll do the operation better over time. And that's demonstrated in this paper, where with experience the positive surgical margin rate was decreasing from 16.7% to 9.6% as the surgeon's experience increased from 10 to 250 cases, and that was reflected then in an increasing rate of biochemical relapse-free recurrence over time with increasing experience of the surgeon. But we all have to learn, and I think all we can do as more experienced surgeons is help our younger colleagues to start higher up the ladder of learning. As you heard from Prokhor, and I've borrowed the picture from their paper, preoperative planning reduces the risk of a positive surgical margin in T3 disease. And you can do this based on the MRI alone, or as they've done in Guy's, with a 3D printed model of the prostate. But most high volume centres in the UK will now undertake a planning meeting prior to prostatectomy, where they will sit with the radiologists and the surgeons. They will identify where the tumour is, so that when the surgeon goes to operate, they have in their mind's eye an idea of where the tumour is located, and that will reduce the risk of a positive margin in T3 disease. Others have promoted the use of intraoperative frozen section, and you will have heard of NeuroSafe, which is promoted by the Martini Group. And in NeuroSafe, or intraoperative frozen section, in Germany this is very popular, and Arnulf, I think, can confirm. The whole prostate will go off during the operation, having been marked up by the surgeon with paint on the outside of the prostate. And the team of pathologists will then spend perhaps 40 minutes undertaking frozen section analysis according to that methodology that we use post-prostatectomy. And the Martini Group have shown that by using this, you can reduce the rate of positive surgical margin in T3 disease and increase the nerve sparing that you're able to undertake. To my knowledge, this does not affect the risk of PSA relapse, but the increased nerve sparing will improve the functional outcomes of the patient. So, what do we do if we have a positive surgical margin? There is some evidence from this paper from Boller's group that offering post-operative adjuvant radiotherapy after radical prostatectomy improves the long-term outcomes in high-risk prostate cancer. And because of this, there was popularity, particularly amongst oncology colleagues, for offering adjuvant radiotherapy to patients with high-risk disease or positive surgical margins. And I've had, I'm sure Prokar and all surgeons have had not heated discussions, but passionate discussions about whether this was appropriate. And in our own unit, I would say to my oncology colleagues, look, we've got PSA. You know, whilst other cancers you offer adjuvant radiotherapy, they don't have a marker to detect recurrence. So if you offer everybody who has a positive margin or high-risk disease adjuvant radiotherapy, even if their PSA is undetectable, we can say with some certainty that you will be over-treating a significant proportion of those. But the emotional argument is brought to play, and anyway, this discussion went on until in 2020 we had the publication of Radicals and Raves. And these two studies came out almost contemporaneously, and they showed unequivocally that in a randomized controlled trial, offering immediate adjuvant radiotherapy offered no advantage in terms of oncological outcome over early salvage radiotherapy at the time of PSA relapse. However, those who were in the adjuvant treatment arm had a significantly worse functional outcome, which again should not come as a surprise because radiotherapy damages faster growing cells. Those cells that are healing and restoring function post-prostatectomy will inevitably be damaged if you irradiate them shortly after the operation, and therefore the functional outcomes will inevitably be worse. Whereas early salvage radiotherapy, you often will be irradiating healed tissue, particularly if it's more than a year and a half post-op. And in that setting, the impact on functional outcomes is obviously going to be reduced because you're irradiating scar tissue or healed tissue with some cancer cells at the bladder neck. So after the publication of these two studies, I think most oncologists have accepted that we offer early salvage rather than adjuvant radiotherapy. There are still those who say that, well, there weren't enough high-risk patients in these studies and perhaps they should still be offered adjuvant radiotherapy. But in our unit, our oncology colleagues have accepted that we monitor PSA before offering any further radiation or any other treatment. And I think the argument was then developed further when Freddie Hamdi and colleagues published the 15-year outcomes of the PROTECT study, which, as you know, had 3 arms: monitoring, surgery, and radiotherapy. And the primary outcome was prostate cancer-specific survival. And they showed that irrespective of the patient group, there was no difference in the overall prostate cancer-specific mortality rates in the patients that was significant. They had a few patients in the prostatectomy arm that went on to have radiotherapy, but insufficient to make a statement as to whether surgery plus radiotherapy was better than surgery and monitoring of PSA. But the key thing in this paper was that the long natural history of prostate cancer means that once a man has been treated for prostate cancer, his risk of mortality becomes quite low. Again, this paper contains mainly intermediate or lower risk patients, fewer high risk, and that's because it was detecting early disease through PSA testing. But nevertheless, the knowledge that once a man with intermediate risk prostate cancer has had a prostatectomy, his risk of mortality at 15 years from that prostate cancer drops to 2%, is really valuable when counselling patients about what to do if the PSA relapses. We define PSA relapse, as you know, in most centres. It will be accepted that it is indicated by a PSA of 0.2 or greater at 2 measurement points 2 to 3 months apart. If this occurs, as you can see, the risk of further PSA progression at 1 and 3 years is 86% and 100% respectively. Some centres, arguably quite wisely, have chosen a threshold of 0.4 or greater, and this is associated with a 74% chance of further PSA rise at 5 years and with the development of systemic disease. But I'd remind you, as I've just said, the cancer-specific mortality rate for prostate cancer remains low. Risk factors for this PSA relapse, as I've already said, include pre-op PSA levels, so higher is consistent with high grade or more advanced disease, higher Gleason grade, higher stage, and positive surgical margin. The median time to biochemical relapse after radical prostatectomy is 20 to 38 months. But this risk of PSA relapse after radical prostatectomy persists for many years. And I've heard Peter Albertson at a BJUI seminar saying everybody will relapse after radical prostatectomy at some point. This review article showed that relapse rates of above 0.2 are reported at 34, 44 and 52% at 10, 15 and 20 years. But PSA relapse does not mean you're going to die of prostate cancer. So again, I think we need to now be thinking about the patient this is occurring in before we jump in and allow them to be irradiated with the it's about side effects, it's about quality of life rather than risk of death from prostate cancer. Now, in our centre, this is our experience of minimal access radical prostatectomy. So back in 2006 was when I started laparoscopic radical prostatectomy, and you can see over the years the numbers fluctuated. We were way behind the curve in Scotland in terms of adopting robotic-assisted radical prostatectomy, and weren't able to do so until 2016. And then you can see the numbers of prostatectomies have steadily increased. So our standard practice for follow-up of these men is to offer PSA testing every 3 months for the first year. And you might argue this is only necessary for the higher risk disease, but we've adopted the 3 months every 3 months for the first year, because I think it's simpler for everybody if it's a simple protocol or pathway. They don't get confused. And we're often seeing these men every 3 months during the first year, because that's when you need the greatest support after the intervention of any operation. And then gradually, as you get further out for your operation, you need less psychological or holistic contact with your physios and your doctors, and you can wind down the frequency of PSA testing, so it's every 6 months in the first 5 years, and then annually up to 15 years, depending on the age of the man at the time of operation. And I often say to them, I would recommend you get your PSA tested annually until you lose interest or you forget you're supposed to have it done, because by then it probably doesn't matter. But if you take 15 years for each of those 250 patients every year, that's over the 15 years, 22 PSA tests each, which is 5,500 PSA tests. So quite a lot of PSA follow-up. And because these men do not die very often, the number of men under follow-up only just compounds every year. And this is illustrated by, again, our own experience. So here is the number of patients requiring PSA follow-up in our unit year on year since we began radical prostatectomy. And it just continues to grow, of course. When I started doing prostatectomy in 2006, a relatively high volume prostatectomist might have been doing 40 or 50 operations a year. And it was relatively reasonable to suggest that whilst these men did not come to the clinic, we could use a postal follow-up system, which was delegated to our CNS, or cancer nurse specialists. And they would, with administrative support, enter the patients into a program where they wrote to them every few months or every year. They got a questionnaire about symptoms, and they reminded the patient to have their PSA, and then the nurses would look up the results. So when we ran into problems with our general practitioners, and this is happening all over the UK, because we were asking those GPs to undertake the PSA testing and to report to us if the PSA was greater than 0.2. As a safety net, I would say to my patients, don't rely on the system. There's no one more interested in your PSA than you. Nobody. Don't assume that they'll all take care of you. But this created a lot of problems because our general practice colleagues felt unhappy that they were being burdened with the responsibility of detecting a PSA relapse and the consequences of a missed relapse. And there was a case in Lothian where a man presented 17 years after his radical prostatectomy with local and metastatic disease from which he died after systemic treatment. And of course that led to a complaint because his PSA had been tested and was rising steadily, but the doctors who were undertaking the PSA didn't think about the fact he'd had his prostate out because it was so long ago. The issue in the UK is compounded because in general practice, a patient will go to their GP practice and request a blood test. The GP has nothing to do often with the ordering of the blood test, nor putting in clinical information. So the phlebotomist who takes the blood will simply request the PSA. The GPs only get to see the results that are highlighted as abnormal by the lab. So if the PSA reference range the lab uses is 0 to 3 or 0 to 4, then a PSA relapse of 0.2, 0.3 will not be picked up or acted on by our general practice colleagues. So they felt very exposed, and there was an awful lot of pushback in our centre, and I know this is a problem up and down the UK. So we thought about how do we manage PSA follow-up after the radical prostatectomy. You know, who's going to remind the patient? Who's going to book the test? Who's going to review the results? So the first stage in our solution was to talk to our colleagues in the laboratories. And they were good enough to go back 20 years, get every single patient who'd had a radical prostatectomy, and the Path Lab told the biochemistry lab who these men were. The biochemistry lab marked or flagged each of these patients and put their reference range for PSA to be 0 to 0.19. So immediately an abnormal result in these patients becomes flagged if it gets to 0.2. So that helps GP colleagues who might see a result to identify an abnormal result. In parallel, we were developing a database for collection of patient-reported outcomes. And I had tasked a young colleague who was very familiar with databases to create a post-prostatectomy database where we could collect our operative data and use this database to collect patient-reported outcomes. Now, the functionality of REDCap, which is an open access database that costs nothing and it can be developed and maintained without IT specialists. But the functionality includes the ability for the system, when programmed, to send patients by email a link at defined time points to take them into the patient-reported outcome surveys, so that we do this at 3 months, 1 year, 2 years. But in addition, you can set it up to email the patient a reminder to go for the PSA test. So all of our patients now get email reminders to go at the defined time points, and that email reminds them that if it's 0.2 or higher, they should be coming back to us. So there remains some responsibility on the patient to go and book the test with the GP, but we've removed the onus from the GP in spotting the abnormal test, as I'll explain in a moment. And this REDCap has really enabled us to make it a sort of much less onerous task. And the third element of this was that we've used our electronic patient record system, which is TrackCare in our hospital, to note a patient using an episode code when they have a radical prostatectomy in our unit. And this means that Track can be set up to generate a report every week of every man who's due for a PSA test. And these are generated automatically and come to an administrative assistant, ORB, Rory Brennan, who will go through this list and identify the men who have not had a PSA. He will phone them and remind them to go and get it. And if there is an abnormal PSA test, he flags that up to me or a cancer nurse specialist so that we can order the investigations and communicate with the patient. So this is the type of report he gets in an Excel spreadsheet. And this is Rory, who's a young graduate with a statistical degree. So perfect for the job. So our PSA monitoring process now, we identify the cohorts on the left through track coding, path specimen, because the labs still communicate, although Rory fulfills that function now, and our surgical audit. Those who haven't had a PSA test will be telephoned. Those who have an abnormal PSA test will be told that they have a raised PSA and that we are taking action through further imaging. And by instituting this, we've seen the number of patients who are overdue for their PSA test drop to a level that's just recurring now, and it's the much safer program. So when they relapse, we will undertake MRI, bone scan, PSMA, PET CT, and discuss them at the MDT to consider whether they should have adjuvant radiotherapy or other treatment or monitoring. And taking into account the PROTECT data, I think we're probably treating fewer men. And the reason that we need to be, the other reason we need to be thoughtful about who gets treatment is that it's known that if PSA relapse occurs early and the PSA doubling time is short, then the risk of prostate cancer death is much higher through metastatic disease, and radiotherapy to the pelvis isn't likely to alter that survival. So to summarize, with respect to analysing the specimen, standardised reporting is essential, and I'm sure it is now standard. You can reduce your positive surgical margins through experience, planning, and sometimes intraoperative frozen section. If it is present, you should not offer immediate adjuvant radiotherapy, as this has not been shown to improve long-term outcome and will impact functional outcomes and therefore be detrimental to the quality of life of the patient. PSA surveillance needs to go on for a long time, and if you can digitize it as we've done, then this is very helpful. And early salvage radiotherapy should only be offered after careful assessment and discussion at an MDT. So thank you for your attention.
It was a wonderful talk. Before you go down, I want to ask you one question. I done a prostate, and we Indian have a small gland, and very often we thought it was organ confined, and some of the patient has come margin positive margin. Can I grade that positive margin? Because I found previously positive margin, positive surgical margin, negative operating margin, we used to do wait, delayed or a salvage radiotherapy if PSA start going up. But then we found after 2-3 years, those who had a capsular infiltration, they did have biochemical relapse. So we said if 1 slide positive, 2 slide positive, 3 slide positive, surgical margin positive, surgical capsular positive, if it is 1, we can ignore. 2, 3, we used to give early radiotherapy. But do you have any guidelines to grade the capsular infiltration or any extension of tumor outside capsule, 2 millimeter, 3 millimeter, 5 millimeter? Though capsular, your surgical margin is free, whether you should give early radiotherapy or a delayed radiotherapy.
It's a good question. Our policy, there is no guideline that I'm aware of, but I do think you're right. The higher volume disease, so the more slices, then the greater the chance that man is going to have a PSA relapse. The problem is he's also more likely to have metastatic disease, isn't he? So can we prove that irradiating him early is going to reduce that risk? And I think the PROTECT follow-up of 15 years demonstrates that any study that has cancer-specific mortality as the end point is going to be really difficult because it will be so long before you see that. And my concern is increasingly the impact that the radiation has on the quality of life of the patient. Because the partner paper by Jenny Donovan to Freddie's 15-year outcomes showed 12-year quality of life outcomes. And for me, that is as transformational in my practice as the PROTECT survival, because the overall health-related quality of life that Jenny's paper reports was identical whether the man had active monitoring, radiotherapy, or surgery. The side effects or the symptoms that affected quality of life were different. But 12% of the men who had radiotherapy developed fecal incontinence at 12 years versus 6% of those who did not. So we should never underestimate the impact of that radiotherapy when, whilst considering the benefit. And certainly, I think to do more treatment is always easier than to do less, but sometimes less is more.
Because we give a focal radiotherapy and we find morbidity of that is much less.
Well, I agree. I think
Targeted radiotherapy.
post-prostatectomy radiotherapy to a small area does have fewer side effects, provided it's at a good interval from the surgery.
Thank you.
Now we invite Professor Arnold Stengel, who is going to deliver EU lecture, The Best EAU in Bladder Cancer. Dr. Stengel.
Thank you very much. Thank you very much, dear moderators. Thank you very much, Professor Ghosh, for the invitation, and thank you for having such an excellent, really innovative meeting. Now, the goal here is to talk about the best of bladder cancer, and then in Europe, EAU. Of course, you cannot do that in 30 minutes, or I think it's now only 10 minutes. But I will try. There's also a personal touch all the time. But let's give it a try, and then if there's anything missing or any questions, then we can deal with that at the end. So these are my conflicts of interest. And I will start out with the guidelines. And the European Association of Urology guidelines, and this is an EAU lecture. These guidelines are actually have gone really worldwide acceptance. And I think one of the advantages is not only because we have excellent people, we have excellent support with regard to the literature and the classifying of the literature, but also we're doing a review of these guidelines every year. So this is a 7-digit number in euros or dollars that's costing us, and we're giving it out free. But that is our goal, is to make the possibility of looking up the best and classified treatment by worldwide for all the urologists and their patients. Anyhow, so that is, those were the 2023 revised renewals. Some of them, I just give you some examples, some simple ones. That is a classification. Look at both the 2004-2022 WHO classification, as well as the 1973 classification. Why are we going back to look at the older classifications? Because that's where all our, not all, but most of our data are based on. So we cannot really negate this old classification. And then you see the revisions. You can read that through in the Eurovap. Again, it's free, and there are new recommendations, and that is, again, in 2024, when we meet in Paris, you'll have the revision of the 2023 update. Again, now let's look at what does bladder cancer in Europe look like. We have approximately 180,000 new cases of bladder cancer in Europe. But that's not what I wanted to focus you on. The focus is, if you look at the, on your right lower side, if you look at the number of TURBs done, then only 1/3 is done for newly diagnosed bladder cancer. 2/3 is a recurrence. And that is something which we have to deal with, but what we have to focus on. It's really 2/3 is just probably at one or the other cases, we have not done a perfect job in removing enough of the bladder tumor when we first saw that. Now, on the other hand, you know, we are trying to get the follow-up downsized. As Ellen McNeil just showed you about PSA and prostate cancer, we have to really see how we can focus on our resources. And resources are a problem, not only in Europe, but in India and all over the world. We have to focus on the important things. And if we do a follow-up that is too frequent, for example, too invasive, then we cannot use these resources which we have in urology, which are limited, for other things. And one of the things is, what about to do the low-grade bladder tumor? And very nice, nicely shown in the UK from the president of the Bowles, Joe Gresswell's group, sorry about that, that we might think about reducing the follow-up. On the other hand, and here this is a very nice study from a registry in Sweden. I mean, the Scandinavians have just terrific registries. With a good registry, you can get really good and important data out of it. And one of those data is that even in the TAG1, you have late recurrences. Maybe the mortality in the TAG1 is a problem with a pathologist. But look at it, the intermediate risk, TAG2 and on. And up to a quarter of these patients will die within 15, 20, 25 years. So what does that tell us? That tells us some of these cases would have done better if we had followed them longer. And that is the question, when should we stop following patients with a non-muscle invasive intermediate risk patients? Is it going to be at 5 years, as the guidelines even say, or should we do it longer? And if we do it longer, how should we do it? How can we reduce our resources despite the fact that we don't want to lose patients? And that one of them is the urinary markers. The urinary markers in the surveillance setting. You know, you see it's a big and it's an evolving market. I've not even put all the currently evaluated urinary markers up here. But definitely that's a way to go. We have done a prospective randomized study. We showed that at this year's German Congress and as well as the EAU some of the preliminary data, where we tried in the low grade, good risk patients to use markers instead of cystoscopy. Now, I must correct myself, not instead, but by reducing reducing the cystoscopies, which is invasive. I know you know that the patients don't like it very much, especially male patients don't like it very much. And on the other hand, still have a possibility of picking up any recurrence just with the urinary marker and doing the 3 months standard of care and cystoscopy, which is in the guidelines, and then just do all the additional follow-up in the study group, and then for the next 3 years. These are the markers which we used in green, those that we have included for for studying, for evaluation. You can see there are several ones you know, and the question is, are these experimental markers making it? I cannot show you these data yet, but we are in the process of working it out. And what we can say is that a marker-guided surveillance in low risk and low intermediate risk non-muscle invasive bladder cancer is safe. There is an algorithm, of course, necessary, and the experimental markers, which ones will come in, we'll have to see. But it looks like that's the way we are going in a low risk, low intermediate risk for really reducing the number of cystoscopies. And we're not the only ones, we're not alone here, and that is where we are currently are with the marker-enforced follow-up. With a marker enforced, that means you use a marker and the standard cystoscopy intervals, with the idea that if you would know already beforehand or at the time of cystoscopy if a marker is positive, then sometimes your cystoscopy result gets more precise in some. I don't want to make any false statements here. And then you can really go to what we have shown, reducing the number of cystoscopies in these patients. Again, that's where we're now swimming more or less, but that's where we have to also go to spare our resources. Well, what can markers tell us also? Very nicely, yesterday we discussed the BCG, we discussed the follow-up, the maintenance therapy, but if we have a problem with BCG, and not only that, also with the side effects of BCG, especially in the maintenance, and up to 3 years, you've seen the data yesterday, the majority of patients will not make it up to 3 years, either because their compliance is not there, or they have enormous side effects, or there is not enough BCG. And so if we had a marker like it has been shown here at this year's EAU that could avoid maintenance or stop maintenance or motivate the patient and you to have a maintenance therapy, then this would be ideal. EpiCheck marker has made that study, and it looked actually that we may see a urinary marker for the intention or the reason why we should do a maintenance therapy. Let's go back. This is historical. Let's go back to what can we do with a TOR? How can we have a perfect TOR? And a perfect TOR is one where you can get the utmost out of the tumor at the first resection. PDD may be a surrogate for a good TORB. And that is, of course, always in question. Must it be PDD? Can it be NBI? Can it be SPICE? Can it be any of the filtered light? It seems at least And maybe PDD is just a surrogate for a good TURB. But if we do a good TURB and, for example, using a tracer with photodynamic diagnosis, then these patients seem to work better. And that is, again, the quality of the TURB, and we've shown that in older papers. Then these patients fare better even beyond those 9, 12 months which we have shown in the prospective randomized studies. In the prospective randomized studies, after 4 or 5 years, you can still see an effect. Where that comes from, we don't know. Is it an immunological effect? Is it the effect of a hidden, sleeping, aggressive tumor cell that just pops up later on? We don't know. And it is also the experience of the urologist, as you may know, and has also been shown this year. And that is also, if you do a better TURB, if whatever your tools are to do a better TURB, these patients will also need less of an adjuvant therapy, coming back to, for example, BCG. I took this from a discussion on a paper on PDD. Let's switch. BCG non-responders, aggressive disease, how can we prevent cystectomy? Checkpoint inhibitors have tried to do that, and we've talked about that. There's the Keynote 057 study that used pembrolizumab, a checkpoint inhibitor, in patients with BCG being unresponsive to BCG. There are two groups. One was the carcinoma in situ. The other one was the high-risk patients without carcinoma in situ, cohort B. That has been shown this year, the data, and the median follow-up is 45 months. And for me, that is a little bit disappointing. We're giving IV treatment, which does have some side effects, some remarkable side effects, different from chemotherapy. It's more in the endocrine area. And we are seeing overall in less half of the patients at 12 months response. You can get a better response if you look at the combined positivity score, if you stain these patients for PD-L1. But those that respond have a long-term result. We see that in the metastatic disease as well with the checkpoint inhibitors. But again, this is really something, it's not green tea you're giving these patients. You're giving these patients a toxic drug, toxic treatment for a disease that must not necessarily be deadly. It's a non-muscle invasive disease. So we have to really put that into the right perspective. Anyhow, something which we'll see later on, there may be combinations with a checkpoint inhibitor, with a instillation therapy, so combined IV and topical therapy. Anyhow, not really not a runner, so to say, more or less. These are the other ones. You have seen some of them already yesterday, nadofaragene firadenovec, pembrolizumab, BCG with IL-15, and a new drug, an antiviral drug with checkpoint inhibitors. The difference, as you can see here, is some of them are intravesical. Nadofaragene firadenovec, for example, is given only every 3 months, so that could be something. Yeah? But others have a combination or are giving IV. So that is where we are. There are additional ones coming up for the high risk and very high risk BCG naive non-muscle invasive bladder cancer. And these are studies that do sometimes either combine it with BCG or, for example, have a BCG induction and a continuous follow-up with a checkpoint inhibitor. So interesting combinations, and there is some movement in the non-muscle invasive high-risk and very high-risk disease, which we're going to see. The Potomac study, by the way, was some of the data have been shown this year already, and they look favorable, but we will see, especially with the BCG induction, and whether you could replace the maintenance with a checkpoint inhibitor. So really play around here a little bit. Yeah? Switch again. Let's switch to the more aggressive muscle-invasive disease, lymphadenectomy. Yeah? And that is, we have shown the European extended versus standard lymph node dissection in bladder cancer. A couple of years ago, we were part of that multi-center study in Germany, prospectively randomized. It's been shown that you look at the limited classical lymphadenectomy versus the extended one, and it's been shown, the initial data, that recurrence-free survival, no difference, cancer-specific survival, no difference, overall survival, no difference. And that goes in line with this year's SWOG study from the US, phase 3 study, same thing, looking at standard versus extended lymphadenectomy, no difference. Except there is more of a problem with the side effects. Now this year's, there have been the long-term follow-up shown, median follow-up almost 5 years, 58 months, and time to progression, no difference, overall survival, no difference. The only thing that was different is now the cancer-specific survival, which significantly improved with the extended lymphadenectomy. Question is, if the cancer-specific survival is better, but the overall survival is not better, where's the benefit? So that is in contrast a little bit to the whole pelvis radiation study, which has also been shown this year. And this is actually looking at the radiation field, just the bladder, or the bladder plus the lymph drainage, so the entire pelvis, whole pelvis versus bladder only in trimodal therapy. And the whole pelvis actually did do better. We'll have to think about it. What is the difference between doing an extensive lymphadenectomy versus an extensive radiation therapy? Why is one better than the other? Of course, the extension of the radiation cannot go up that far because of the side effects to the bowel. I'm just coming back. I mean, Purkar Dasgupta really has nicely shown the development of robotics. One thing very nicely has been studied by Jim Cato and other centers in the UK. What is the difference not only doing a robotic cystectomy, but also doing the urinary diversion intracorporeally versus doing an open urinary diversion? And the primary outcome was the days out of the hospital within 90 days. I'm showing this partially because, as you can see here, I congratulate you if you can do 98% of all radical prostatectomies robotically. Are we going to see the same in cystectomy? In that study, a lot of these patients could not be put into that study because they were not thought to be feasible to be done robotically, a cystectomy robotically. That's one of the things. The other thing is, if you look at that study, and that is even better than the data which we get from the US, 70% or 70 to 75% of these patients were organ confined, T2 or less. The mean age was 69 in the male, 67 in the female. So there were some younger patients in there, but only 10 to 12% of these patients got a urinary and orthotopic neobladder. And that is, I think, concerning. I don't know if push it if you're seeing the same effect in the States. And I think it's in Europe we are seeing that. It's something has to do with money, but some, I would say even more, has to do with education, training. And I love, Borka, your lab looking at education, virtual education. That is really necessary in order to keep an orthotopic neobladder on our armamentarium in patients with a cystectomy. And that is, you know, robotic surgery that needs especially training for the reconstructive part. The ablative part is pretty much, I think, it's getting around pretty well. But if we don't get the ablative part, the reconstructive part, then we'll just have a little bit of an advantage in the quality of life in the patient for the first 3 months at most, but not more. And if that takes a lot of more of your operating time, then this is not going to fly in the majority of institutions, at least in Europe. Let's switch. Next one, chemotherapy. Just an explanation. In some countries in Europe, and Germany is one, the chemotherapy, systemic therapy, immunotherapy is done in a large part in the urology department. In some countries like Italy, you have uro-oncologists, which are part of urology, but in some parts it is a dedicated urologist that does the systemic therapy, and that's why we are taking part in a lot of studies. And that's why we also think that, at least from an educational standpoint, we need to be educated in systemic therapy in urology. Otherwise, in a multidisciplinary tumor board, we will be just the handyman for oncologists, just to say it very roughly. One of the studies shown was carboplatin versus cisplatin. You know, carboplatin, especially in the elderly population, may be the better way of having less side effects, may be the only way of giving platinum-based chemotherapy. And still, cisplatin is superior, and there are some studies that try to show that carboplatin has the same effect, but it seems that it is not better. This is absolutely something, an eye-opener. This year, and it's been shown at EMUC, the latest, a couple of weeks ago again, enfortumab vedotin, a new class of drugs that use antibody-derived conjugates that are used in metastatic and advanced bladder cancer. And this study, for the first time, after 40 years. 1988 was when MVAC was introduced by Cora Sternberg and Howard Scher. Since then, we have not had, except for gemcitabine, not very much happening. This drug has now shown that the survival of these patients with metastatic or advanced disease is doubling almost, from 16 months to 31 months overall. And if you take some staining with PDL, then together with pembrolizumab, these patients even fare better. 1 year is considerable. 2 years even in some patients with a good staining is even more. 2 years is when the son is finishing his studies. That is when the grandchildren are coming. 2 years is considerable, average, median. And that is something which we'll hear. And we will also hear, that will be interesting also for you, this drug is also evaluated in the non-muscle invasive disease. So that is something where we will see future coming. Now, you've seen there's a lot of drugs coming. What shall we use for the urothelial cancer? What we are doing now is we're doing organoids like other people are. We're trying to get that bad bench bad model. You take the tumor from the patients, you grow organoids out of that, and then you test the respective drug, and then you can give that drug to the patient. And that is organoids. It's not easy, but we can use now organoids not only for drug testing, but also, for example, sensor testing to make a more precise testing during, for example, robotic surgery, laparoscopy. And that is, the results are that the culture is possible. Others have shown that. They are sensitive to different drugs, and they may be the guidance for adjuvant chemotherapy by their characteristics. So, in conclusion, urinary biomarkers influential in the follow-up and in the extended treatment of non-muscle invasive bladder cancer. We have to, it's been a long time, but they are coming up now. They're coming up now in combinations, maybe with a score, and they will be able to help us in getting our resources better focused. An extended follow-up for the high-risk and very high-risk non-muscle invasive bladder cancer, yes, it should be done. Whether that has to be cystoscopy or better a combination of markers, we'll see in the future. Good quality TURB, yes, definitely that is helping the patient not only for the early recurrence, but also for late recurrences, maybe also for progression in some patients. There are increasing studies, not only for checkpoint inhibitors, as you have seen, other drugs, viral drugs that use adenoviruses, or drugs like the antibody-derived conjugates are coming up for non-muscle invasive bladder cancer. The extended lymphadenectomy in localized muscle invasive bladder cancer, not proven. It's devastating for some of those that have promoted it. It's not flying as it looks like. Enfortumab vedotin and pembrolizumab is a new star for the metastatic urothelial cancer, maybe not only for the metastatic urothelial cancer. And organoids, bad, bench, bad, as a guidance for adjuvant chemotherapy in urothelial cancer. We're working on that. It looks promising. A lot is happening in urothelial cancer, not only urothelial cancer. It will be shown next year in Paris, and I hope you'll see you at next year's EAU in Paris, France in April. Thank you very much for listening.
Thank you, Ernest. We'd like to thank all the speakers. Because of the time shortage, we will not have questions now. But later on, if anybody wants, they can discuss with you. Thank you very much. Thank you all.
Can I just ask the Euro-Onco Council to come over, and we will take this opportunity to hand over a token of appreciation to all the faculties from abroad. I hope you had a nice experience in Kolkata, which is a heritage city, popularly called a city of joy. It's been called a lot of names. It has been called a decaying city, it's been a dying city, it's been called a city of joy, it's been called Mother Teresa's city, it's been called the city of Nobel laureates, it's been called the most underrated city of India. So, you know, after all, it's a vibrant city. I can only say that you will get addicted to Calcutta once you come over. So first of all, as a mark, as a token gesture, so that you remember us, we will give you a little memento so that it as a memory aid to Calcutta. Can I ask Professor Arnold Stenzel to come up on the stage for a minute? Arnold, this is from the Council of the Euro-Onco for USI. This is a little book on Calcutta to remind you about the memories of Calcutta. You told me last night that you haven't been on a trip on Calcutta. You were too busy with the science of uro-oncology, but you can share some thoughts. Khurshid is laughing, but he's got the most hilarious experiences of Calcutta. If you want any aids, you can contact him.
Thank you, sir.
Thank you very much. Thank you.
Thank you. That's what I remember of Calcutta. That's better than any sightseeing.
Oh, thank you. Thank you. Thank you very much. May I now call Alan McNeil, the chair of the BJUI, for a token gesture on a little book on Calcutta. Thank you very much. This is our counsel for you. And now the great Khurshid. Khurshid, this is not a damaged record or an old book from Free School Street. This is a real little gift from the Euro-Onco section council, and I hope you enjoy it. But it's a new book. It's not an old book or a broken record.
No doubt. They'll be shared afterwards.
Where is it? Simon Hughes, the real popular man with our council. Simon, this is a little gift from Calcutta. Thank you very much. And maybe a word from you.
Yeah, no, this is my fifth trip to Calcutta, so you're right, it is addictive, isn't it? I'm sorry, Adam, but I've been to Calcutta more times than I've been to Scotland. I live in London, so thank you.
Thank you very much. Raj Nair. Calcutta, for you. Thank you very much. Thank you. Now, the backbone of this entire program, Prakhar Dasgupta, coming home.
Make sure he gets a book. Make sure you get a book.
Prakhar, thank you from behalf of the entire council. Thank you for everything that you've done for us. Coordination, active support, and everything. Homecoming for you, I know, but we are privileged to have you.
Khurshid, I had to send 75 records from Free School Street all the way to your home outside New York. So let's not forget that, but this time it's just a small thin book, so we can take it with us. Thank you so much.
Thank you. We'll just use this occasion that we have got the first prize of the video, Dr. Girdhar Bora. Where is he? He was sailing on the Ganges at 1:30 at night, I'm told. Now, this prize has been shared with Kinju, who is probably not here, but we'll ask Raghunath. Now, this is for you. Now, don't abuse it. You can use it. Yeah. Raghunath, if you can do the honors of handing this over to Kinju. Thank you very much. Thank you. First prize for the video amongst the residents, Deval Parikh. Are you here? Congratulations, Deval. Thank you. Come. First prize for the Gora, for the poster, Dr. Girdhar Bora again. Girdhar, when is the party? Congratulations. Congratulations. Yeah. Come. First prize for poster for the residents, Dr. Shomen Shah. Anybody who knows him? Anybody from the institute? Okay, we'll take care of this. Thank you very much.
So we have the result of Raisin quiz, which was yesterday. So we have the first prize for Raisin quiz goes to again Deval Parekh, MPUH Nadiyad. The second prize goes to Mehul Agarwal, AIMS Rishikesh. And the third prize goes to Elam Kaman, GMC Assam. Congratulations to all of you.
We'll continue straight. So we'll have a break for 10 minutes for tea break, and then we'll start with the consensus statement sessions. So if anybody who has not collected their voting pads, please do collect the voting pads, because again, without that, the meeting cannot happen. So in 10 minutes we assemble here. Again, thank you very much.
which is high risk and locally advanced prostate cancer. May I have the pleasure of inviting Dr. Manoj on the dais to be the coordinator. Dr. Manoj. And for the chairpersons, may I request Dr. Percy Chibber, Dr. Ajay Kumar and Dr. Shashank Barua to be on the dais, please. Dr. Manoj, is he there in the audience? No. So let me proceed with the first topic, and the first speaker is none other than Dr. Simon Hughes. The topic for the presentation is the introduction to the HR and the locally advanced prostate cancer consensus statement.
Perfect. So this is really just an introduction to the next voting session. My talk is going to be like me, very short. Yesterday we had voting on small renal masses and on non-muscle invasive bladder cancer. So these are mainly urologically managed conditions. A bit more controversy today. We've got locally advanced prostate cancers where the surgeons and the radoncs meet. So thank you for your enthusiasm yesterday. If everyone can activate your voting pads again, everyone take a seat, activate your voting pads, and then we'll catch up a bit of time by moving on to the first topic. And what we'll try and do is analyse everything so we can present the results of all the consensus statements at the end of the meeting today. So thank you. Oh, I'll smile.
Thank you, Simon. So the first topic is the optimal diagnostic imaging, and may I invite Dr. Aparna? Yeah, thank you.
Good morning, everybody. Big thank you to the organizers for the privilege. For the next 10 odd minutes, I'll be speaking on optimal diagnostic imaging in prostate cancer. It's one of those rare talks by a radiologist where there is not going to be any image, because we're just going to talk about where we stand right now with regards all these modalities. So we'll be taking a look at prostate MRI, its present role and limitations. Multiparametric MRI do's and don'ts as a radiologist, and good for the urologist to know as well. Where we stand right now for multiparametric versus biparametric, are we ready to do away with contrast? PIRADS, the present version, and do we have a scope for the next version, and if yes, what are the points of improvement that we could think of? The present status of PSMA PET and biopsies. It's really fascinating the way the biopsies have evolved, and we now have a lot of choices, but do we use all the choices, and in which patients do we use? So let's begin with prostate MRI. So it's now the first line imaging for localized prostate cancer if there are abnormal DRE findings or raised PSA. Whether we're talking of screening scenarios or diagnostic, we really need the prostate MRI to localize the lesion. It has a sensitivity of 93%. That's as much as the male-female ratio here in the audience right now. Avoids 27% of patient biopsies for clinically insignificant cancer. So that's important. If we do not think that something is likely to be clinically significant, then we are avoiding biopsies and the complications therein. Avoids false negative biopsies by helping targeted biopsies, so about 43% improved cancer detection and reduces the number of cores required. And for follow-up patients on active surveillance, it can reduce the number of annual biopsies because it rarely misses high-grade lesions. So if you're not suspecting high-grade lesions, then in follow-up patients on active surveillance, then there is no point in doing those annual biopsies and subjecting patients to those complications. And radical prostatectomy follow-up to look for recurrence. This is one area where I would, I kind of visualize MRI and PSMA PET kind of having a fight as to which is better right now. Probably the PSMA PET could be a notch ahead, but then there is also the PSMA PET MRI, which is kind of an exciting new modality. So, let's see where we go from there. And it helps facilitate focal therapy, of course, by localizing the lesions. But is it all, hunky-dory? No, there are certain limitations of MRI. One is that not many, but some clinically significant cancers can be missed, and that can get crucial in screening scenarios. With a lot of patients undergoing random PSA evaluation as part of health checkups, there could be a lot of MRIs being done, and then if we are, in spite of that, if we are missing clinically significant cancers, even in those small 7% of cases, that can become an issue sometimes. And the lesions at the apex, the lesions at the central zone, they need a lot of learning curve, and despite that, it is possible that they may get missed. So those are right now the limitations of even a multiparametric MRI. So that's where we are right now with that. So what are the do's and don'ts here of multiparametric MRI? Whether we should use 1.5 or 3T, both are acceptable. We at our institute are very happy with our 1.5 images as well. Of course, 3T is preferred, just like it would probably be preferred for any scan anywhere in the body, just because it's a higher image quality. But nevertheless, 1.5 Tesla is completely acceptable. So there's no issue with that. Endorectal coils are really, there's a lot of discomfort to the patients, and then there are the workflow issues that come with it's time consuming, and there's also the cost. And whether all these efforts, it's worth it, is there any additional benefit for the patient in terms of images? No. If we are tweaking a good prostate MRI with set protocols, and we have good images coming up, then there really is no need for the endorectal coil. We do not use it, and there are hardly any centers who are using it. So we're not much in favor of that. The sequences, of course, the T2 diffusion are the bread and butter sequences. T2 axial is an absolute must, either in perpendicular to the actual plane of the prostate, or just a rank axial one, and then one additional orthogonal plane, either coronal or sagittal. Since we don't take at our institute 3D routinely, we take both the coronal and the sagittal. It helps a lot, especially for the seminal vesicle involvement in those plus minus cases. A 3D T2 sequence does have comparability with the 2D T2 for cancer as well as extraprostatic extension. It also has the theoretical advantage. If you're getting a whole set of 3D images, then the segmentation, if you're planning a fusion biopsy, would probably get simpler, but it is an additional sequence. It is time consuming, and at our institute, we're doing it as an experimental basis, not in all patients. Diffusion, of course, is crucial. We get diffusion at two B values, the 0 to 100 and the 800 to 1000, and a greater than 1400 B value, which can be extrapolated either by the first two sequences, or it can be acquired additionally as well. Doesn't make too much of a difference. So this is, of course, a crucial sequence. And the dynamic contrast enhance is part of the multiparametric protocol. A lot of discussion, and I'll come to it in the next slide, where whether it's even needed, given that biparametric MRI has shown, at least initially, to give excellent results. So, we're not in a stage where we've discounted the contrast entirely. So right now we do take T1 weighted gradient TECO image sequences, and a 3D is, of course, better than 2D. Antiperistaltic agents before the scan help a lot. Buscopan, the bowel movements can really interfere with especially with the diffusion. So we would like those to be reduced to the minimum and improve the anatomical visualization. We do give it. And the interval between a previous biopsy and MRI is preferable to be 6 weeks or more. Now again, time and again we have patients coming in who have had a recent biopsy and it has been proven to be cancer, and then it's just a question of, it's not a question of giving a PIRADS to that lesion. You probably know that it is a big lesion. It's about whether it there is an extra prostatic spread or not. In those cases, sometimes we have made exceptions, but it is entirely an MDT decision, tumor board decision, whether you want to make exceptions, because if we are looking at giving focal therapy, focal ablation, if you are looking at something very precise here, then you would probably want those 6 weeks to go and the hemorrhage to settle in before you go in for an MRI. Now the burning question, whether we can do away with contrast and just move on to biparametric. Biparametric would mean just the T2-weighted sequences and the diffusion and omits the contrast. Obviously, it reduces the acquisition time, the cost, the contrast, whatever, even, little side effects. We don't really see adverse reactions so often with MR contrast, but whatever it is, it avoids an injection. So, studies have shown comparable accuracy with MRI in detecting clinically significant prostate cancer. So, detection has had encouraging results, and it can be used for fusion biopsies as well, as shown in a few studies. But where a contrast really helps, where a contrast really helps is in those PIRADS 3 and 4. Now, PIRADS 3 and 4 are those headaches for all radiologists. It's where, most of the discussions take place between the treating clinicians, treating physicians, and the clinical radiologists, whether, you want to call it a PIRADS 3, a PIRADS 4, do you want to upgrade it, downgrade it? And, those are the questions where, even while interpreting MRIs is where, that is the point where you press that contrast button, and, that when that one lesion where you're not sure lights up and the others don't. And, that's where you really feel that the dynamic contrast enhanced MRI has worked, the contrast has worked. So for PIRADS 3 and 4, whether to upgrade or downgrade them, that is where we cannot yet do away with contrast and a multiparametric MRI. For active surveillance as well, because obviously any smallest new lesion is first going to show vascularity, and we want to pick it up. Diffusion or T2 is still not, the gold standard for that. And for extracapsular extension as well as recurrences, multiparametric MRI is better for the simple reason that the enhancement that is shown offsets any limitations of a diffusion-weighted MRI. Moving on to PIRADS, do we have a scope for the next version? Are there any burning questions which are not being solved by the present PIRADS statement? So, present PIRADS version is the version 2.1. Well, we are okay with the peripheral zones most of the time. It is the transitional zones that sometimes is an issue. Now, if there are typical BPH nodules, PIRADS version 2.1 just says to call it a PIRADS 1 or just a normal PIRADS. The moment we see atypical BPH nodule, something that doesn't have a proper capsule, something that is not properly rounded, something that is not T2 hyper intense, has some heterogeneity, the moment we start seeing these kind of atypical nodules is when version 2.1 says that if these nodules are showing restricted diffusion, then they go on to the PIRADS 3 category. Now, once you call them PIRADS 3, it's again a gray zone. There is again a discussion whether they should be biopsied or not. And results have shown that only 7.5% of these harbor clinically significant prostate cancer. Now, 7.5% is not really a small number. I think if you, especially in a screening program, if you're looking at that, a 7.5% of those nodules becoming significant cannot be ignored. So that is somewhere, where the PIRADS version can get better. Now, wedge-shaped lesions. The moment you see wedge-shaped lesions on T2, the first reaction is to call it prostatitis. Maybe just look at the PSA levels and wait for the biopsy. But now it has been shown that there is a significant amount of these lesions that are actually prostate cancers as well. So whether we can do away with just calling wedge-shaped lesions as prostatitis, and how much importance do we give the restricted diffusion for these images is again a point of contention. The assessment of fibromuscular stroma or the central zone is not given any specific additional weightage by version 2.1. It is just considered as a part of the rest of the gland and probably needs a bit more attention because the central zone especially is an Achilles heel for radiologists. Like I said, it needs a learning curve to interpret certain findings in that area. So maybe there could be a standardized protocol for these. A PIRADS M category, just like a LIRADS M category, would be a great help probably because the neuroendocrine tumors and mucinous tumors don't look like the typical adeno-CAs. So if you are still suspecting a cancer but it does not fit into those rigid T2 diffusion and contrast enhanced MRI criteria, then you probably want a PIRADS M category to say that, it does look like a malignancy, but there's a good possibility that it is not adeno-CA, but actually could be a neuroendocrine variant or a mucinous variant. So, that could probably help a lot. The aggressiveness of the lesion, we are still in a PIRADS 4 and 5 category where the lesion size of 1.5 is taken to be the cutoff for these. But is size the only criteria? No. It's been shown that, the darker the ADC and the lower the ADC values, the lesion is probably going to be more aggressive. Now, if we're making a standard PIRADS, going ahead, it is supposed to show you more clinically significant prostate cancers, then probably you want to know the aggressiveness of the lesion as well. So that's one area where a new PIRADS version can help. The extraprostatic extension right now is only about the capsule, whether the capsule is breached or not, but that should not be the only criteria. Very often we see that the contours are different, the margins are fuzzy. There is a rectoprostatic angle that is aberted and it is distorted a bit, and these can be indirect indications of an extraprostatic extension, but they find no role right now in the official PIRADS V2.1, so maybe those could be included. And finally, we have this nice BIRADS atlases for mammo and ultrasound and MRI, and they have very typical terms that are used, and it's really used uniformly across platforms, but that's not true for PIRADS yet. If I am calling something focal, someone else may call it something localized, someone else may call it something a background, and there can be a bit of a confusion in terms of terminology. So that's where PIRADS Atlas can really help. Moving on to PSMA PET, the current status, the one area where the PSMA PET really scores over most other conventional modalities is the detection of recurrent disease. So that's the role where it is best established, especially if the PSA values are low and if it is a low volume disease. There is a positive association between ADT use and tumor detection. The ADT use, and if with ADT the tumor aggressiveness is coming down and the tumor is responding in fact, then the PSMA lighting up also comes down in the same way. So that's amazing. That's where it helps. But it does not detect the neuroendocrine variant. It does not light up on that. So that can be an issue, especially if you're starting with the PSMA PET as the starting point. Then you're again not sure whether there is still cancer and it just did not light up because there's this variant. A disease that is equivocal on the MRI, then a PET MRI, like I said, could be a promising modality. It's coming up right now. It's not being used across centers. It's just there in a few centers, but it is a promising modality. For local staging, however, it's an evolving role. We are still dependent on MRI purely because of the amazing soft tissue contrast that the MRI gives. But whether PSMA PET catches up, we'll have to see. Finally, we move on to biopsies, and there's a lot of excitement about the fusion biopsies that is happening. So the fusion biopsies can be cognitive, where you see the images on the MRI and make a mental note, and then you do a truss or transperineal and then just see where the lesion could be based on what your MRI findings are. Or it could be an actual fusion done by the software where the MRI images are fused on the ultrasound images. There is the issue of segmentation, and we're still, at a stage where that's being worked out. The planes in which the MRI has been done and the planes in which the ultrasound is being done have to match perfectly. So that is one area that's a challenge, but nevertheless, it's fascinating. And then there is MRI fusion, where, actually it's in bore biopsy. The patient goes in, we know in the MRI bore, we know where the lesion is, comes out, and step by step we proceed with the, the needle till it reaches the point where we want the biopsy. So these are the three kinds of fusion biopsies that are available. Targeted biopsies meaning that we see an image, we see an MRI and we see a lesion, and to reduce the number of cores, we only target that biopsy, so that, we're not shooting too much, and then the resultant complications are less. So they have shown to have a higher detection rate than systemic biopsies, but the best detection rate is by combining the two methods. Purely because, some clinically significant prostate cancers, like I said, may not be apparent on the MRI. There is the imitation of overlaying of the two sets, like I mentioned, and, that is one area where, technology needs to get a bit more robust. So to recap, we saw about prostate MRI and its roles and limitations. The multiparametric MRI, which is still the gold standard, and we need to follow that. Yet we're not yet completely ready to give away the advantages of contrast. We still need to give contrast in those couple of cases, PIRADS 3, 4, extracapsular extension and all. But nevertheless, in selected studies and in selected scenarios, biparametric works excellently. And it's probably something that's going to be looked at very deeply in the PIRADS, the next version. The scope for the next version, yes, we saw, and we saw the present status. The biopsies which to choose, again, depends on the PSA levels and the patient findings for an MRI. Thank you very much.
So as we are behind schedule, we like to take comments on any questions at the end of the session. Thank you, ma'am, for the deep insight into multiparametric MRI and CA prostate. Now I'd like to invite Dr. Rajesh Kumar, who is going to talk about a urologist perspective in imaging in CA prostate.
Respected teachers and dear colleagues, I'm Dr. Rajesh Kumar Reddy Adapala from Asian Institute of Nephrology and Urology. I'm going to discuss the optimal imaging modalities for CA prostate as a urologist perspective. No conflicts of interest. There are few challenges posed by the high risk and locally advanced carcinoma prostate while diagnosing the case. And second thing is assessment of the local staging, lymph node mets, and even detecting the distant mets is an integral part of imaging modalities for high risk and locally advanced carcinoma prostate. Multiparametric MRI is the gold standard for establishing the diagnosis of the carcinoma prostate. And maybe few patients have claustrophobia in the MRI gantry, but each and every urologist has a phobia of reading the MRI. So I think urologists are very much familiar and proficient about reading the CT scan, but not the MRI. I think this is the high time to improve the skills. The MRI prostate T2 weighted imaging is a workhorse of the multiparametric MRI, where we can see the zonal anatomy very clearly. Here we can see the BPH nodules with a smooth and regular contour, and here we can see the peripheral zone, and there is an irregular lesion, carcinoma prostate lesion in the peripheral zone in the midline and paramedian location. Whereas in a transitional zone, the classical erased charcoal appearance, otherwise called as it is distorted organized chaos, where we can see the hypo-intense area with the irregularity and with the absence of zonal anatomy in case of transitional zone lesions. There are other components of multiparametric MRI along with T2 weighted imaging, the diffusion weighted imaging, which is based on the Brownian movement of the water molecules in the peripheral zone. Here we can see the high signal intensity lesion, which is suggestive of carcinoma prostate, whereas in ADC, that is the volumetric and the molecular movement restriction. Here we can see the low signal intensity, whereas in dynamic contrast enhanced imaging, we can see the early enhancement and washout of the contrast. Based on the multiparametric MRI, radiologists give PIRAD scoring. If the PIRAD score is 3, 4 or 5, which requires and warrants transrectal or transperineal biopsy. Here we can see the lesion in the posterior peripheral zone, and the same thing is being demonstrated in the transrectal ultrasound, and that will be targeted. Being cognizant of the MRI findings, we can target the lesion easily. If somebody has facility of MRI fusion biopsy, that gives a better accuracy in targeting the lesion. Here we can see that targeting the lesion. So this is already discussed by Dr. Aparna. I'm skipping it. This is a landmark precision trial where they compared systematic biopsy versus the MRI fusion targeted biopsies, and they found clinically significant cancer that is 3+4 or more is well detected in targeted biopsies rather than clinically insignificant lesions, and the number of targeted the biopsy course were less, and that led to lesser complications. Coming to the local staging, single most important the parameter of detecting the predicting the positive surgical margins or the biochemical recurrence is extraprostatic extension. If there is a frank extraprostatic extension, we can easily detect on MRI. However, if there is not always the case, most of the times we may not find the frank extraprostatic extension. We need to have few other predictors to determine the extraprostatic extension. One of them is capsular contact length. This is the single most important parameter one neurologist should see in MRI. Here in multiparametric MRI, we can see the capsular contact length is more than 1 centimeter, which is the predictor of the extraprostatic extension. And there are other features of extraprostatic extension like capsular bulging or capsular irregularity. Based on these parameters, there is a grading system, extraprostatic extension grading system. As the grade goes up, the incidence of extraprostatic extension also increases. Coming to the neurovascular bundle invasion, here we know that neurovascular bundle is located at the 5 o'clock and 7 o'clock position. Here we can see left side there is a neurovascular bundle invasion. The right side the nerve sparing is being done, left side extraprostatic extrafacial dissection is being done. So we need to see the neurovascular bundle invasion properly in the MRI imaging. Seminal vesicle invasion, T3B, there are 3 varieties of seminal vesicle invasion, type 2, type 1 via ejaculatory ducts, type 2 via extracapsular disease, and type 3 is a skip met. Although it is very rare, it is possible. T4 disease like bladder neck invasion, bladder base involvement, rectal involvement, and extensive extraprostatic extension reaching the pelvic wall. The lymph node involvement, there are few telltale signs of lymph node involvement on MRI. The size exceeding 8 millimeter in short axis diameter. It is not the long axis, it is a short axis diameter. And loss of fatty hilum and low T2 weighted imaging signal and irregular border. So in spite of having this evaluation criteria, still MRI has got very suboptimal and very less sensitivity for detecting the positive the metastatic lymph node. So that maybe this is the reason we do extended pelvic lymph node dissection as a gold standard in detecting the positive lymph nodes. Knowing well the fact that extended pelvic lymph node dissection is mainly of prognostic rather than therapeutic. We still do the extended pelvic lymph node dissection because we don't have proper imaging to detect the pelvic lymph nodes. There is high risk of false negatives and as well as false positives. So metastatic workup is an integral part. It the unfavorable intermediate risk, high risk and very high risk the cases warrant a metastatic workup. So there is a debate between bone scan versus PSMA PET scan. I would like to share our experience. So the one patient was a high risk carcinoma prostate was referred to us for radical prostatectomy. The bone scan was done outside, which is showing no evidence of osteoblastic lesions. However, as an institutional protocol, we got the PSMA PET CT scan, which showed the PSMA avid lesion in the pelvic bone, and we started wondering what could be the cause for all these things. And there is a study called PRO-PSMA study, which compared the standard imaging, that is the CT, abdomen, thorax, and pelvis, and bone scan versus PSMA PET CT scan, and results are amazing. The accuracy of standard imaging, that is CT scan and bone scan, is 65%, whereas PSMA PET CT scan it is 92%. And another thing, ironically, even the bony mets, the sensitivity and specificity of detecting the bony mets by PSMA PET CT scan is 98% and 97%, whereas with the MDP bone scan it is just 83%, and grossly lacking the specificity is 68%. The gross lack of specificity probably because the bone scan detects the degenerative changes in the bones and arthritis, all these things. That's why it is the lack of specificity. So where PSMA PET scan score over. This is the PSMA PET MRI. It's a one-stop shop test. If you have the facility, better to get it done to detect the tumor, and local staging as well as nodal and distant mets. And the 3D modeling is coming up. The high quality MRI images are processed by software and segmentation done. Here we can see the yellow line is a prostatic the capsule. Here is the lesion. This is the urethra. These two are the neurovascular bundle. And we can see the 3D imaging nicely, which can even be superimposed during surgery. Here this is the lesion, and at that part we can stay away from the lesion and to prevent positive surgical margin and thereby biochemical recurrence. So what are the take-home messages? The MRI prostate definitely is a gold standard in detecting the prostate cancer as well as local staging, and predictors of extraprostatic extension and MRI are capsular contact length, which is more than 1 centimeter, capsular bulge and irregularity. MRI of the lymph node staging is bit suboptimal. And PSMA PET CT scan has got the better accuracy in detecting nodal as well as skeletal metastatic diseases. And PSMA PET MRI, one-stop shop for local recurrence and metastatic workup. 3D modeling and augmented reality has got the emerging role in diagnosing the prostate cancer, especially high risk and the locally advanced. Thanks for the opportunity.
Thank you, Dr. Rajesh. It's a really nice presentation. And can I call upon Dr. Prokar Das Gupta and Dr. Gopal Sharma, sir, to take over and proceed with voting?
Good morning. Thank you very much. So shall we start? We can start with the voting. The first question, first statement, the optimal staging investigation strategy for patients with high risk or locally advanced prostate cancer in an MRI pelvis, a nuclear medicine bone scan, and a CT chest / abdomen / pelvis is needed. So we'll start the voting. Statement 2, the optimal staging investigation strategy for patients with high risk or locally advanced prostate cancer is an MRI pelvis and a PSMA PET scan. Statement 3, the optimal staging investigation strategy for patients with high risk or locally advanced prostate cancer is an MRI pelvis and a whole body diffusion weighted MRI scan. Statement 4, in patients with Gleason grade group 5 disease or neuroendocrine differentiation, dual PET tracer imaging with FDG and PSMA PET should be considered. Statement 5, what is the optimal PET tracer for staging high risk or locally advanced prostate cancer? A, fluoride 18 PSMA PET scan, B, gallium PSMA, C, choline, D, other, F, not my specialist. Last statement, biparametric MRI is an acceptable alternative to MP-MRI for local staging of high risk or locally advanced prostate cancers. Thank you.
So, for the next presentation, I'd like to call upon Dr. Manoharan sir, who's going to talk about transperineal versus transrectal biopsy of prostate.
Hello. Yeah. Thanks for the opportunity. Global Urology Congress, Kolkata. I'm just going to cover regarding the transrectal and TP biopsy of the consensus. Actually, the first transperineal biopsy was done in 1922, as there was no imaging and biopsies were done transperineally. And over a period of time, because of its complications, pain, hematoma, and other things, the world started moving towards transrectal biopsy in 1937. And with the advent of a lot of ultrasounds, linear array biopsies, transrectal ultrasounds, and then in 1989, the sextant biopsy was standardized by Hodge et al. And with the advent of biparametric, multiparametric, and fusion biopsies, and I think it started moving towards the fusion biopsies, and with the era of antibiotic resistance, and then the template biopsy come into picture with the transperineal biopsies, with Basil has coined the term of template biopsies. And with the availability of fusion technologies like cognitive in-bone and predictive target biopsies becoming more and more important. So this is the overall picture of the scenario. And just understanding that transguided biopsies in both the procedures, the probe is inside the rectum, whereas the transperineal is going to the perineal area, and the biopsy is done to the transrectal route in transrectal biopsies. And we have devices of the new devices for the transperineal biopsies. We have stepper devices, and also lately revolutionized freehand technique with a precision point biopsy techniques are available. And for the transrectal biopsies, we have end probe and a side probe. But coming to the biopsy areas, it's different there. In this area, depending upon the size of the prostate, we go for a sextant biopsy transrectally, or if the prostate size is more, we go for a laterally directed biopsies, and sometimes transrectal anterior biopsy if the biopsies, the lesion is in the anterior. Whereas in transperineal, the difference is that it's a sector biopsies. You can see that it is going through the anteriorly, so it's the anterior, mid, and posterior sector biopsies. And from anterior to posterior, then it is called the basal course. So depending upon the size of the prostate, you can go for a number of course can extend it depending upon the size of the prostate. So coming to the cancer detection and why we need to address this issue as such. So you can see that in the earlier period with 3 randomized controlled trials, there's not much of difference. In fact, transrectal biopsies, the cancer detection rate is better. As the world started moving towards the more imaging, and we started understanding the prior scoring, the transperineal biopsy cancer detection rate started increasing. And this meta-analysis comparing the transrectal versus transperineal, 4 RCTs and 7 observational studies, does not show any significant difference between transperineal and transrectal approaches on diagnostic accuracy. Why? Why there's a sudden change? We need to go for suddenly there's a lot of issues regarding this. Look at this. In England, I think probably in 2022, they've stopped doing probably the transrectal biopsies because the worldwide, the infection rate is alarmingly high to the tune of 10%, and the biopsy sepsis can be life-threatening. It's a mortality rate of 0.13%. So the transrectal biopsies are not in favor, and the next is transrectal exit biopsies. So looking at the complications in the multisystemic meta-analysis in this study, you can see that the rectal bleeding in the transrectal biopsy is almost to the tune of 10%. And in the hematuria, of course, in both the transperineal and transrectal route is equivalent. As such, it's about 12% and 16%. The most bothersome symptom which was bothering for the transrectal route is the fever, which is around about 6%. But then pain is more in case of transperineal route as compared to transrectal. But however, the major concern the world over is that the infection rate following TRUST biopsy varying from 1% to 12%, with severe sepsis varying from 0.1 to 2%, and rapid antibiotic resistance making the things complicated. So the world started moving towards the lot of MRI-guided targeted biopsy to reduce the biopsies, especially in case of transrectal biopsies. And there are a lot of papers published going toward the MRI with the era of MRI, MPMRI, and targeted biopsies. So a lot of biopsies going towards the less amount of systemic biopsies and more targeted biopsies come into picture. With that, the detection rate of ISUP grade 2, more than 2 cancers, was significantly higher in men assigned to MRI targeted biopsies as compared to the systemic biopsies. So looking at the systemic meta-analysis of the MR fusion, when you start comparing with the MR fusion of the TP versus TR, there is significant increase in the cancer detection rate and upgrade to clinically significant cancers. And also there are target biopsy detecting more cancers than systemic biopsies. And target biopsy has a better sampling efficacy. So in terms, cancer detection rate is almost 50% versus 23%, whereas the TP versus TR. And then better sampling efficacy, 46% versus 1.5%, the targeted was systemic, and upgrade to clinically significant cancer by 6.2%. And MR fusion, when you compare the TP versus TR, the cancer detection rate is almost 44% for TP versus TR for 33%. And when the MR TP fusion target versus MR TRUST fusion systemic, there is significant difference of 46% versus 23%. So we are moving towards the more and more target, either in TP or transrectal. But when there's a head-to-head comparison of the transperineal MR fusion targeted biopsy versus transrectal, in this, the analyzing the 8 study showed higher sensitivity for detection of clinically significant prostate cancer with the transperineal approach, has almost 86% versus 73%. So CDR improved by 13% in TP route with MRI targeted fusion biopsies. So why this is happening? only the transectal route even with the biopsies because there are random errors. So there is, in the transectal route, there's a possibility of cognitive. You may tend to miss a small lesion. There's an error of systemic error. Sometimes if the lesion is anterior, you may not be able to reach there, so you're going to miss them there transectally. And sometimes if the lesion is small, because since it's a cognitive, you tend to miss a lesion again as a random error in transectal route. So there are, to modify this to improve the specificity of the biopsy course, there are various fusion biopsies technology techniques are available. You can see this TR fusion biopsies, mostly it's a freehand with a cognitive transplexity and with a side fire and end firing. With the end firing, you can use it for apical biopsies. So basic in transectal biopsies, one needs to have a systemic biopsies with the targeted biopsies. Whereas in freehand, we have a different instruments with the mostly cognitive, the freehand technique, wherein you have a tracker is here. This is electromagnetic tracker, where you can track the targeted biopsies. Or you can use this precision point technique where you can target the lesion, but still, however, it is not a predictive fusion, so you may tend to have a random errors in case even in freehand TP biopsy. Whereas in stabilized, although it's very cumbersome, but it requires a stepper device. This must be mounted, which I'm going to little show that technique, and wherein this is a real-time predictive fusion where you can, if you know that MRI is proper, then you can do a target-only biopsies in target biopsies. So another evidence of targeted biopsies wherein transitional zone course were positive with TP approach more than the transectal route, that brings to the discussion that more and more anterior prostate cancers are detected. So with the transperineal route, as we know that 15 to 25% of them are in the transitional zone, and up to 1/5 of the RP specimens are missed. That is the era when we were doing the transectal ultrasound biopsies. So Lowenstein et al. also reported that these anterior tumors had a poor oncological outcome, and he called them as prostate evasive anterior tumors. And also it is found that 50% of the men with APC had upgrading at surgery, and 40% had more positive margins. So anterior prostate cancer seems to getting the more and more attention, and hence the TP biopsy. So we have a guideline where transperineal biopsies are preferred over the transectal biopsies as a strong evidence. And regarding the procedure, I think we have previous speakers have mentioned that the requirement is T2-weighted images, diffusion-weighted images, and contrast enhancement. And I think I'm just showing the few examples. I rushed this slide. So the procedure is done with a lithotomy position. I'm talking about the transperineal MPMRI. Previous speaker already showed the transectal ultrasound. So the scrotum has to be secured, and anatomical landmark can be mentioned here. I mean, you can make markers. And this is the stepper device where it fixed to the table, and the patient is in lithotomy position. And this stepper device is mounted by these transectal ultrasound. This has got a 6 movements. You can see that X movement, Y movement, and Z movement. In addition, it has got a rotation. So totally it has got 6 movements, so that you can actually virtually fix the MRI image to the ultrasound image almost near normal. So it is called a real-time, almost predictive fusion, which has got a rigid registration. So what happened, this mounting, you can see that instrument here, this is the stepper device, and this is synced with ultrasound, and this is the probe which has gone in, and this is the grid technique which has been put, and ultrasound images what we have done. So you need not have to do a separate ultrasound is required. The same ultrasound, you can have the MRI image coming into the ultrasound, and this has been almost imaged and fused. So you have a fusion ready, and then you can possibly see the lesion, and when the contouring has been done pre-hand by the radiologist, and this is the contouring of the prostate, and you have identified the lesion either in a yellow, red, different 3-4 lesions, target lesions can be identified. And with the tracker, this is the red tracker, once the fusion is occurred, it's very easy to go and take the biopsies. You can exactly go and take, depending upon the size of the prostate, you can go on increasing the 2, 3, depending upon the size of the lesion. So this is how the biopsy report comes out. Either you can do the target biopsies. If the periodic lesion is shown, a suspicious lesion, you can go for a systemic biopsies also. So we have a template biopsies for the transperineal biopsies, and also we know that any lesion more than 15 millimeter can be targeted easily. So in those cases, you can do only target-only biopsies. The future is moving towards the more and more target biopsies if you know the number of lesions. And we also had some few experience of doing the target-only biopsies. So this is how in 102 course, with the positive course was 79, and there is a positive yield of 77.5% when we did only the target-only biopsies for more than 1.5 centimeter lesion. So trans biopsy, there's a difference between the freehand and stabilized. Freehand trans biopsy can be done for the large lesion, moderate size prostate, it's a cognitive fusion, enhanced target biopsies, there's a possible errors may be there, and it can be done through the single incision. But disadvantages is you possibly of missing the cancers in large prostate and anterior lesions, and when the lesions are less than 1 centimeter. Whereas in stabilized DP biopsy, you have a small lesion, even less than 1 centimeter can be picked up accurately. Large prostate with peripheral lesion, laterally directed biopsies can be done. And it's a predictive fusion, it's a real-time predictive fusion. And so the target biopsies are accurate. And the disadvantage is general anesthesia and have to have a multiple needle pricks. So what are the pitfalls of transperineal biopsies? It's a more time-consuming, operation time is more, painful, 4 versus 2, had higher repeated rates. We also had 2 cases of repeated biopsy because we didn't fuse it properly. We have taken only the soft tissues, and additional anesthesia is required. So how to tackle this additional anesthesia which is required? And this is a technique wherein a local freehand technique you can inject into the 2 local incisions here, and then you can go trachally, anteriorly, and from that area you have to have one precision technique. This instrument has revolutionized in doing a local anesthesia transrectal transperineal biopsies. Whereas in grid technique, you can inject almost all these areas of local anesthesia, or you can, if you have a targeted lesion, big lesion, you can inject only to the areas of identify the MRI lesion, and you can only put in the local anesthesia and you can put a grid technique to those areas. So in the local anesthesia technique is that with the grid technique, you can inject 2 to 3 of lidocaine 1% along neurovascular bundle, just distally to the apex and about a 3-5 cc, and maximum 35 cc you can put all along the neurovascular bundle so that you can have even the grid technique local anesthesia biopsies. So what are the pitfalls of transrectal systemic biopsies versus plus MRI TB fusion? It may sample only 0.04% transrectal and difficult to sample the anterior and apical region, and less effective in patients with prior negative biopsies. So how to overcome this? Is there reality? Is that because in India we have a problem of plenty that we cannot forget about the cost issues and availability of the machines. So how to overcome all these things? For anterior lesion, there's a technique in the transrectal route wherein you have anterior advanced biopsies, wherein the prostate biopsy is put in the rectum area there, and then the needle is advanced 5 to 15 millimeter forward, and then hit the anterior biopsies. Probably this can be done with about up to 50 to 60 gram prostate. Bigger prostate still pose a problem with this. And we also identified one of the repeat biopsy in the transrectal with the anterior advanced biopsies. This lesion is the one when we repeated and we are able to find out the malignancy in this area, transrectal route. So how to overcome the infection, which is really bothersome, but I don't know about a lot of issues were mentioned in the literature. A needle is inserted into the formalin to release the specimen and wash the pyridine iodine after each firing. And pyridine iodine plus lignocaine jelly rectal packing for 20 minutes prior to procedure and 2 hours post procedure. This is how it has been done, and I think this has yielded us not less amount of infection. After the biopsy has been done, the packing has been done again for about 2 hours, and the patient is asked to sit in a commode and pressurize himself to pull out this. So this is the intraoperative protocol, and also we have an evidence that meta-analysis of 8 RCT showing that the rectal pyridine iodine preparation before transrectal biopsy, in addition to antimicrobial biopsies, resulted in significantly lower rate of infections and complications, and use of rectal cleansing with pyridine iodine in men has a strong evidence. So with the fluoroquine license, if there is a first evidence is transperineal, and if somebody is doing the transrectal biopsies, and if the hospital infection committee, if agrees for the sensitivity in that particular area, so that we can use more than 24 hours of antibiotic prophylaxis is required. With this, I think we can prevent the more and more transrectal biopsy infections. And our experience also shows that we have done about duration, the duration of surgery for transperineal biopsies is more. We have done a few cases with the pudendal block and local mapping and GA, but it's definitely painful. And then the iridoid retention is bothersome in the initial period. Because it has got a steep learning curve, you may have to do a 20-30 cases before you get adjusted to it. And of course, the infection rate, we had about 1.2% as compared to the literature, which is showing up to almost 10% nearly. And of course, also we have found a repeat biopsy in one of the 45 repeated biopsy we did in transrectal, we found in 1 patient, whereas out of 6 patients, we have found about repeat biopsy showing the positivity in 4 patients. This is because of the advancement of the MPMRI and fusion technologies, which I could attribute that to. So in comparison, infection rate and sepsis is high with the transrectal fusion. Fusion of the supine MR images done in lateral position of the truss images. Hence, it is a cognitive fusion. And fusion direction is freehand. Random errors are more. Target biopsy errors may be there. Anterior lesions are difficult to target. In TP fusion, minimal or no infection. Fusion of the MR images are done with the truss images in supine position. The accuracy of the predictive fusion is a real time. Biopsy direction is stabilized. Minimal errors. Target biopsy is accurate. Anterior target is the best technique. So this is the overall fusion in my last 20 years of experience, which I put across here with the MRI fusion with the transect ultrasound. You have a clinical suspicion with the MRI fusion available, and if it is not available, we still do in one of the centers a transect ultrasound with the cognitive fusion, where we tend to do a MRI targeted biopsies and sextant biopsies, and we also follow the anterior, extended, advanced for the transitional zone anterior biopsies. With the freehand technique, we also use both the freehand and stabilized technique. So here in the freehand technique, it depends upon the PIRATS 3. I think it depends mainly on the radiologist. You have to sit with him. And some of the cases with are more than 1.5 centimeter lesion, if they are large, if they are multiple, you just can do only target lesions, target biopsies only. In cases of freehand, if there's some kind of errors, if the lesion is very less than 1 centimeter, then it's better to do a template and target biopsies. So here also in freehand, one can do target if lesions are multiple and if the lesions are more than 1.5 centimeters. 1.5 centimeters, more than 1.5 centimeters, each almost correlates with the PIRATS 5. So in short, CDR rates mainly depends on the quality of MP-MRI. Anti-tumors are more preferable for MP-MRI TP fusion biopsies. TP fusion biopsy preferable for previous truss biopsy negative patients with suspicion or raising PSA. Apical small lesions better picked by TP-MRI fusion. Modified probe needle advancing technique is suitable for truss MP-MRI guided anterior lesions. Truss biopsy infection can be reduced following the protocol which is mentioned followed. Thank you.
Thank you, sir. This is a detailed presentation comparing both the transperineal and transrectal ultrasound biopsies. Now I'd like to call upon Dr. Prokar Das Gupta and Dr. Gopal Sharma to proceed for voting.
So, are we all set now? So, statement 1, can we have it on the screen? Yes. So, the optimal prostate biopsy technique is transrectal ultrasound and transrectal needle biopsy. Statement 2, the optimal prostate biopsy technique is transrectal ultrasound and transperineal needle biopsy. Statement 3, prostate target lesion biopsy alone is sufficient to accurately diagnose prostate cancer and guide management decisions. Great. Statement 4, whole prostate gland mapping biopsies are required to accurately diagnose prostate cancer and guide management decisions. Statement 5. MRI software guided fusion biopsy is superior to cognitive fusion biopsy to diagnose prostate cancer and guide management decisions. Statement 6. All patients undergoing transrectal needle biopsies of the prostate should receive prophylactic antibiotics. Last statement, all patients undergoing transperineal biopsies of the prostate should receive prophylactic antibiotics. Great. Thank you, everyone. Thank you, sir.
So we came to the last session. So I'd like to call Dr. Anup Kumar sir, who is going to talk about the role of radical prostatectomy with or without a pelvic lymph node dissection.
Good morning, respected chairperson, seniors, my dear colleagues. I want to thank organizers for giving this opportunity. So, I'll be talking about role of RP and lymph node dissection in high-risk localized and locally advanced CA prostate. We all know definition of high-risk localized and locally advanced CA prostate as per EU guidelines. Now, when we talk about high-risk localized CA prostate, what are the treatment options? Of course, active surveillance is out of the question because any patient with Gleason 4 and above is a contraindication for active surveillance, and watchful waiting again is out of question except if the life expectancy is less than 10 years. So what options do we have? The latest guidelines of EAU shows that you can offer radical prostatectomy to these patients in selected groups as a part of multimodality treatment. And one should perform extended pelvic lymph node dissection in these patients and do not perform a frozen section as this has not added to any advantage. Second option is you can offer EBRT along with ADT for 2 to 3 years, a strong recommendation. And also you can offer EBRT along with brachy with ADT for 2 to 3 years. But one should not offer any focal or whole gland therapy, focal therapy or ADT monotherapy in these patients. Now this is very important that whether you do open, lap or robotic prostatectomy, there is no superiority in terms of functional and ecological results as per the latest guidelines. But yes, if you have to do lymph node dissection, it has to be external lymph node dissection. Do not perform nerve sparing if there is an extra capsular extension on that side. And currently, there is no role of new adjuvant ADT in this group of patients as per the latest evidence. The NCCN guidelines also support the same guidelines. Either you go for RP plus PLND for these patients, or you can go for EBRT along with ADT. Now, when we talk about RP versus RT in this group of patients, how to choose? This is again an important question. So this paper summarizes outcomes of radical prostatectomy in these patients, and they've found positive cervical margins of 25%, lymph node positivity up to 14%, and 5-year outcomes if we see 44% of biochemical recurrence, 7% metastasis, and overall mortality is 3.3%, and around 40% required some kind of adjuvant treatment. This is the paper published in JAMA, which compares the outcomes of multimodality treatments versus monotherapies, and what they found, whether you do RP or RT along with the multimodality treatment, it has got better outcomes as compared to monotherapy. So that we now agree it has to be multimodality treatment. But the million-dollar question is, what should we choose, RP or RT as a multimodal treatment. So RT is normally preferred for patients who are at high risk for anesthesia, and radical prostatectomy also addresses the question of LUTS because it can address the question of LUTS and chronic retention for that patient. Then we have a better accurate staging with the RP because the chances of down staging from T3 to organ confined group in up to 30%. The down staging of Gleason score in up to 10% patients, and pathological lymph node staging is also possible. Radical prostatectomy also, PSA becomes undetectable, so it's better to follow up and we can easily identify biochemical recurrence. And also we can distinguish between local and distant recurrence. But with the RT, it may take up to 1 to 2 years to reach the PSA nadir, and that raised PSA can be due to different reasons like residual prostate, PSA bounce, or residual disease. So post RP, if there is a biochemical recurrence, you have still option of going for RT, and post RT, if there is a recurrence, salvage RP, you know, has a lot of morbidity and a lot of other complications. So in nutshell, I can say in this particular group, RP versus RT both have equivalent oncological outcomes. It basically comes down to how to choose minimal side effects, and you have to counsel the patient and take the patient factors into account whether to decide for RP plus RT as a multimodality treatment. Next group is locally advanced CA prostate. It's a very, very complex group, high risk of biochemical recurrence, high chances of requiring adjuvant therapy, and management option namely depend upon the life expectancy. If you have a more than 10-year life expectancy, it's better to offer a local treatment in addition to systemic treatment. So we divide this group into two subgroups. One group where is T3, T4 with low lymph node positivity. There, if you offer local treatment as a part of multimodal treatment, it has definitely benefit. Another group is only any T with lymph node positive. That group, traditionally, there was no local treatment offered, but now the scenario is changing, and now even in this group, local treatment has shown to have some benefits. So now, this is the advantage of showing if you go for RP as a multimodality approach in this particular group, especially in T3 group I am talking about, when there is no rectal involvement, no bladder neck involvement, then you can have an accurate histopathology assessment. 30% can again have a downgrading or downstaging, and you can better prognosticate these patients for the further management. And of course, it can also treat the associated LUTS for the patient, which is a very common presentation in our part of the country. Easy follow-up with the PSA, and 30 to 40% may not need adjuvant treatment. If they require, you can still give adjuvant treatment and you can have a control of the disease. And there is weak evidence which I will show that suggests possibly some superior oncological outcomes if you offer RP in at least T3 group as compared to the RT. So if you look at the EU guidelines, it says RP offered to these patients in a clinically lymph node negative patient as a part of multimodality treatment, and you should do an extended pelvic lymph node dissection. Now this paper summarizes the results of RP in locally advanced CA prostate. 78% patients required some kind of adjuvant treatment, and 27% are overstaged. If you compare the outcomes of T2 versus T3, so the outcomes of T3, they are not very lower than the T2. And that's why they concluded that RP can be offered as a multimodality treatment in this group of patients with optimal outcomes. This is again another paper, systematic review, which compares the role of RP or RT in lymph node positive patients. And what they found, that traditionally ADT was given alone, but now there is ample evidence which shows you should add either RP or RT to systemic treatment, and does have the survival benefits. Now this paper directly compares the role of RP versus RT in locally advanced CA prostate, and it's like 2,000 plus patients in each group. What they found, if you look at the graph, that if you compare EBRT versus RP in this group, higher mortality in the RT group and lower cancer specific mortality in the RP group. So they concluded that there is some evidence of superior outcome in the RP group. Again, a paper comparing the RP versus RT in this group, they also found that if you do RP in this group, 60% patient might not require any ADT. However, the sexual and the urinary toxicities are higher in the RP group. So again, we have some evidence which shows RP might have superior outcome as compared to the RT in this group. And this again a very important paper in lymph node positive group. What they found in this group, if you offer local treatment in addition to systemic treatment, definitely the results are better. And therefore, they concluded that either RP or RT can be offered to these patients in addition to the systemic therapy. Now, this you look at a trend last 20 years. The role of RP in these patients is increasing steadily because of the better outcomes and less morbidity in these patients. So this, I think, shows the trend across the world. Now, adjuvant treatment, if you look at the guidelines, they say if pathological lymph node negative in these patients with positive margins, then you can offer adjuvant radiotherapy. It's a strong recommendation. But if it is lymph node positive, still a subset of patients where the lymph nodes are less than or equal to 2 and PSA less than 0.1, you can still have observation. So this is this group of patients who can still avoid adjuvant treatment. In other groups, you can offer adjuvant ADT with RT. So this again shows that RP as a first approach, as a multimodality treatment in this patient can have a curative intent and can have better outcomes. Now, there is a talk about neoadjuvant ADT in these patients before RP. And this systemic review shows that there is good pathological response of neoadjuvant ADT. Positive surgical margins 50% lower. Positive lymph nodes were 40% lower. Organ confinement was 60% or higher. However, they could not achieve PT0 disease. But oncological outcomes at 5 years, they were comparable to the other group where they have done in the localized disease. So what they found that neoadjuvant ADT is showing a good results. However, this is still not in the guidelines. And to address this question, these trials are on the way. One is SPCG trial, which is comparing the role of RP versus RT in high-risk localized CA prostate. And other trials addressing the role of neoadjuvant ADT prior to RP are Proteus, Neptune, and Genus. And we are waiting for these trials to basically address this question whether neoadjuvant ADT can be given or not. In the last, I'm going to show a small video of locally advanced CA prostate. And what we found as a challenge is when we do RP, robotic radical prostatectomy in locally advanced high-risk prostate. So this was a series which we performed.
And also as per the NCCN guideline approach. So we start
2021, it's currently still going on. And I'm going to show a small video of that patient. 67-year-old gentleman with obstructive LUTS, which is a common presentation in India for last 6 months. And biopsy showing a Gleason score of 5+5 and 5 out of 12 cores were positive. And PSA was 26. There's a heart nodule on the left side. And on further evaluation, if we look at the MRI, both the seminal vesicles were involved. Both seminal vesicles, but there was no lymph node involvement. We did a PSMA PET scan, which was negative, and therefore, this was a case of locally advanced CA prostate. CT3, N0MX, and Gleason 5+5. So we planned a robotic prostatectomy as a part of multimodality treatment with the XI robot. And we always start with the posterior approach first. And this is the dissection of the vas and seminal vesicle on the left side. And then we follow the seminal vesicles, go in the posterior plane in 30-degree up position. There was a lot of inflammation around because seminal vesicles were involved, but you could get a good plane and then you can dissect the rectum down and then you go further to the apex, then you drop the bladder, go to the endopelvic fascia. And in this particular patient, we did not do any nerve sparing because, as I said, if there's a extracapsular disease and high volume disease, better to avoid nerve sparing. So we do not try any nerve sparing. The bladder neck transection you can see. And then we are clipping the pedicles on both the sides. So it is non-nerve sparing RARP. Only thing different as compared to the localized disease is the difficult planes in the posterior area because of the lot of desmoplastic reaction. And the apical dissection done, and then we preserved a good intrapelvic urethral length as we do for any disease and for the good anastomosis. So urethra was transected, and then we did a modified transverse bladder neck plication. You can see the orifices because the big medial lobe was there. and then this is using the 3O V-lock suture to do the modified plication, 2 to 3 sutures on each side. This was followed by uretrovesical anastomosis, typically von Welthoven modified technique, 2 3O V-lock suture joined in midline, and then we are starting on 5 o'clock to 10 o'clock, and then in the anti-clockwise direction. So that is the completed anastomosis, saline distension, no leak. And then we'd always do EP-LND in this patient. Our template is proximally, we go 2 centimeter proximal to the common iliac bifurcation, distally to the lymph node of Cloquet. Laterally, we go to the external iliac artery, medially to the perivesical area, and posteriorly you can see the obturator nerve. So a good lymph node dissection is must for this particular disease, and our template says at least 15 lymph nodes on each side should be there in the histopathology. So that's the final template on the right side. And so this particular series, what we found, that we had 71 patients with PSA of around 13. These are the comorbid conditions you can see there, and all of them, they were having T3 disease with Gleason 8 and above. And of course, SHIM score was on the lower side in most of our patients. Therefore, we did not attempt any nerve sparing. So our mean operating time in this group was around 2.5 hours, and there was no open conversion. And most important was the histopathological results, which I was referring to in my presentation earlier. The complications were Olivine-Cleven 1 and 2. Mean catheter days was 7. And look at the post-op histopathology results, 20% they had downstaging and downgrading in 10%. Positive surgical margins in 4%, and mean lymph nodes were 18, which we removed in these patients. Our mean functional, if we look at the functional outcomes, the continence rate at 6 weeks, 3 months, it was comparable to what we can achieve in a localized disease. So this series just shows that yes, outcomes as a part of multimodality treatment is feasible, and it can be done in centers with expertise. Thank you very much for your patient listening.
Thank you, sir. That's a good presentation from Anup Kumar, sir. So we'd like to proceed with the voting. I'd like to invite Prokar Das Gupta, sir, and Gopal Sharma to proceed with the voting.
Thank you. So we have 14 questions, 14 statements. First statement is patients with high risk or locally advanced prostate cancer can be considered for a radical prostatectomy. It's not going ahead. Next slide.
Next, please.
Next. Statement 2, patients with clinically T3A prostate cancer can be considered for a radical prostatectomy. Statement 3, patients with clinically T3B prostate cancer can be considered for a radical prostatectomy. Statement 4. Patients with clinically T4 prostate cancer can be considered for a radical prostatectomy. Statement 5. Patients with low volume clinically N1 disease on PET scan prostate cancer can be considered for a radical prostatectomy. Statement 6. Patients with low volume clinically N1 on MRI prostate cancer can be considered for a radical prostatectomy. Patients with bulky clinical N1 disease on any imaging modality can be considered for a radical prostatectomy. Statement 7. Statement 8. Patients with Gleason grade group 4 can be considered for radical prostatectomy. Actually, this should have been in terms of ISUP. With Gleason grade group 5 can be considered for radical prostatectomy. Statement 10. Patients with PSA more than 20 can be and prostate cancer can be considered for a radical prostatectomy. Patients with clinically CN0 prostate cancer undergoing radical prostatectomy should have a pelvic lymph node dissection. Statement 12. Patients with low volume clinically N1 disease on PET scan only, prostate cancer undergoing radical prostatectomy should have a pelvic lymph node dissection. Statement 13, patients with low volume clinically N1 disease on MRI, again prostate cancer undergoing radical prostatectomy, should have a pelvic lymph node dissection. I think we can take this question as well. So patients with bulky clinically N1 disease on any imaging modality should have a pelvic lymph node dissection. Thank you. Thank you, sir. Thank you very much.
So thank you everyone. It was a nice session. We covered all most important topics regarding the imaging and biopsies and the role of prostatectomy also. And because we are behind time, we can discuss any questions or comments during tea break or lunch break. And I'd like to call Dr. Saket Singh for the next session.
Thank you. For the next session, I would like to invite our chairpersons, Dr. Venkatesh Krishnamurthy, Dr. Rajiv TP, and Dr. Dilip Pal. The voting for this session will be conducted by Dr. Prokar Das Gupta and Dr. Tarun Jindal. So, unfortunately, due to some personal reasons, the first speaker couldn't make it for the session. So we will directly go ahead with our second lecture, that is the role of androgen deprivation therapy with or without androgen receptor targeted agents. It will be delivered by Dr. Mahendra Pal. Sir, please come on the stage.
Thank you, Dr. Amit and Ravi, for the invitation. So the talk is on role of ADT and ARTA in high-risk clinically advanced prostatic cancer. So as we all know, prostatic cancer is the most common cancer in the man, leading cause of death in developing countries, and localized high-risk prostatic cancer accounts for 20% of total clinical presentation, and is the most concerning form of the disease because one spectrum is localized, the other spectrum it can progress to the metastasis with the time. And despite of advances in the treatment of prostatic cancer, high-risk prostatic cancer still have 35.5% of mortality in 15 years, and locally advanced is approximately 50%. So in the riskometer, as we can say, these high risk and very high risk carry long-term consequences. I will not go in the detail of definition of these category. The clinical stages ranges from T2C to T3 for T4 in various guidelines, and the common thing is serum PSA is more than 20 and the glycemic scale is more than 8. So coming to ADT, as we all know, ADT is a cornerstone of the management of whenever ADT started as a localized or locally advanced or the metastatic prostatic cancer, and the aim is to achieve the castrate level prostatic serum PSA. It can be achieved by the surgical or the medical castration, but despite of having castrate levels, testosterone level, the cancer cells of the prostate may have some mechanism to produce their, to escape this control of the ADT, and they lead to disease progression. About the androgen receptor targeted agents, where ADT affect the production of the testosterone, and these targets affects the hormone function, like apalutamide, enzalutamide, dolutamide, and the androgen biosynthesis like abiraterone. But on the heel of success, these novel agents are still under trial, and we will see in the talk. So in these category of this category, do we need multimodal therapy? The answer is yes. The reason, because the presence of the subclinical metastasis. And how to deal it? Applying novel therapeutic agents, using treatment intensification, and treat both primary and the micrometastasis at the same time. And we all know that ADT plus RT has become the standard of care in the men with the presenting with the high risk and the locally advanced prostatic cancer. ADT, now coming with the different scenarios. So ADT alone in the management of high risk. So neoadjuvant ADT for the RP is strongly discouraged other than the clinical trials. And routine use of adjuvant ADT with the RP is definitely strongly discouraged, only selected patient where the nodes are positive. Now coming to the node of positive, the primary ADT can be given, as we show that there is immediate ADT has a better survival rate compared to the delayed ADT, and it is the non-inferior. Messing et al. Studies the ADT after the RP, and they prove that immediate ADT with the RT has a better survival rate in the high risk and prostatic cancer. Now coming to the radiation with the ADT. So this 3 cohort study was done, and they studied the specific ADT duration with the only EBRT and the EBRT with the brachytherapy. And they found, and the ADT was given to less than 6 months, 6 to 18 months, and more than 18 months. And they found that there was with the threshold of the ADT was 26 months, 3 months with the EBRT and 12 months with the EBRT plus brachytherapy. And they found that EBRT with brachytherapy, a longer duration ADT, has linked with the improved disease margin-free survival. And the patient with the EBRT alone, they need more long duration of ADT compared to the EBRT and the brachytherapy. And they concluded that optimal minimum AD duration for the duration of the treatment with a high dose EBRT alone is more than 18 months. And with EBRT and brachytherapy, it should be 18 months or the less. Again, these 2 trials, RTOG 9202 and the DART trial, they again studies the duration of the ADT in the localized and locally advanced prostatic cancer. And they concluded that improved OS with the prolonged ADT with the 18 or 24 month of duration. Another study which studied the 483 patient with the short-term suppression of the ADT and 487 is the long-term suppression. And they found that with the follow-up of 6.4 year, the short-term duration patient has a more mortality compared to the long-term duration. And prostatic specific mortality, again, it was approximately 3/4 times more than the compared to the long-term group. If you compare the overall mortality in the short term was approximately something 4% more than the long-term ADT suppression. This study concluded the combination of radiotherapy plus 6 months of ADT provides inferior survival when we do give ADT for the at least three years. So what is the optimal treatment for locally advanced prostatic cancer at present? Ideal is a local treatment with systemic therapy in the form of ADT. Most studies using EBRT as a local therapy. There is no randomized control trial at present with the EBRT and the RP. Optimal time will be unknown, and initial measurement definitely should be the multimodal therapy. Coming to the clinical trials, so all these androgen receptor targeted agents are at present in the clinical trials. Let us go one by one. As per the drug, it's the Atlas for the apalutamide, Anzard with the enzalutamide, Stampede with the abiraterone, and HiCap with the darolutamide. Again, the role of antigen therapy has been studied, is studied with the surgery. There is a Proteus trial. Atlas trial is a large phase 3 randomized control trial that will study the addition of apalutamide to the radiotherapy for the high-risk and locally advanced prostate cancer. It will be given prior to radiotherapy and after the radiotherapy for 2 years. Primary endpoints of metastatic survival. Secondary endpoints, they have overall survival, disease progression, PSA control, and distant metastasis. Study completion date is 2026. Anzard trial, again, is a phase 3 randomized control trial. They will receive antagonist for 24 months and RT for RT after that, before that is 16 months. And enzalutamide will be given for 160 mg for 24 months, and additional radiotherapy will be given if there is a node positive in the imaging. And this trial going to be finished at 2025. The Stampede trial, it has done something some similar before. So whatever they studied in their previous study, they selected some few cohort in their patient, and they divided those patients with the non-metastatic disease, in which 20% having node positive and 28 having node negative non-metastatic disease. And they found that in this cohort of the patient, if they add abiraterone with the standard of care, they have a significant higher rate of survival rate and failure survival compared to the ADT alone. So this paper was an guide to decide the ATR with the therapy in the locally advanced prostatic cancer. As we can see, the graphs, definitely the adding the abiraterone has a better survival, and the forest chart we can see it is towards the combined therapy with the abiraterone. The same authors, again, they propose in 2021, there is a scope of using ATR with the radiotherapy in the locally advanced and localized prostatic cancer, and maybe the most likely they are going to present this case, propose this study in future. This paper for using darolutamide presented in 2021 as an abstract, and they are going to randomize 1:1 patient darolutamide 600 mg, and they will receive, it will be given for 96 weeks plus RT starting week 8 to 24 for randomization, and primary endpoint is the metastatic survival. Secondary endpoints are overall survival. They also have tertiary endpoints like cost effectiveness, identification of prognostic and predict biomarkers in that. So this will give us maybe the better something new insight for the further future studies and some guidelines. Now coming to Proteus trial, which is actually comparing these drugs after the radical prostatectomy, and they are using epiloteramide for that. In this study, patient will receive 6 cycles of epiloteramide or a placebo followed by RP, and followed by again 6 cycles of epiloteramide or the placebo. The dual primary endpoints, pathological complete response or the metastatic-free survival, and secondary endpoint will be the PSC survival and the progression-free survival. And this study is going to finish in 2026. What guidelines says at this scenario? So EU guidelines says that ADT should be given for the high-risk patient whenever the RT is planned, but not with the radical prostatectomy, the nodes are negative, and it should be given for 2 to 3 years. And RT can be IGRT or EBRT with brachytherapy. Again, only offer ADT monotherapy in those patients who are unwilling to receive any form of local treatment if they have PSA doubling time less than 12 months or PSA more than 50 nanogram or other pathology. For the locally advanced prostatic cancer, what EU guidelines says, again offer ADT for the N0 patient along with the EBRT or the IMRT. It should be for at least 2 years. And again, long-term ADT is given for the selected patient with the more than 2 high-risk factors like T34, Gleason more than 8, and PSA more than 40. And they also propose the long-term ADT, that means more than 2 years. ANSYS guideline proposed the similar things. So as a take-home message, as this the format of this conference is something different, so I am not putting over any take-home message. Please take a message whatever we have discussed, and we decide after your voting. So please vote. Thank you.
So the voting for both the sessions will be conducted now. I would request Dr. Prokar and Dr. Tarun to please conduct the voting.
You do for the first one, I do for the second. Right, sir. So let's have the questions for both the sessions. Statement 1, please. Statement 1. Yeah, start with that. There's no statement 1. Okay, let's go with it. Okay, patients with high risk or locally advanced CN0 prostate cancer receiving radical hormone radiotherapy should have their prostate, seminal vesicles, and pelvic lymph nodes irradiated. Next question. So patients with high risk or locally advanced CN1 prostate cancer receiving radical hormone radiotherapy should have their prostate, seminal vesicle, and pelvic lymph nodes irradiated. Statement number 4, the optimal radiotherapy schedule for high risk or locally advanced prostate cancer is conventional fractionation, that is 2 grays per fraction. The optimal radiotherapy schedule for high risk or locally advanced prostate cancer is moderate hypofractionation, which is 2.2 to 4 gray per fraction. The optimal radiotherapy schedule for a high risk or locally advanced prostate cancer is extreme hypofractionation. It's really heartening to see that F is gaining majority in this. Patients with high risk or locally advanced prostate cancer should be considered for ADT plus radical radiotherapy plus a brachytherapy boost. Wonderful. Wonderful. At least we are good with the theory. Can we move to the next set of questions? Okay. So patients receiving radical radiotherapy for a very high risk or locally advanced prostate cancer should receive 24 months of abiraterone plus prednisolone in addition to the ADT. What duration of ADT should patients receiving radical radiotherapy for a high risk or a locally advanced prostate cancer receive? 6 months, 18 months, 24 months, 36 months, lifelong, and not my field of specialty. So A is 6 months, B is 18 months, C is 24 months, D is 36 months, E is lifelong, F not my field. Patients with multiple comorbidities receiving radical radiotherapy for high risk or locally advanced prostate cancer should still receive ADT. Neoadjuvant ADT can be given to patients with locally advanced prostate cancer to downstage the disease prior to radical prostatectomy. Adjuvant ADT can be given to patients with locally advanced prostate cancer post-radical prostatectomy if PN1 disease is found. And the last question being, patients undergoing radical prostatectomy for a very high risk or a locally advanced prostate cancer should also receive 24 months of abiraterone plus prednisolone off license or an alternative ARTA off license in addition to androgen deprivation therapy. Thank you. Thank you, sir. So before we move on to the next presentation, Dr. Ghosh has an announcement to make.
I'll just interrupt the program for 2 minutes. May I call Vishal Arora from IPCA Labs to come up to the stage for a minute, please? Mic though. I just wanted to acknowledge in public that 6 months ago, or even 5 months ago, I took on this Herculean task, absurd rather, to publish a journal of uro-oncology. The dream came true, and this man was responsible. So I just wanted to put our hands together for this man. It is not a question of endorsing a pharma. This human being was by my side, and I was chasing this unreal target which became real. Vishal, thank you very much.
Thank you. Thanks a lot. No, I'll say thank you very much, Dr. Ghosh, and all the luminaries sitting over here. I think IPCA had been always in the forefront whenever it had been an area of academics. And when Dr. Ghosh discussed with me this idea about this entire conference and the journal, I also got so excited seeing his enthusiasm for the entire project that I could not say no. And I'm really thankful to Dr. Amit Ghosh for giving us this opportunity to be the part of this conference. And we will definitely love to be the part of this set of conferences ever in urology. You would have seen in the last 3-4 years the way IPCA has come up in the area of academics. We will definitely love to be, and I'll thank you from the core of my heart.
Thank you very much.
Thanks a lot.
For the next lecture, I would like to invite Dr. Raj Nair. He will deliver his talk on prostate cancer survivorship.
Thank you very much. So, survivorship in prostate cancer, why does it matter? Because through the eyes of the patient, they think one thing. Through the eyes of the surgeon, they think another. The eyes of a radiotherapist, another. The eyes of the family, they may think another. Even the eyes of the employer. But here you are, surgeons in the audience, and a few radiotherapists, Simon. And you know, what's going through your mind when you have a patient that has, say, localized prostate cancer undergoing treatment? It might be, gosh, they're a bit obese. That might be a difficult operation. I hope there isn't much blood loss. I just need to make him continent. You know, he hasn't got much money. We'll try and get him out of hospital as quickly as we can, make sure there's no complications. And I hope his PSA is okay. But the patient might be thinking something completely different. The patient may be thinking, well, I hope my cancer's sorted, but I need to get back to work. I need to sort out my family. I need to pay my bills. You know, I'm an active person, I'm a laborer. I work on the roads, building the highways. I need to get back on the road and start lifting again. Is that possible? There's a dichotomy of interests, and that's what survivorship looks into, and it's the treatment beyond the cancer itself. And this is why it's so important. It's because, actually, we're surviving longer. Our treatments are getting better, and over time, what we're seeing is patients are not dying from cancer necessarily all the time, but they're surviving with cancer, or they're surviving because the treatments of cancer are significantly better. And look at this line, you know, in 2022, the number of people with malignancies in the United States that are surviving beyond 15 years is that blue line in the top right. Look at where it was in 1977. This is going to be a huge, not only a healthcare burden when it comes to follow-up and tests, but an emotional burden and a survivorship burden for patients. But what is survivorship? There are many definitions out there. There are definitions from Wikipedia, there are definitions from all sorts of the guidelines, the EAU guidelines, the NCCN ones. It's all slightly different, but they all focus on this particular point. It's a survivor, it's a cancer survivor, is someone who's living with or beyond their disease. And we've looked at this a lot, and these are the two main things that us as urologists in the audience are concerned with, are continence and erectile function, beyond the cancer's specific survivals. And there is a way that we can measure some of the impact of some of the treatments we can deliver to patients with when it comes to survivorship. Here's a very nice review article which looks at postoperative exercise interventions to optimize continence outcomes following radical prostatectomy, and it works. A very simple intervention works. You know, there's a curative effectiveness, there is the oncological curative effectiveness of radical prostatectomy, but that can seriously be diminished by the treatment-related adverse events. So if you make people incontinent, they are not going to thank you following their surgery, because life is miserable then. And you can do what you can in the audience to help improve that. And one of those things is pelvic floor exercises. Look at this. All the way back in 1976, biofeedback was studied in men post-radical prostatectomy. And then the first prospective report of urinary incontinence after radical prostatectomy surgery. And then the first randomized controlled trial in 1994 looking at pelvic floor muscle exercise following radical prostatectomy. These are interventions, simple interventions that one can exercise, and they need to keep being studied. So it's not just about the abiraterone plus this combination plus that combination. These are cancer survivors that need other aspects of their care studied and studied well. Erectile function. 100% of men will have sexual dysfunction after prostate cancer intervention, okay? 100%, it's sexual dysfunction. But 85% of those men will be erectile dysfunction in some way or form. You are more likely never to go back to normal than going back to normal. And that's a message that I think is an important message to get out there to patients, because you have to manage that expectation at the start. Even at Guy's Hospital, where I work with some of the best surgeons who perform radical prostatectomy, we've looked at our data. Despite bilateral nerve sparing, spontaneous erections are only seen in about 30 to 40% of people, if that. And that's, and more people are unhappy with that aspect of their life than anything else. But they do recognize that was a sacrifice that they would have to have made in order to manage their cancer-related outcomes. Men with prostate cancer, they experience a significant amount of emotional distress related to their AD. relationships suffer. If they need to have children, that suffers. Depending on which part of the world you're from, where perhaps having more and more children is an important aspect to your cultural life, that can be a significant thing to take, or a reason why patients may not necessarily consider surgery or radiotherapy for prostate cancer. But it also means that they harbor their emotions in a very in a destructive way and not seek out an opinion. So they sit and suffer with their erectile dysfunction, and we don't ask the question. And there are not just tablets, and there's not just Cavaject, but there's also psychosocial interventions that have to be demonstrated. Lessons that we've learnt are, and I'm sure many of you do this, but penile rehabilitation early on in the post-operative course of a radical prostatectomy is important. Patients need to be offered PDE5 inhibitors pretty much within the next sort of 2 to 3 weeks following surgery in order to optimize penile rehabilitation. And generally speaking, if it doesn't work, there's no point in persisting with it. You move down the treatment ladder with intracavernosal injections sooner rather than later. Otherwise, you start to have a group of men who are somewhat disenfranchised by the treatment that they've had. And it goes beyond localized prostate cancer. In high-risk localized disease, you've got ADT, you've got the side effects of radiotherapy. And survivorship issues include hot flushes, decreased libido, urinary toxicities, rectal toxicity, sexual dysfunction, mood, bone health, metabolic syndrome, cardiovascular disease, fatigue. All of these things come under survivorship. But in the audience, you're all experts in your own field. Many of you work with multidisciplinary teams and have access to uro-oncologists who might manage some of the side effects of androgen deprivation therapy appropriately. But many of you are actually not only the urologist, but the general practitioner, particularly here in India, where patients can seek specialist opinion very quickly. So you've got to be on top of the management of some of these side effects with respect to ADT and the newer ARTA medication that's there, because you're the only point of contact for these patients. So managing hot flushes by manipulating their hormone treatment or adding in tamoxifen or whatever therapies that are at your disposal is an important thing. Managing bone health with a baseline DEXA scan and calcium supplementation, maybe in your realm. For us, in other parts of the world, it may be in someone else's. But still, it's if you're not doing it, either delegate it to someone who is able to deliver this, or try and learn and manage this part of the treatment yourselves. And of course, there's also the additional things that patients go through, the financial toxicity. Will my son have prostate cancer? Will my brother get it? Should they get tested? In elderly patients with metastatic disease, it's a really important area of prostate cancer that's often forgotten. We are all generally surgeons that enjoy the localized disease aspect of prostate cancer care because it's something that we can directly be involved in terms of the surgical management. But the reality is, in India in particular, there's a large number of metastatic disease with cord compression that might need radiotherapy, that may be incontinent from bowel and have bowel and fecal incontinence, and also may be wheelchair bound at the end of their treatment strategies. These are the patients that actually need more from you at that point in time than necessarily the man with localized disease. So do think about the cognitive effects of treatment, what care grouping issues that you can try and help support, wheelchair access, crutches, all these things come into your domain as well, and it's not simply sidelined. We manage the disease in the human, not just a small aspect of that disease. And that's what patients want. This is not me just standing here trying to preach. This is what patients want. So patients are out there, and they have told us exactly the kind of aspects of their care they want more input with. Yes, they're concerned about surveillance and recurrence and second cancers, but they want more information. They want their physical effects. They want their family support. They want the exercise sorting, peer support. They want more patient-centered care. And you can just see the list is there. And this is a list of things that actually most of us are not used to dealing with. So what survivorship looks at is exactly that, beyond the treatments that we give, but I think is important that we need to have an understanding for, or at least have an availability or an access to this care. So health promotion and advocacy services, shared management, and really getting to grips with what the patient needs or what the family require, particularly with physical side effects and comorbidity management. On ADT, they've got an accelerated cardiovascular risk, and perhaps pulling in physicians who are interested in this area is important. You have to have a vigilance for monitoring the side effects of treatment, particularly when you're introducing novel therapies. It's very easy to start a tablet, but to monitor the side effects of that medication is something that's in our domain, and the psychosocial aspects as well. And those patients who do have hematuria following radiotherapy for whatever reason, take it seriously. Understand that there is a risk of this secondary malignancy that can form with time. And of course, there's the personal agency, the care coordination, and there are lots of evidence-based survivorship interventions. We have evidence to suggest that psychosocial care and caring for family members improves the overall welfare of that patient journey. And in your own country and through your own organizations, one thing that is important is financial assistance and financial support for those who may not have that. They may have enough money to get through an operation or have their immediate treatment. They may not have enough money to continue ARTA treatment or ADT in the long run. And so it's trying to have an understanding of to perhaps charitable organizations that through organizations such as in urology that could be started. So these are interventions that all of you can think about. Because a lot of patients, what you don't want them to do is feel a degree of decision regret. And in fact, this is from Prokos Group here, who's looked at decision regret in patients with localized prostate cancer. And amazing, 1 in 5. 1 in 5 people regret what they've had done to them. Isn't that incredible? You wouldn't buy a car if there was a 1 in 5 chance that you would be unhappy with it. So why would you offer a treatment if you haven't adequately counseled the patient? And the point of reducing regret is giving them information so that in a realistic fashion in order to prevent that. And you see, 13% is the lowest. 13% of patients have regret even with surveillance, but actually doing nothing is probably better than doing something. And roughly between surgery and radiotherapy, it's a tie. So there is a framework that exists for prostate cancer survivorship, and cancer survivorship in any cancers, to be honest. But it really starts with education, and education of the people who deliver the care in particular, and an understanding and awareness that it doesn't stop when they walk out of the door. There's a lot more that can be done. In the UK, where we have a process of multidisciplinary team meetings, but they don't just involve tumor boards in the conventional sense of histopathologist, radiologist, clinician. Often in these meetings are nurse specialists, physiotherapists, researchers. Everyone comes together because everyone has an aspect of the care that they would like to take control of or try and lead on. And perhaps that's something that you can also incorporate in your individual institutions if at all possible. I think there's a recognition that we're all incredibly busy with our time and what we do offer patients. But if you can't deliver it yourself, you can train someone else to deliver that service for you. And certainly in the UK, we have many cancer nurse specialists who try and to manage a lot of the holistic needs that these patients have. And they will sit with them for the extra hour afterwards and talk about exactly what needs to be done, what their concerns are beyond the immediate cancer-related aspects. And I think that's something that probably will be filtering into your services as time goes on, because it is an invaluable resource to have. So don't forget about survivorship. There's more to it, to the patient after they've been discharged from your wards. Thank you.
I would request Dr. Tarun and Dr. Prokar to please conduct the voting.
Thank you so much. Can we have the questions on the presentation? Yeah, questions please. Right. So patients receiving ADT should have a structured exercise program, resistance and cardiovascular. Next question, patients receiving ADT should receive vitamin D and calcium supplementation as a routine. Next question, patients receiving ADT should have a baseline DEXA bone density scan done. Penile rehabilitation therapy should be offered to all patients undergoing a radical prostatectomy. Dedicated pelvic floor physiotherapy should be offered to all patients before and after a radical prostatectomy. Patients should be offered duloxetine as the first-line medical therapy for stress urinary incontinence post-prostatectomy. Patients with urinary incontinence post-radical prostatectomy for a high-risk prostate cancer should be considered for a urinary sphincter. Patients with erectile dysfunction following radical treatment for a high-risk prostate cancer should be offered specialist advice on the management of ED. All patients should have an access to a key worker to coordinate their holistic care needs. In certain centers, yes, but not routine. Certainly we do. Thank you. We move on to the next session. Thank you.
For the last lecture of the session, I would like to invite Dr. Ashwin Tamarkar. He will deliver his talk on future research themes.
Good afternoon all. Thank you for this opportunity. So it's a little difficult topic to discuss in this particular forum, but I'll try my best. The organizers have requested me to restrict to non-metastatic cancer, so I'll be discussing about localized and locally advanced prostate cancer and my views on what we can do in future. So that gives me a horizon from early detection to the management of identifying the disease, the wolf in sheep's cloth, focal therapy, and some aid or tools for getting our surgeries better, and salvage therapies, and ultimately the goal on training and retraining. So from the diagnosis, we all know biomarkers do exist. Unfortunately, in India, it's underexplored. There are two new markers, EPI and MPS, My Prostate Score, which gives you the score based on urine testing and amalgamates the TAMPRAS ERG mutations. So the first step from Indian standards is we need to start modifying these markers or utilizing these markers regularly. Obviously, there are certain limitations on finances, but that's the way forward, at least the basic ones, PHI or 4K, which are blood-based markers. The liquid biopsy is something which is coming up in a big way. All of us know that the circulating tumor DNA, CTCs, microRNAs, they increase in the proportions starting from the diagnosis as we progress on the disease spectrum to hormone sensitive and castrate-resistant disease. There are limitations in that, but the ideal goal for a blood-based marker or a liquid biopsy marker should be, it should be good validated. It should answer a meaningful biological question, and it should be giving utility and implications for clinical outcomes vis-a-vis comparing the cost metrics in proportion for the benefit of patient. So coming back to the basics, these are markers which are obviously which will be the ultimate goal. But coming back to the basics, in Indian cohort, obviously PSA cutoff, we still do not have any answers on what's the exact cutoff of PSA from which we should be giving or evaluating patients for MP-MRIs. We are just following blindly the cutoff of 4. Tried searching for some literature. So generally, general consensus on base retrospective data is that the PSA cutoffs in India should be little higher than what we have. One of the paper mentions 5.8. So that's something which we need to start off as the basic research in Indian context of patients. Coming to the patients with BRCA positivity, again, talking about the PSA cutoffs, we know that with the impact study, the cutoff for BRCA positive patients is lesser because they are aggressive cancers, they manifest little early, they are high risk nature and disease. So PSA cutoffs of 3 nanograms per ml. So probably if there are some residents out here, a nice future research would be to collaborate the data in the oncology setups, go back to your clinical setting, talk to your breast oncology colleagues, gather the data of BRCA positive patients and screen their male members of the family to know what is happening. It doesn't take a lot of time or efforts, it just needs cross collaboration probably. Genomics is coming up in a big way. All of us know that we are having certain limitations on the utilization Oncotype DX. We sometimes do it. Decipher's, Prolaris, we have to send the samples abroad. Again, these are the tests which are going to be there with us with certain limitations on finances, but they need to be utilized, especially in Indian cohort of patients, because all of us believe that we deal with the high-risk disease of patients as compared to the West. That's just a hypothesis. There is no concrete evidence to that, unfortunately. We need to build some data on that, and these are the steps which we need to be taking for understanding these markers. Again, talking about the family repercussions of a patient when we talk about genomics, a simple basic principle that when you have a prostate cancer patient in your clinic, we tend to ignore about the family repercussions of the patient. Try and educate the son of a patient or the male members of the patient to get screened for PSA. If it is a metastatic candidate, try and educate the daughters that you may have a BRCA positivity, do test it, and if it is yes, they need to be extremely vigilant for breast and ovarian diagnosis. So these are the data which ideally a genomic thing should be. So we always talk about genomics to the core, but understanding the clinical implications, pulling out the data on clinical front is extremely important, which will have some meaningful correlations. Talking about the biopsies, that there was already a talk and the consensus, but transperineal is the way forward. Institutional things in institutions in India can definitely take it forward. In private sector, the cost becomes an extreme challenge, unfortunately. So we are yet to get there. Eventually we will get there. And the cost metrics and the finances of upstream and downstream cost do sway in favor of transperineal biopsies. So that is something which is important. We gathered a similar data in UK NHS when I was a fellow for a year. The next aspect of treatment, focal therapy. Dr. Yuvraja sir is going to talk on focal therapy, going to give an overview of focal therapy. So that's something which is underexplored. All of us know that we do not have that much of experience in focal therapy in Indian context. neither we have that many eligible patients in Indian group of patients, but multiple options of focal therapy have been tried and tested. HIFU, pedilif-poffin 2-cut therapy, which is a chlorophyll extract, irreversible electroporation, and TULSA. So many therapies have been tried and tested, but again the limitation is the follow-up in the longest series is only up to 4 years. So we do not have robust answers to this particular modality at this point of time, but the future is bright. We need to explore this horizon for a future research perspectives. The high frequency irreversible electroporation is something which they utilize to the core, and then they understand the overall parameters of treatment at 6 months of biopsy and 12 months of biopsy. The TULSA technique, which is a magnetic resonance image guided transurethral ablation, wherein they do the heat wave. Basically the mechanism lies similar to heat based coagulative necrosis as compared to HIFU, but the extra advantage is you real time monitor the effect by MRI thermometry, so that you know which all places the temperatures are based on the heat maps. Talking about the salvage therapy, all of us know that in India, especially the salvage setting post radiation, I'm trying to mention here, unfortunately these patients do not get flagged up to the surgical cohort or surgeons, I mean to say. So we do not have a robust representation of patients having failure post radiation therapy, wherein these focal therapies would come handy, of course with a little more complications. All of us know that post radiation you have high focal therapy which has been going to be given. You have higher complications of rectourethral fistulas and complications in strictures, but that's a segment which definitely needs to be explored well. For that we need to have a good multidisciplinary team approach, wherein a radiation oncologist would diligently discuss with you about the failures which they have it, and not just empirically start on hormone therapy to suppress the PSA forever. So that's the thing which need to be having in future. So focal therapy, it's evolving, I would say. Side effect profiles are safer, but still it's at this point of time no single ablative technology has demonstrated significant oncological superiority, and the long-term data is eagerly awaited. Talking about the surgical aspects, when we know that we need to be getting better and better, Professor Prakhar Dasgupta sir mentioned about the various aspects of how the surgery of robotic scale is refined over last 2 decades in the morning. So talking about those particular aspects, these are little challenging things in Indian standards, but obviously at least the first step is to know about what we can potentially do, and then probably the next will be implementing it into a routine practice and then culminating into a future research project or a nice article. So talking about this paper comes from Professor Rocco's group. It mentions about focal confocal microscopy. It's basically a real-time evaluation of the sample without a conventional processing, which gives you an exact image similar to H&E image. The scope is called Viva scope and gives a fantastic concordance with the final pathology with respect to all the adjacent structures around the prostate. So you know exactly where you have cut on the lateral surface of the prostate edge. Summarizing the advantages of focal confocal microscopy is it gives a fast acquisition and a straight acquisition. The good concordance with the H&E image gives more confidence to the pathologist. It preserves the integrity of the tissue. So going forward, if you want to utilize that tissue for IHC, that tissue is not going to be discarded. That tissue is going to be valid with all the native properties, and it gives opportunity for a real-time remote reporting from sitting at the distance, because it's machine-based reporting. The augmented reality robotic prostatectomies, again, what they have done is so they have mapped the lesion properly prior, amalgamated into the software, and after the bladder neck is transected, a dedicated bioengineer is navigating the model and superimposing the model in a tile pro fashion for high fidelity precision 3D reconstructions. So these are the things which are little far-fetched at this point of time, sitting in Indians, as we speak from Indian cohort of patients, but we need to be evolving towards those lines. What we have as an exception in this belt of patients is aggressive disease. We have a lot of lymph node positive disease. So likewise, we get a lot of patients who have failed with lymphatic single lymph node recurrence in the pelvis as a part of post-surgery PSA relapse. And these are the candidates which should be explored for evaluation of a PSMA-based intraoperative monitoring strategies. Like in this particular paper, they had 21 patients with a salvage lymphadenectomy and 2 in the upfront setting, wherein they used PSMA-based evaluation for understanding the lymph node sampling and to understand whether we have sampled it adequately or not. NeuroSafe, the technique which is not commonly used in India because we believe that our patients are not that deserving or I should say demanding for high-grade nerve spare. But again, there will be a select group of patients who would be trying to understand, not trying to get the balance between the nerve spare and the oncological outcomes. So the first step is to start understanding about what NeuroSafe means and to start implementing, to start knowing the challenges so that we would know how to overcome those challenges. A good pathologist or dedicated team approach has to happen, and obviously with the high degree of, or as a standardized NeuroSafe protocol, you have better nerve spares and better positive surgical margin status in favor of the patient's program. So intraoperative PET scan monitoring, again, this corollary has been taken from the breast mammogram specimens. All of us know that the breast oncologists sometimes do a wire localization of a equivocal lesion. They take out the lesion and do a mammogram intraoperatively, that is called as specimen mammogram. Something similar has been tried with the PSMA PET-based imaging, wherein they have taken out the specimen, did the mammogram that's depicted in the diagram there, and then the histology correlates, especially understanding the nature of the surface and understanding the margins. We spoke about the 3D printing in this particular morning, but that's something which is extremely coming up in a big way at this point of time to know about the high risk, especially for high risk prostate cancer patients, to minimize the margin positivity. If you have something like a 3D reconstructed model, you will be more cautious in selecting your incision site at the respective location. So the basic thing starts from utilizing it as a standard of practice. You should get better and better on every occasion. So they say that there's a hype cycle described by Gartner, wherein any technology which comes in initially, you have a boom of technology. So in 3D printing, we are currently in that phase, especially in India as well as the West. They are utilizing it to the core. There will be a downslope and disillusionment, and then people will get enlightened about what to be done exactly and which candidates need to be embarked upon for 3D printing. The robotic surgery has already crossed this path and come to that particular plateau, and 3D printing will come up. So we need to find a thin line of balance between two and try and select our candidates closely to understand which will be the most deserving candidates for 3D printing technologies. Professor Menon, we heard Professor Menon yesterday about precision prostatectomy. I'm not going to go in details of it, but the premise lies on having hidden carcinomas on the opposite sides of the prostate when the candidate is eligible for focal therapy. So you have a balance of good nerve spare as well as the oncological outcomes. Probably in India, we will have limitations on these group of patients. We may not have that many patients to have this particular approach valid in Indian context. Last 1 or 2 lines on integrative monitoring of the post-operative follow-ups of prostate. That is something which we definitely ignore in routine settings. Our job does not end after the surgery is done. We have to follow up the patients properly for their recovery in terms of continence, recovery in terms of their overall energy levels, and the resistant exercises, the remote-based monitoring. In fact, in IROC trial, they utilize these Fitbit devices for understanding the recovery of the patients in a post-operative phase. So similarly, that can be explored in prostate, which people have already done it. That's something which is new. When I was going through the literature search, when I was given this particular topic, one title which I could nicely gather and I wanted to put forth in this particular August gathering is every urologist and oncologist should know about treating sexual and gender minority prostate cancer patients. Unfortunately, in India, because of the social stigma, we do not talk about this to a very large extent, but they have some different priorities. So try and have a good round of discussion with the psychologists being around with the patients. That can be one segment which can be explored. The learning curve of a prostatectomy, unfortunately, it's not been explored on a very large note. I was fortunate to gather a data when I was a fellow in UK NHS, and we could probably summarize that nearly 300 cases are required to get your results better, and they come to a plateau after about 300 cases, including the complications, the consult times, the overall times. And as a present surprise, I got a compliment from Professor Costello that he agrees to the fact that there are nearly around 200 to 300 patients which need to be done consistently to get yourself better. So that's something which, as Indian cohort of patients, we have a lot of fellowship programs in India. Unfortunately, the data on large collaborations is missing. So unfortunately, these kind of things are something which we need to be embarking upon a lot. Just to emphasize to candidates, probably I will say whenever we talk about future research topics, we should start with the basics. We need to look into what we have the maximum thing in India. We have more patients who are old, who are eligible. So we tried exploring these segments for our research perspectives and finally could give some good implications for patients who are old, who can be subjected for prostatectomy in a safe way. Majority patients are on aspirin. There wasn't a robust data on continuation of aspirin through the surgery when we pulled out the data across, and that's the way of getting a research done in a select group of patients. Try and look into your own data. Try and see what you have the maximum in maximum numbers or maximum capacity. Like I said, lymph node positive data. Being in Indian cohort of patients, we have a lot of patients who have aggressive disease. So a good collaboration on lymph node positive data can come from this particular belt, and unfortunately may not come up in a big way now from the Western countries. All of us will admit that, because the disease there is all screen detected and you do not have that many node positive patients. So we could pull out the data of 100 node positive patients to give a scoring system to give us the implications on adjuvant or salvage radiation settings. So a good collaboration has to happen. I will probably end it here with a note that the ultimate future lies in these two questions, especially for prostate cancer. Is cure necessary when possible, and is cure possible when necessary? That's an aphorism given by Professor Whitmore. So I think if you just sit down with these two questions in mind, there will be probably 10 futuristic ideas or research ideas which would pop into the mind, and those would be the way forward to monitor and refine in coming days forward. Thank you so much. Thank you for this opportunity.
So I would request Dr. Prokar and Dr. Tarun to please conduct the voting for this session.
So we have a set of 4 questions for this. The role of trimodality therapy for high risk and locally advanced prostate cancer. Do you agree, strongly agree, neutral, disagree, strongly disagree, and not my field? The impact of PET-guided management decisions on the management of prostate cancer. Genomic profiling of high-risk prostate cancer. And the last one is extreme hyperfractionation when delivering prostate plus pelvic lymph node irradiation. Thank you. Yeah, yes. All the voting is over. So I will just wrap it up. You want to say something? Please proceed.
Thank you so much for your participation. Ashwin, that was just terrific. Raj, you seem to have convinced people that survivorship is the way forward, and that patients and their doctors often have completely different perspectives. We hope you found this session interesting. In the afternoon, you can question the experts. So a number of us will be available to be grilled, and we can discuss more after lunch. Thank you so much for your participation.
So we'll break for lunch. We have finished a bit early, and we expect to start a bit early because people have flights to catch. So I would request you to be in the hall again, say after half an hour or so. Thank you so much. Thanks. And I would request you to please return the voting pads, or you can keep them on the table. We'll come and collect them. The voting pads, please. Thank you. and ablative therapies for prostate cancer, and we also have a genomic workshop in the first session. So for coordinating this particular session, may I have the pleasure of inviting Dr. Saurabh Vashish from the dais, please.
Yeah, good afternoon, everybody. So this is the next session regarding the prostate cancer, LAPC and oligometastatic. So first of all, I will like to call Dr. Sameer Trivedi and Dr. Aditya Pradhan to chair this session. Okay. So next, as an expert, I will like to call Dr. Prokar Das Gupta. Sir, please. Are you sure it's me? Yes, sir. This Dr. Arnav Stenzel, Dr. Venkatesh Krishnamurthy, Dr. Rishi Nair. Next, I would like to call Dr. Shyam Sundar, who is a radiotherapist. इनको बोल दो. You can sit on that side, yes. And Dr. Saurabh Kumar Mishra and Dr. Atul Batra. क्या कर रहे हैं? करण? दोबारा बोलो. Arun? So, as a first speaker, I will like to call Dr. Raghunath to discuss a case of locally advanced CA prostate.
Very good afternoon. Thank you, organizers, for this opportunity. May I request Dr. Stenzel to come on dais, on stage. So I request everyone to be alert post-lunch session and actively participate, because bulk of our clinical practice is locally advanced prostate cancer, unlike in the West. Okay, so we'll be speaking on locally advanced prostate cancer, and thank you organizers for this wonderful opportunity. So without wasting much time, I'm going to present a young gentleman, 58 years teacher, life expectancy of more than 15 years. Father is still alive, 89 years, and mother 84 years. Lower tract symptoms for 2 years on alpha blockers. PSA 16, and he has hypertension, managed with one drug, very well controlled, no family history of any malignancies. Rectal examination, hard bilobar prostate, suspicion of extraprostatic extension. MRI was done. All these guidelines and morning discussions, I don't want to get into all these things. MRI showed PIRAT 4 and 5 lesions on either side, and right neurovascular bundle and seminal vesicles were involved. One doubtful enlarged node on the right side obturator group of lymph node, 0.9 to 0.7 centimeters. Biopsy was done, showed adenocarcinoma, Gleason 4+5, no ductal carcinoma was present. 13 out of 16 cores were present. My question to Dr. Prokar, do you suggest IHC in these patients?
You mean immunohistochemistry?
Immunohistochemistry, yes.
Thank you. No, my index pathologist would only do immunohistochemistry if the diagnosis to him was unclear. So for me, the answer is no.
Okay. So next diagnostic pathway is obviously PET scan. Again, I will not dwell into this. When do you do the scan after biopsy? Biopsy has been done today. You got the report tomorrow or day after tomorrow. So are you going to wait, or because there is a node?
Right. No, I wouldn't wait. I would go ahead with the...
Okay. So PSMA PET scan showed PSMA avidity in both the lobes with SUV of 19, and again, right neurovascular bundle infiltration and seminal vesicle infiltration was present. And right obturator lymph node, which is about 1 centimeter, and SUV of 7. So this is T3B, N1 and M0 disease. Do you all agree with me?
Yeah.
Yeah. So you don't need any more investigation, because
why is it N1 if the PSMA PET CTA is negative?
PSMA PET CT is showing SUVF7, right obturator lymph node is enlarged.
Oh, that's okay. I'm still not, this was done after the biopsy.
That's what I asked. When do you want to? I'll ask you the same question. When do you want to do the PSMA PET scan after biopsy?
Well, usually it takes me 2 to 3 weeks to get an appointment anyhow, because, you know, it's very popular now, and people feel well after PSMA PET CT. 3 weeks, that's fine.
Yeah.
And
in our clinical practice, we also do that. We generally wait for at least 10 days because we have seen PSMA uptake, mild uptake, maybe SUV of 3 or 4, and when we do lymphadenectomy, particularly targeting that, it used to come negative. So after that, we just wait. Okay. Sometimes after inflammation of the, in the prostate, some enlargement of the lymph nodes are expected. So we generally wait for 10 days. Okay. So is genetic testing required? If so, Dr. Stenzel, which genes? If family history is present, without family history of prostate cancer?
Well, the guidelines really say it's not genetic testing unless he has family history at the time of diagnosis. If he's getting castrate resistant, yes, or if there's any family history or any other adverse.
Okay, thank you. So this is locally advanced prostate cancer. How are you going to treat, Dr. Prokar?
This, I see what you have put up, but in the UK, this man would typically be discussed at a multidisciplinary team meeting, and the team would say that the standard of care here would be hormones and radiation for this patient. I accept he's 58. If there was a trial ongoing which randomized the patient to surgery versus radiation along with systemic therapy, which is not currently ongoing following the failure of the German trial to recruit and following the closure of Trombone in the UK, which only had bone metastases as an inclusion criteria, not lymph node metastases. So there's currently no trial in the UK.
Okay.
I do not think the MDT will allow me to operate on the patient. So I have certain restrictions. So that would be my recommendation to the patient.
So any role of neoadjuvant therapy, intense neoadjuvant therapy? Yes or no? Because we have shortage of time, I need to cover in another 9 minutes.
Not currently in my practice, although I have operated on these patients in Apollo in India, where by the time I arrived, they're already on intense hormonal therapy and anything else that you can think of, including ABI.
So just to think about these things, there is some data is there. Proteus trial is going on and Punch trial, docetaxel with ADT with hazard ratio of 0.61. 10 years overall survival was statistically significant with hazard ratio of 0.61. Again, pathological response after potent or intense neoadjuvant hormone therapy, the complete response was seen in around 10 to 12%, and minimal residual disease. Of course, this is only on 72 patients. Minimal residual, bulky disease has become minimal residual disease, which is defined as 0.5 less than 0.5 centimeter, which is seen in around 15%. Both put together around 25%. 1 in 4 would achieve complete response or minimal residual disease. What will happen to them at 3.4 months, 3.4 years, that is 40 months, there was no biochemical recurrence. Okay, these are early studies. Again, they don't progress at 40 months. And your thoughts on intense neoadjuvant therapy already discussed. EAU guidelines, again, strong recommendation for RP as a part of multimodality therapy, and you should always perform EPLND. So I would like to ask Dr. Shyam Sundar, how do you treat this patient?
Typically, sir, this patient has lower urinary tract symptoms.
No, you just tell what is your treatment. Would you like to go for ADT plus
ADT followed by radiation.
Okay. This is a systematic review from Stenzel's group. So this is your paper, okay, published in Urology International in 2017. You see here, role of RP plus RT in LAPC. It's a systematic review on meta-analysis. Impact of radical prostatectomy with or without adjuvant therapy, compared with other options where RP was not part of it. It is in favor of RP. Again, RP plus RT versus RP alone. It is in favor of combination therapy. This is another 2018 systematic review and meta-analysis where they compared radical prostatectomy plus radiotherapy versus ADT plus RT. RP plus RT patients were less likely to die of prostate cancer. That is the conclusion with respect to cancer-specific survival and overall survival. There is 15%, 10 years cancer-specific survival and overall survival was better in favor of combination therapy with RP plus RT. However, their erectile dysfunction was higher, urinary incontinence was higher, bladder neck stenosis and urethral strictures were higher. This is here data again. Men who received RP plus adjuvant RT were significantly less likely to die from prostate cancer and improved CSS and OS. I will not get into this again. This is another trial study. Again, they concluded RP is a part of multimodality therapy and EBRT gives almost same results. Okay, SPCG 15 is ongoing. We have to wait for the results. Okay, what are your thoughts on this? Now, I would like to ask you, Dr. Prokar, between these two, after understanding all these things, he's a young guy, life expectancy of more than 15 years. What would you suggest?
Look, if this man, 58, fit otherwise on a single drug, says to me in any part of the world saying, I would very much like you to operate on me, I would, of course, operate on him as part of a multimodal treatment. I have operated on some of these men who turned up yesterday. I can't tell them who they are, but they are alive a number of years later as part of triple therapy. So yes is the answer, but in the UK I can't.
Dr. Rishi, yes. You heard James Systems had come to your place recently. Yeah, please.
So my decision would typically would be dependent upon the MP-MRI findings. If the lesion is involving near the apex or involving the bladder neck area, then I won't generally venture into doing a surgery. But because otherwise the long-term survivals are almost equivalent in both the arms.
Thank you. So this is another paper published in BJUI in 2013, 10 years ago. The primary treatment of prostate improves local palliation in men who ultimately develop CRPC. Say for example, if you give ADT plus RT, at least some patients would develop metastatic disease at a later date, right? So 56% of them would have local problems. What are those local problems? Acute urinary retention requiring TURP, hydroureteronephrosis requiring stent placement, pelvic pain and clot evacuation. All these things were significantly less when you have done radical prostatectomy upfront. Okay? It may not add to cure rates, but definitely these local symptoms will be less if you have done radical prostatectomy when it was compared with RT versus no local treatment at all. So your thoughts on cytoreductive prostatectomy in bulky LAPC, Dr. Prokar?
I've done a number of these in India and other parts of the world. You have to choose the patient very carefully. Typically, from cohort studies, these patients are more incontinent. You have to tell them that. And I avoid operating on the patients, particularly with large apical tumors, because their risk of incontinence is higher. If they have a lot of disease outside the prostate, I also typically avoid operating on them unless there is good reason to do so, such as impending ureteric obstruction.
Dr. Guru, I have only 3 minutes.
I just want to ask a question. What is the thought process of every cytoreductive prostatectomy? I think people should seriously discuss this because I don't want people to walk away with the thought that this is standard of care. Can I just make a remark? I mean, if once you do consider surgery here, and as Prokar was saying, we should avoid any possible comorbidity. Now, the location of the tumor, if it's in the apical part, where you may have to really cut some of the sphincter, is definitely not a good option. And that is something where I would stay off.
Can you reduce the bulk of the disease at the apex by giving neoadjuvant therapy? Can you improve the continence outcomes? Is it possible?
You know, the neoadjuvant therapy, it has so far not shown that it alters the biology of the disease. It may alter your surgical, but then there is a problem. Because if you need that's like in radiation therapy, sorry about that, but they need the adjuvant hormonal therapy. And so we are in the same boat then. And that hormonal therapy, by the way, if you give it 2 to 3 years, I do not see any study where it shows that erectile dysfunction is worse in radical prostatectomy versus radiation.
Thank you. So which, in case if you are opting for radical prostatectomy in early diseases, obviously robotic is the choice. So there is some data published in 2012, radical prostatectomy by robotic versus open. The complications are significantly better in favor of robotic. Again, RERP resulted in significantly better continence recovery at 3 months compared to open, and recurrence-free survival is also better in favor of robotic versus open surgery. Dr. Shamsundar, how would you like to treat this patient? In case if he is going to recur at a later date, what are the chances of his recurrence? How are you going to manage?
Recurrence, sir. Local recurrence or?
Local recurrence or metastatic? What is the risk of local recurrence and metastatic?
The chances of local recurrence and metastatic are less, but if there is a local recurrence and if the time period is sufficient enough, like if it is more than 2 years or 3 years, then definitely we can try for brachytherapy as a salvage. If it is local recurrence without any systemic.
Okay. Dr. Venkatesh sir, how would you like to treat this patient?
You're talking of if there is recurrence or?
No, upfront.
Upfront, I would go ahead with the radical prostatectomy.
Radical prostatectomy, okay. Thank you. We have discussed about all these things. Some 8 seconds more is there. Thank you.
Now I would like to call Dr. Santosh Kumar to discuss second case.
Thank you very much. Yesterday I bombarded with a lot of literature. I am really sorry I had to do that. So as a compensation, no literature today. Everybody knows the guidelines. Everybody knows. So we want to see, we have practices from the NHS, which is like the government practice. We have practice from the German group. We have practice from the Academic Indian Center, AIIMS. We have a academic private center. I hope I had a real cutting private surgeon, could cut anything there. But Dr. Venkatesh, you can try to play that role. And we have, of course, radiation and medical oncology with us. I'll be dealing with the oligometastatic carcinoma prostate. So, first thing, let's go to the definition and we'll start with Dr. Prokar. So those issues are there. Number of metastases, 1, 3, 5. We'll just take these 3 numbers, your comment on that for the bone metastasis.
The lower the better.
Yes, sir?
The lower the better.
The lower the better, okay.
Yeah.
So you would consider all of them oligometastatic, the lower, the more happy you'll be.
Correct.
Fine. Dr. Arnav?
Yeah, it depends on what type of imaging you're doing. If you're doing a regular bone scan, then 2 to 3 is okay. If you do a PET scan, a PSMA PET scan, then you can go up to 5. If it's
axial versus appendicular, you think?
Sorry?
No. Axial bones versus appendicular bones?
Axial, well, in the axial, that includes the ribs. And the ribs is a problem. It's less the lymph nodes that can be false positive, but it's the ribs, especially in the F18 ligand, then you may have a problem with false positive ribs, especially if the rest of the axial is 0.
Lymph nodes, no issues anywhere. And non-visceral, everybody will reject. Anybody wants to take non-visceral? Okay. So non-visceral, everybody is very clear. Numbers, the lesser the better. Axial, nodes. So we'll go to the case. 60-year-old gentleman, poor flow with incomplete emptying. That's the situation in India, unless you have a poor flow, you don't get carcinoma prostate. You don't come normally with a healthy individual and have carcinoma prostate. Developed AUR a month back and was catheterized, hypertension on medication, otherwise ECOG 1, nothing else which was significant except that the DRE felt that it may be beyond the prostate, maybe seminal vesicles were involved or capsule was involved. Investigations, PSA 43. We do have patients presenting with a higher PSA here always, and TRUS biopsy 4+3, all codes are positive, 90% pattern 4. So that is the information we had. So somebody has done the PSMA finding a scan, subcentric left external iliac node, non-avid findings, sclerotic bone metastasis in left iliac bone. So radiologist did all the imaging he wanted, X-ray and CT, and he limited CT for that area, and he is very clear that this looks like a sclerotic lesion from a cancer prostate. If I was not given the PSMA, this would be a metastasis from the cancer. So now we come to that question. Dr. Prokar, what do you think? Radiologist otherwise feels it is cancer prostate, no history of trauma, no history of anything, sclerotic lesion, but PSMA non-avid.
I think based on the pro-PSMA study from Declan Murphy and his team from Australia, published in the Lancet, this patient should have a gallium PSMA PET scan.
Yeah, he had a gallium PSMA.
Yeah, because F18...
That says non-avid.
F18 is a disaster. So its PET scan is non-avid. Wow.
Yeah, PET is non-avid. The gallium 68 PET is non-avid. PSMA PET is non-avid.
So the iliac lesion doesn't shine up?
Doesn't shine up.
So what is it? Is it a bone island or what is it?
It doesn't look like a bone island. The radiologist is clear. It looks like a sclerotic process if I have not given the PSMA PET.
Look, the PSMA PET is not 100%. So if the radiologist feels that there is bone destruction, then it might be one of those
because
lesions.
Sclerotic lesion is there, and it is not like a very confined bone island type which has very clear margins.
So, look, you have
with
to,
this PSA being around 48 or something.
Yeah, you have to
You
assume
still consider
that
him as a
that it is a
oligometastatic. Any reference, Dr. Anol?
This case smells. And I don't think PSMA PET-CT would change my management. I would not touch him surgically. He has a PT3B, he has 43, he must have some lesions somewhere, if that is repeatedly 43. If he's a biker and he was on a biking holiday and came back, and then it may be that he has high PSA. But now, if you repeat it and it stays like that, I would get his bone alkaline phosphatase just to have a serological approval that something is happening in the bone. I wouldn't touch. The first case, I would have operated on. This one, no.
Okay, so PSMA PET would not change your management is what you have told. Rishi? India has too much of PSMA PET being done, more than Europe, more than America, more than the poorest country on the earth. We are doing PSMA PET because at places it's the cheapest investigation available. One shot investigation still cheaper than anything, cheaper than the CT. So we are blessed, How much does it cost? 8,000. Rishi?
So typically such a equivocal finding on a PSMA or we discuss it in our uroradiology meet, and typically what would be we advised by the radiologist would be MRI, a focused MRI for this, just to make sure that the lesion is metastatic or not. And then based on that we'll...
I think we will not discuss more on it. So we are clear. I think PSMA should not dictate change in the plan, though I know the pro-PSMA study will say around 27% patients it may alter the management. So now we assume that that was positive on the PSMA, and we go again, probably will be overlapping a little with the previous. One is Dr. Prokar, whether you'll do radical prostatectomy. It is T3 involving seminal vesicle or something, T3A or
The answer, very simple answer is I can't. I work in the NHS. This man will have hormone systemic treatment with hormones. He'll have a ARTA and he will have radiation to the prostate. And depending on what the radiologist says, he will probably have targeted radiation to that bone met.
So now radiation therapy, yeah.
Sure. So this
You'll
patient
be
will-
happy to provide radiation to the...
Yeah, we will start him on of hormone therapy and then radiation to the
So
primary.
you will give hormone and radiation together, wait 3 months, see the response, and then do a PSMA again and do radiation, or you will 3 months later straight away go for radiation?
No, we will start him with only hormone therapy first for about 3 months, and then if needed, we'll repeat the scan. And depending on how the metastasis has responded, if it has responded very well, then I can treat only the prostate, and I can keep the patient on
So,
follow.
Doctor,
Yeah. Systemic therapy would be ADT plus abiraterone either.
okay,
Such
we'll come to
patient-
that at the end. Okay,
Yeah.
so I'll
No,
ask
I
you
mean
the
just when we are
pointed
initiating
questions.
the therapy, I wanted
So,
to add on.
for radiation, definitely they will give. Surgery, I think in the previous case we already discussed about neoadjuvant radiation, hormonal therapy before surgery, so I will not go too much into it. Any difference, Dr. Anand? You happy with the radiation, and that's a part of the guideline, and you would not push anybody for surgery?
Sure. If we go on a PSMA PET-CT based imaging below 5 in the axial, yes. If he has more, then I don't think radiation would really help.
Okay. So not oligometastatic, no treatment to primary. Oligometastatic, treatment to primary, preferred radiation. Okay, those trials are there. Everybody knows them. We will not go to them. Same patient has retention of urine. Sir, we forget that part. We are assuming it is positive. That part, we would not go just by PSMA. We take the
Is
whole
there a case for a bone biopsy here? Because this is my question.
Okay. We are assuming it is positive, so we will not go into it. This patient comes with retention, has local symptoms. DRE is T4. Now forget the previous patient. I am showing this patient. This is the finding. Person doing the DRE felt that rectal wall is a bit abutting, and that is the MRI picture. Query T4. So anybody would like to do anything local treatment in this also after adjuvant, or again you will want to re-evaluate after adjuvant, or you say we will not do local treatment, or you will say as surgeons we know how to cure bladder outflow obstruction. Very simple. Do TURP. Not for cancer prostate, for him to pass urine. Yeah.
Now, if the PSA shows that there has been resolution, then response, then I would go ahead with TURP.
So in oligometastatic, you will avoid radiation also to a few individuals who have locally advanced disease.
No,
And
I'm a little confused. I'm presuming this is after the treatment. Or you're talking of before therapy, or I'm presuming that we've already been treated, that is systemic therapy, radiotherapy, and then he comes with retention.
No.
Okay.
This is a new patient.
Oh, no, then.
The local finding.
Okay, primary therapy.
Primary?
Yes.
So you will give hormones and then give radiation. Are you happy? Or
Yes, sir. We'll start off with hormone therapy, and then we will plan for radiation.
in presence of catheter retention, not passing urine, or locally infiltrated? Because my radiotherapist said that I am not sure whether I can spare the rectum and prevent dose to the rectum, and he will develop significant rectal symptoms, so I will withhold radiation for this individual unless he really shows good response.
Radiation will be not started at front. It will be hormone therapy which will be started. So hopefully the disease has to shrink. If it shrinks, then I think delivering radiation will not be a problem.
So I just wanted to bring the point across that though that says that radiation therapy could be the first, could be treatment of the local, you have to look at also the possibility of the complications of radiation therapy, and if it is very locally advanced and radiation is not possible without severe toxicity and big volume of the prostate, in that case you would treat it like malignant disease and not specifically treat the prostate also. I don't know if anybody differs. Yes, Dr. Stan.
I would suggest, in that case, based on the recent EMBARK results, you may go for a doublet, that is LHRH plus and one of the new hormonal agents. In that case, it was enzalutamide, which has shown in the metastatic disease, first thing has shown good results. And as our colleagues to the right just said, here abiraterone. But I would go for a doublet. And definitely do that before radiation, because radiation, this one sounds like it's going to be inflamed due to the catheter, and probably that was a reason for the AUR. And I'm not a radio-onc, but they tell me if there is inflammation and you irradiate, you just have a synergistic comorbidity.
Okay, I think I have only 2 minutes, so I'll very 2 quick questions to 2 individuals. First is to radiation. Metastasis-directed therapy. Will you give to all patients?
Only if,
you would
only if
treat it as a curative treatment, or you think it is only deferring the inevitable?
No. Usually, if it is limited disease, we will only treat the primary, and the metastasis only if it is symptomatic.
So, if there is one, you will not believe in?
Yes, if there is, even after the systemic therapy, if it is still persisting, then yes.
So, if a PSMA after systemic therapy 3 months later doesn't show uptake, that area you leave alone and just treat the primary?
We will keep it on follow. We will keep it on follow.
Okay. I think we come to the last question to the medical oncologist. Please don't feel left over. Please answer those questions. And you have 1 minute.
I think to begin with, it is a metastatic disease, so we can never feel left over. The only discussion here would be that, of course, we will treat with ADT and one of the newer ARSI.
So you will always add a newer
Absolutely.
ARSI
There is
or
an
AR.
overall survival benefit very, very clearly shown in the Latitude trial and the Stampede
But
trial.
they were not specific to oligometastatic disease. They were specific to metastatic
If you
disease.
look at the low risk, low volume disease, so this is basically a low volume disease, less than 3 sites of metastasis, showing 1 bony lesion. These patients benefited clearly with abiraterone.
The answer is directly ADT, you will give ARSI.
Absolutely. Yeah.
How long?
To continue, this is a metastatic disease. It will recur eventually, right? We hope that it doesn't, and in few patients we may see that it does not. But eventually, this is an M1 disease. We need to be sure when we are discussing
So
about
till it
the local
progresses,
therapies.
till the patient doesn't have money, till it has complications,
till
when
it
you will
is
have to stop,
tolerated well,
you will continue. Okay,
That
thank
is
you
the
very much,
standard
sir.
of care.
I think we will have to stop. So no literature review. Thank you.
So now I will like to call Dr. T.B. Yubraja to discuss the ablative therapies in LAPC. Ablative therapy.
Good afternoon. Thank you very much, Dr. Ghosh and Dr. Jindal, to invite me for this meeting. So sorry, we are going back now. We are going to the early cancers. The disclosure is that I am not expert in focal therapy, especially HIFU. Recently, we have started in our institute. We have just done around 6 cases. So Tarun has told me to give a brief overview or talk and followed by a case discussion. So I'll taking through the process of focal therapy in prostate cancer. So it's quite interesting. So it started way back in 2006 with a whole gland HIFU, and then the 2 important advances took place. One is MP-MRI in 2012 and the transperineal biopsy and a fusion biopsy. These 2 things completely changed the understanding of focal therapy for prostate cancer. So now, thanks to many trials like Precision trial, Promise trial, and so many trials which proved that the biopsy is very important. So finally, we know the disease exact location and exact the disease character. Based on that, parallelly the focal therapy is also evolved. So MP-MRI is the main game changer. Followed by now, we are going towards AI-generated image. There are already companies who can create an image, where to biopsy the lesion. You can see the picture. And thanks to the fusion biopsy, what we get with the MRI fusion biopsy, the exact location of the disease and we can make out. So you can see that the precision in MRI targeted biopsies, so fewer men needed biopsy, fewer biopsy cores are required to diagnose the case, more men with clinically significant cancer can be detected, and complication rates are quite low. So these are the advantages of having a MRI biopsy. So based on the precision trial and a promise trial, the simple flow chart is that MP-MRI for everyone before biopsy, and then targeted biopsy for only targeted biopsy. We need not do a systematic biopsy. Systematic biopsy for those with red flags where we expect some lesions outside the target lesion. Although we don't have enough literature for a targeted biopsy, I think in the next couple of months, an article from Mark Emberton, he told, when I went to London, he told that the paper is ready for publication for targeted biopsy alone. So because of this, the ablation of the gland has, the idea of focal ablation has improved. What exactly is a focal therapy? It is ablation of an image-guided biopsy-confirmed cancerous lesion with a safety margin. What is the margin? So generally 0.5 centimeter to 1 centimeter the margin. So the goal is to reduce the side effects of the treatment what we generally as a standard we use and maintaining the disease control. What are the indications for local therapy? There are so many, but generally they are all unilateral. Typically the lesion should be lesions go 3, that is favorable intermediate risk group. These are the commonest group. And the next commonest group is 3+3 low risk, although the patient goes for active surveillance. Many people with a high PSA density, high volume of disease, or patients are not ready to accept active surveillance will be opting for focal ablation. In lesion group 4+3, very rarely we have to use it. So small lesion, not willing for surgery or any the whole gland therapy. So usually the focal therapy is good when the disease is in the posterior lesion in the mid gland. PSA less than 10, now it is expanded to less than 20. And should we have an opportunity to give a margin? If it is very near to the urethra, it is difficult to do that because urethra will get ablated. And these are the indication for focal therapy. And it's important is that there is a concept called as target lesion. So we know that only one lesion is very important in the entire process, although there is multicentric. All other lesions will be very small if it is less than 5 millimeter. And if the lesions are 3+3 score, no need not receive any treatment. Although it is multifocal, it is like a very a latent or a innocent cancer there. So focal therapy is a necessary and a legitimate response to change in the management pathway. In one side, we have a radical treatment where we have certainty of cancer control, but problems are there with incontinence, impotence, rectal toxicity, and etc., etc. Similarly, we have active surveillance where the patient have very low side effects, but there is a cancer progression, psychological burden, surveillance burden. So focal therapy fits in between these two, where we have neither too aggressive or not too conservative. So even if you see active surveillance, if you see the red one, the patient have decided, almost at the end of 15 years, 40% of the patients have progressed. And if you see the violet one, although there is no progression, patient because of the psychological issue converted into a treatment. That means almost 50 to 60% of active surveillance patients undergo treatment eventually. So it may not be its active surveillance, always it should be accepted. The range of technology are capable. How to destroy the tissue, focal therapy. There are many energy sources. So generally either direct energy source with a temperature, cryo or nano. Or we have an indirect one, HIFU. It is an indirect one, we don't put anything inside the prostate. So then we have nano knife, brachytherapy is coming in a big way, focal brachytherapy and etc., etc. There are so many articles which supports this type of energy ablation. Finally, factors influencing the oncological efficacy depends on the energy source we use, tumor size, location, gland size, disease focality. In other words, the case selection is the most important. Not all the energy source fit into one patient. No, it's not possible in that way. So how do we ablate the tumor? So earlier it was a whole gland ablation when it started in 2006. India also they did it in a few cases in Mumbai. Out of 10 patients, almost 2 patients got fistula, 1 patient died of sepsis. So that time it was a blanket statement, HIFU is not good. I think over almost 1.5 decades, there is 11th generation software and 3rd generation hardware. I think completely it has changed the understanding. Now we can ablate only the tumor. You need not ablate the gland at all. This is called as focal ablation or a lesion ablation. Or we have a hemi-ablation like this. Or we have a hockey stick, although it may be hockey stick down or up, but not usually done. But the whole gland ablation or what we call a subtotal ablation is also possible now, although it is not done nowadays. The reason is that the ablation is so accurate that we need not go outside the capsule of the prostate. That is because of the good MP-MRI. So now, when we have a different energy sources, is it only one energy sources is sufficient? Generally, when I spoke to focal ablative surgeons, they say that minimum 2 you have, so that all the lesions can be covered. Generally, if the lesion is in the anterior lesion, anterior lobe, cryotherapy or a nanoknife is better. All other lesions, posterior lesions, are good for HIFU. Even apical lesions, none of them is good. Apical lesions, usually they prefer to do surgery. So this is very important, because you cannot apply everything. And if the gland size is more, you cannot do HIFU, because the focal length is only 4 centimeter. Beyond that, it cannot. So it cannot reach the lesion. So HIFU is a versatile and a precise technology for focal ablation. And the reason is that it is a choice of plan. Margins you can give, very good margin, accurate margins, overlapping the ablation, and second tap and repeat. We can repeat the same HIFU in the same site in future if the patient recurs. These are the advantages of HIFU. And how does exactly it happens? The machine which goes into the rectum, the probe, it has got 2 transducers, one for the scanning, one for the energy delivery. And with that, we can control clearly the exact location, and also we can real-time analyze exactly whether we are doing properly or not with the color signals. So what is not suitable? Definitely would be better with the radical therapy, not suitable, and does not accept the concept of focal therapy, they are not suitable. Or if the patient has got more than 80 ml, or intraprostatic calcification is a contraindication for HIFU, because it scatters the ultrasound waves and the energy source will not be delivered. Sometimes if it scatters back to the rectal wall, rectal wall can be injured. Previous brachytherapy very difficult. Naturally, UTI and limited life expectancy are the contraindications. So how do they do the procedure? Before the procedure, consent and bowel preparation is not required. We just give enema 2 hours before. Stockings and treatment planning is very important. MRI is very important before doing any focal therapy. And a urethral catheter we always put before the procedure. And the important, during the procedure, it is a complete GA procedure. For 2 hours, patient is not supposed to move. So complete anesthesia and paralysis. And no nitrous oxide, because it causes bubbles in the prostate, it scatters the ultrasound waves. That the normal antibiotics and all those things will be given. Post-operatively, there is the discharge will be on the same day or the next day. Antibiotics, anesthetics for a couple of days. Catheter is generally removed after 3 to 5 days. We keep it for 5 days. Complications, these are the most talked about. Usually there is a very minor complication like LUTS patient may develop. They are easily treated with alpha blockers. UTI can happen if there is an undetected UTI beforehand. Rectal injury, which was very, very common, now it is 0.1 to 0.01%. That means usually these are all salvage cases where already radiation, the patient has received some other cryotherapy and we are doing HIFU, then only rectal injury is common. So when I ask the expert, they say that you cannot injure rectum in HIFU unless you want to injure it. Because if you don't want to injure, you will be far away from that. Or your technique is not good. It's like robotic surgery. We don't want to injure the rectum, but if your technique is wrong, you are going to injure the rectum. And erections, usually if you include the posterior lateral, then it's an issue. Incontinence is very, very rare. And all other things, even a redo focal treatment is around 10 to 15%, it is doable. So how do we do that? We divide the gland into anterior, middle and posterior segment, 1, 2, 3 are called zone 1, 2, 3. And each, the energy delivery is like a grain of rice. That's all the energy area, and that is the exact amount of energy at a time and in an overlapping manner. If you see a small video on this, you can understand it. So this is the probe which goes inside the rectum. You can see the patient is in the lithotomy position. Yeah. So there is a coolant around the ultrasound probes to cool the air, because it generates heat. If you can see, the probe goes with a stepper here, and the probe goes and everything is static. And once it is inside, then we scan it. We scan the prostate, and both in sagittal way as well as in both in sagittal and axial films. And then we identify the lesion. Once I identify lesion, so it is completely targeting the zone, which zone to be done, and you can fuse the MRI fusion image with this HIFU so that we know exactly where to ablate. So this is the information which we got in the screen, and then we mark where to serve. You can see here, these are the red dots where we are going to give the ablation. So you can extend even with, if there's, so you can see that everything only is confined to the capsule. It's not outside the capsule. So it is so accurate so that you can't injure anything outside the capsule. So once it is done, then the every movement, it goes anterior posteriorly and zone 1, zone 2, zone 3, 3 times. It takes time. The ablation time is only 10 minutes to 10 to 15 minutes for one zone, but the entire procedure takes around 2 hours because you have to really plan it every time when we do the zonal ablation. So this is how it represents in the picture. So finally the entire prostate is ablated. This is how the picture representation of this one. So do we have proof for this? So do we have so many articles which have come? So especially from UK, Dr. Hash Ahmed and Mark Humbert, these are the two stalwarts. And if you can see here is the initial paper, Lancet Oncology 2012. The continence and the erection rates are almost to the tune of 95%. So unlikely you have any side effects. 89% of men will achieve trifecta after HIFU therapy. And we don't have a randomized trial, although they are being done now. But if you see any propensity score match which is near to that, so you can see here no clinically relevant difference in cancer control at the end of 7 years when we do HIFU or any focal ablation versus a radical treatment. And then we have another study from Dr. Taimur Shah, again from UK, and it also shows that the failure-free survival is almost the same whether you do HIFU cryo or compared with a robotic prostatectomy. That means for a section of patients, so this is a very good treatment to be offered. And these are the latest publication involving large number of patients in different journals, including almost varying from 100 to 1,000 patients. All of them, without doubt, have only one, this thing that the side effects that are very, very uncommon, and the oncological outcomes are equal to any other aggressive therapy. So these are the outcomes if you can see. If you put everything put together, 98% the continence, 85 to 90% sexual function in almost all the trials. And the HIFU company has got a registry at 1,317. It's a continuous process. If you see metastatic free survival at the end of 7 years was almost 100%. And the failure of free survival, that means involving a second treatment is around 10 to 20%. Adverse events are only 0.5%. It's a continuous process. All the focal ablative surgeons, do this data collection. So this is an RCT not yet published. When I attended a Chicago meeting in focal therapy last week, 15 days back, so this was presented as a in the conference. If you see, this is a randomized between HIFU and radical prostatectomy. Incontinence 6% in HIFU, RARP 42%, impotence 9% in HIFU, and RARP 74%. So he's very clear. This is a randomized study yet to publish. There is one more trial, PART trial. So this trial actually had a very lot of expectation, but when they started, the people are, they are unable to randomize the patients because 70 to 80% of patients were choosing only the focal therapy, not the radical therapy. That's the reason they were unable to do it. Even when they took radical therapy, 60% of the patient converted into focal therapy before they went into randomization from the initial visit. So that is the reason they told that they may have to discontinue this trial. But there is another trial, not comparing with surgery, but we comparing with hormonal therapy. You can see focal treatment alone, plus or minus finasteride, plus or minus bicalutamide. So we have to do the trials like this, like radiation oncology does, radiation with ADT or without ADT, but not against surgery. So we think that is better. That's how the same thing we are doing it now in HIFU. So follow-up, how to do follow-up after HIFU? Usually PSA doesn't come to a negligible level like radiation or a radical surgery. PSA expected decline in PSA is around 70 to 80%. That is considered as a good treatment. And we do repeat PSA every 3 months, but MRI will be repeated either 6 months or 1 year, biopsy at 1 year. So usually because this is done in a clinical registry setting, so we have to do biopsy after 1 year to prove that our treatment is over, and redo biopsy depending upon the MRI findings. So suppose if there is a recurrence, what are the types of recurrence? We have an in-field recurrence, so it may be due to technical failure, or some tumors may be resistant to ablation. So you can plan for repeat ablation or a surgery. Out of field recurrence, we can do ablation because there is one more tumor has come up, or we can go for radical therapy. So the beauty of HIFU is that all the treatments are open. And when I spoke to the experts again about the surgery after focal therapy or HIFU, they said that in the era of whole gland ablation it was difficult. Now it is focal ablation, very precise inside the capsule, there is no problem at all. Although it will be little difficult than a normal surgery, so it is not as difficult as actually they said as a radiation therapy or a brachytherapy. So focal therapy is not a challenge to any radical therapy, it is complementary. We are going to choose patients in between active surveillance and a radical therapy, and where we put a focal therapy depending upon the disease severity. What does the EU guidelines says that only offer focal therapy, because now randomized trials results has to be out to get into a complete recommendation. So now it has to be done in a clinical trial or a prospective registry. So we have registry for all the cancers in our hospital. So we have to do this, the outcomes every now and then to the ethics committee. So what does the public survey in 2012 published in European Oncology 2020, what does it say? The percentage of people choosing prostatectomy is reduced by 7.2%. Cryotherapy by 9.9%, but active surveillance is increased by 14%. And HIFU or nanofocal therapy is increased by 27%. That means people are opting for this treatment because it is very attractive with very less number of complications. So I think the summary says that it has emerged as a new class of therapy in an indicated patient, and JAMA Surgery 2021 says that the routine application and a broader acceptance of minimally invasive focal therapy within next years will be very, very acceptable. It is going to become very routine. Thank you so much. And we will go to the case discussion. There is one case, small case discussion for the panelist. So 60-year-old male with LUTS since 10 years, routine health checkup, raised PSA, DRE, there is no, grade 2 prostate, there is no nodularity, his SHIM score is normal, PSA is 4.5, generally we repeat PSA after a couple of weeks, it also came as 5.25. So what is the next investigation we do, Dr. Rishi Nair? So PSA is 5.5, so what investigation generally you will do it?
So the next would be doing a MPMRI.
MPMRI. I think all of us understand it. MRI, so earlier we never used to do it, but now MRI is the standard one. So MRI showed pyrite 4 lesion on the left side. You can see the peripheral zone. So again, I was just talking to Dr. Manohar. Every urologist now, like CT scan, what we used to read for renal cancer, we have to learn how to read MRI scan. Because MRI, when it comes to urology, we should no, let the radiologist. But we have to, they will report it, but you have to cross check because you are the treating physician. So this is the pyrite 4 lesion, no extracapsular extension. So what is the next investigation you will do? Yeah, Rishi, you can go ahead.
Yes, so now this lesion warrants a biopsy, which would I would do is a standard 12 core along with the targeted course.
Fine. Dr. Senzel, so do you do a routine biopsy or a targeted biopsy or a fusion biopsy, or you do a transplant? What is your choice of biopsy in this patient?
Absolutely, fusion biopsy, using a navigated biopsy device as well.
Thank you. Dr. Dasgupta. Sir, in UK, how much percentage of the patients undergo transperineal versus transrectal and fusion versus non-fusion?
The majority are undergoing non-fusion transperineal biopsy with some kind of fixating device, usually precision point. You saw earlier the paper on Trexit, just to taunt Brexit, which was an absolute disaster for the UK. Oh, sorry, I'm not political. In the UK, we've almost killed TRUST biopsies, although there is a randomized control trial driven by Leeds, which is currently Leeds and Oxford, which is randomizing to TRUST versus transperineal.
Fine. So now we accept that at least we have to do transperineal biopsy. We have to move towards transperineal biopsy. Few centers in India that are doing it, I think moving towards that. The cost is...
2 centers?
No, in Bangalore there are 2 and we are starting from next week.
Okay, wonderful.
So the biopsy report came as 3 plus 4, 7, lesions grade 2, 2 core positive in the right. Actually it was a left one, sorry. And 45% of one core and 75% of another core. 1 of 2 targeted biopsies showed 80% of involvement. So how to risk stratify this, Rishi? So whenever we see the patient, we generally put into some risk category so that our further management will be planned. Sorry, medical oncologist, I don't have any question for you.
So it is a favorable intermediate risk as per the standard.
It's a low risk
EAU classification.
Or an intermediate risk, but favorable situation. Yes. Because it is a Gleason group 2. Fine. So is the PSMA PET indicated, Dr. Dasgupta?
I wouldn't waste time doing a PSMA PET on this man.
You don't want to do it, right? Fine.
Not at all.
Yeah. So anyhow, this in India, everybody gets it done, whether we tell or not. So this patient got it done and it showed no metastasis at all, as expected. What are the treatment options for this patient? Favorable, Gleason group 2, Dr. Dasgupta, you can tell. If the patient comes to your clinic, what is that you are going to advise?
This patient would be counseled as per NICE guidance. All options would be available to him. He's a fit man, he's young. I wouldn't personally advise him towards active monitoring because he has enough 4 in the 3+4. So all other options would be available to him. If he can't live with this disease in his head, then the only way to treat it, and this is one thing I keep saying, if the man cannot live with it inside his head, do not ignore that decision. The only way then to treat the man is to take it out unless he was completely unfit. Otherwise, all other ablative and radiation therapies would be available.
Fine. Dr. Stenzel, so do you advise active surveillance for this patient with a Gleason group 2?
Yeah, there's same thing. Everything, he's all options. I always tell the patients, he was 60, so he has a 20 to 25 year life expectancy. For me, MRI, I'm favoring MRI, but MRI, at least 20% do not show lesions. And those lesions may be on the contralateral side. So in addition, there may be new tumors popping up on the non-treated side. So I always keep telling the patients as well, so that if you want to make sure, either wait or then if treatment, do it the right way.
Fine. So finally, it is the patient decision. Dr. Khurshid Guru, you can give your opinion. Suppose if the same patient comes to you, so now we have so many options available. So finally, it is patient decision. But what is your treatment you feel that it is good for him?
There's data shown that 3+4 Gleason grade 2, you have one core with 80%. A lot of people would basically sit on active surveillance to favor this. But I think I agree with my colleagues here. If it is in their head and they're worried about it, then radical prostatectomy. I personally wouldn't favor radiation because he's young and he has 25 years to live.
Fine. So what about precision prostatectomy?
I think we should have asked Dr. Menon yesterday about that. He would have said yes. But no, I don't think so. I personally don't agree with that.
Okay, fine.
I would totally disagree with the statement. Sorry, Khurshid, we are friends. I would totally disagree with the statement because he's young, he should have radiation. I think it's the opposite. Because he has 20 to 25 years to live, and the chance of a new tumor popping up is much higher than if he will be older. That would be...
Would you give radiation or no?
No. I would go for a surgery.
Yeah, that's what he said.
Oh, I misunderstood.
Okay, then anyhow, radiation therapist is there. So do you want to give radiation for this patient? We'll ask the expert only.
Yeah, all the options are available. So explaining the pros and cons, if the patient is okay with it, then I think SBRT will be a good option in this patient. Rather than radical, full course radiation. SBRT 5 days.
No. Technically we can give. For all prostate we can give. But whether this patient is a very low risk patient, like, or in a early intermediate risk, so do you advise in a young patient to undergo radiation for this?
Again, as per the data which is available, I think there is not much to choose from in terms of outcomes.
If it comes to you, you will give radiation.
I will give radiation.
So, sir, any role of focal therapy now? So, if the patient says that I want to preserve any ischemic core is normal.
If the patient wants focal therapy, is perfectly entitled to it. He would do equally well. There is now enough long-term data to show some confidence. The patient will be told that there's a 20% chance he will need a second treatment. I wouldn't do it myself. I would send it to Hash Ahmed.
Yeah.
Our own center data from Declan Cahill using focal therapy was a disaster. So we gave up doing focal. But that was mainly driven by wrong patient selection, I believe. And Declan accepts this himself, despite the disastrous paper in the BJUI. We are about to start a new kind of focal therapy, which another one of my colleagues is going to start as an ideal stage 1-2A study called profocal therapy, which unlike HIFU and nano and cryo can target all areas of the prostate. So absolutely today, if he wanted focal therapy, I would send him to HASH.
Thank you. So the take-home message is that you have to identify the patient who are useful. Number one, that is most important. And I think the high volume, so generally when they say HIFU, they say that you put the machine and you go and just relax. No, this is a treatment where constant vigilance is required, even not like surgery. That's what I felt, because even one small mistake, it is in the rectum. So we have to be very, very careful. Yes, sir.
Yeah, I think I agree, but what I would say is focal would fit in where I think Prokar is saying it's in the head. He wants some kind of treatment to make him kind of bridge the gap. Otherwise, active surveillance is also very good.
You know, some time ago, about I think 8 or 10 years ago, we had MR HIFU at our institution, and that was for the whole gland treatment. The results were awful, and all those patients had to have suprapubics, and ultimately, I'm so glad it was used just for total benign gland treatment. So yeah, this makes more sense than MR HIFU.
So another reason why the failure rates were high in few centers were that it was done by a radiologist.
Well, in our center, it was done by a highly experienced prostate surgeon who took it on despite being a highly experienced laparoscopic surgeon. Focal therapy also wasn't helped when this trial that you're about to show came out, because in the lay press, while they did not declare any rectal fistulae, a patient publicly said, I am a colleague, I am one of 2 patients with a fistula. And this went absolutely viral.
Yeah.
It destroyed the
image,
opportunity and the debate of the public driven by what happened in the press. But now I think a number of years down the line, we can be reasonably happy that the follow-up has been done properly in a registry.
Yeah, that is true. I think, again, it comes back to the same technique, the same amount of rectal fistula even a brachytherapy person has. In fact, it's more than this. So I think these are the questions regarding HIFU. I can go through a little faster. Time interval of HIFU after biopsy is 4 weeks. After surgery, like TURP or HOLEP, is 3 to 6 months. So that's generally the wait. Perioptic IV, already indication and contraindication, we discussed about that. It's a daycare admission. So, otherwise I think we covered almost all these questions in the talk itself. So, as I told you, so MRI guided focal ultrasound therapy is coming. There are so many energy sources are coming up now. You can't imagine. So now there is one small MRI machine inside the theater where the patient goes inside and we give a transurethral ultrasound therapy. Transurethral, TULSA. So that is, in the theater we have MRI as well as MRI guided ablation of the tumor transurethral, not even rectally. So there are so many, the energy sources are coming up in future. So I think guidelines we already know. Thank you so much for your patience. I think we finished in time. Thank you.
Yeah, thank you so much. So now the next session is on the cancer genetics, and for that I will like to call Dr. Mithwa Ghosh. Dr. Sambit Mohanty, Dr. Upasna, Dr. Amlesh Seth, and Dr. Khurshid Guru.
May I invite Dr. Mithwa to introduce this section and proceed with the presentations.
Thank you so much to the organizing committee, to Dr. Amit Ghosh and others for inviting us and giving us an opportunity to do this session. So basically we did this session on 23rd also, and many of you were there in that session. So I really apologize if some of the slides are repetition. but we'll try to make it more interactive since we have esteemed panelists here. So here the whole intention is to go a little basic and down the roller coaster, because we have talked about surgery, we have talked about all different type of therapies, and I will start with what my previous speaker stopped with. He said that we have to identify the patient properly and understand what type of therapy the patient needs, right? When it is therapy, it could be chemo, radiation, hormonal, or any type of radiation or anything. So I'll start this session with a little introduction of genomics in uro-oncology. Where are we? I would just try not to make it very boring and basic, but rather focus on how a case has to be interpreted when there's a genomics report and how a report is interpreted. Dr. Sambit has to leave and catch a flight, so I'll request Dr. Sambit to present some of the cases. And then finally, I'll request Upasana to talk about, does genetic counseling play a role when we talk about genomics? So generally, and then we have a concluding remark, and I would request the panelists to talk that should genomics be the standard of care in clinical practice. So basically, when we talk about genomics, we always talk about, testing BRCA or doing a hereditary cancer panel and so on and so forth. But actually, I want to present here that it is beyond that. There are many more other tests or many other genetic parameters which need to be tested when we talk about genomics. And like all other cancers in urologic cancers, which encompass bladder, prostate, kidney, and testicular cancers, we all know that they affect millions of individuals worldwide, and they present a unique challenge for both patients and clinicians and healthcare providers. Early detection, these are some of the milestones in cancer treatment. Early detection of this cancer or this symptoms is very important. Once you have detected, to understand the biology or the subtype is very important, so that you can decide, so you can identify the patient and decide on the right treatment. And then you have to follow up your patient to understand whether they are responding or not responding. If responding, well and good. If not responding, what needs to be done, how the treatment has to be changed. Your deliverables are better prognosis, good quality of life, improved survival, and naturally when I talk about improved survival, it should have a better quality of life. The challenges which clinicians face, and along with we the lab people face who design all these tests for patients, is the tumor heterogeneity. As we all know, cancer is a heterogeneous disease. There is inter and intertumoral heterogeneity. No two patients are same, no two tumors are same. If a patient has a primary tumor which has metastasized to some other organ, or two synchronous tumors, those two tumors are different. Genetically, they are different. There is microenvironment which is different in different cancers, and then there is a metastasis. Luckily in prostate and all, there's organ-specific metastasis is very limited, but other cancers have different diverse type of organ-specific metastasis. So what's going on? How do we understand the story behind the story? Also, the major challenge is cancer is genetic. There are a lot of genetic alterations in a patient. We all know the adult cancers have more genetic alteration than a pediatric cancer, and the solid tumors have more alterations than the liquid tumor. These mutations or these genetic alterations can be of two types. We generally discuss and talk about germline or inherited like BRCA and so, which are present in the germ cells. But more than that, there is some other genetic alterations which are very important, which are somatic and sporadic. These are the mutations which are, or genetic alterations which are acquired over a lifetime because of multiple factors. It could be epigenetic factors, it could be a carcinogens, X-rays, different type of rays, etc. and etc. Now the question is, are all these mutations important? No. All these mutations, all these genetic alterations are not important. The alterations which drive the disease are important, and these are called driver. These are called drivers, like when you're driving a car, you are the most important person. There are some passenger mutations which are quiet or quiescent today, which are not driving the disease, but it's very important to know about them, because this quiescent or these passenger mutations could be driver tomorrow and may be driving the disease or causing some other resistance mechanism which we need to know. Now the question is, are all the driver mutations important? No, all the driver mutations are not important. The mutations are genetic alterations for which, and these are called actionable, for which some action is there. And this is my focus of this talk today. We want to understand those actionable mutations for which a US FDA approved drug is available, therapy is available for the tumor that you are treating, or for some other tumors from where the drug can be repurposed, or a clinical trial is available which is US FDA approved, and from which you can take the idea, you can do your investigator-initiated trials, or you can refer your patient to that specific trial if the patient has that mutations on which the trial is ongoing. So now the earlier era, the traditional way of treating was very anatomical, based on anatomy, which then changed or transformed into histological, and now it is more of molecular or genetic based. The organ specific is no more organ specific, it's more of a molecular, it's more of a genetic based treatment, which we call genomic medicine, and the study is called genomics. And why it is important? It is important for personalized or individualized medicine. Now, what is personalized medicine? It's very simple. The power in the precision of personalized medicine is to tell the patient, to tell the clinician, to tell the healthcare providers, and definitely to tell the payers, the insurance provider, that this drug or therapy is not for everyone. It is for the patient who has a genetic alteration that therapy should work. That is, it's for you. And it is also to say what is definitely not for the patient. If you know the patient has a genetic alteration against which some drug will not work, why do you want to waste the time and money, to give those drugs which will ultimately show a resistance mechanism? And I feel this is exceedingly powerful and groundbreaking approach. Again, if you see the numbers, why we should do genomics, why we should put more emphasis on genomics, because if you see the number now, in the market there are more than 1,000 drugs available which are biomarker driven, genetic alteration driven. More than 50% of therapeutics in the development pipeline are also linked to biomarker. More than 1,000 ongoing clinical trials are going on all over the world which are based on genetic markers. More than 50 FDA, actually more than 100 FDA approved cancer therapies are available. There are pan-cancer biomarkers. You might be familiar with this. Most of the time, now immunotherapy is a buzzword. We use immunotherapy for urothelial cancer, for many other cancers. Now, would you give immunotherapy as blinded immunotherapy? No, we need to have some markers. And MSI, microsatellite instability, tumor mutation burden, PD-L1, these are some of the immunotherapy markers which are called as pan-cancer biomarkers, because recently FDA has, not recently, I would say 2-3 years back, FDA has approved immunotherapy, pembrolizumab and atezolizumab for this pan-cancer biomarkers. So these are called pan-cancer biomarkers. And then there are many molecular signatures. For example, when you talk about prostate, BRCA, somatic BRCA or germline BRCA, and homologous recombination repair genes, HRR, are very common, which has not only a potential to stratify the risk of the patient and the family members, but also has a potential of using a targeted therapy called PARP inhibitors or platinum. So these are called molecular signature or genetic signature. So I think I have answered your question why genomics should be done for indolent, for curable, or for the metastatic cancers. So what we do in our lab, or I belong to a hospital called Healthcare Global Enterprises in Bangalore, and I have my own lab there where I run molecular diagnostics and genomics. What we do is for every patient, we try to do a somatic mutation testing as well as a germline mutation testing, which includes a comprehensive gene panel. Now this data, definitely I'm not a medical doctor, but this data is provided to the clinician. And the most important thing what we have is the tumor boards and multidisciplinary clinic. It's very important, and where there is a collation of idea from radiation, surgical, medical oncologist, molecular biologist, geneticist, as well as pathologists, to understand the biology and pathology of the disease and the molecular makeup of the disease. Based on this, therapy is decided. So naturally, genomics in urologic cancer, there are multiple. There's germline, there's somatic. It can be done from tissues, it can be done from blood sample, which is called liquid biopsy. Now How we do the test, there has been a lot of evolution. The tests which were single gene testing now has become to multi-gene testing and comprehensive genomic profiling, where actually we test for everything, every marker, and give a comprehensive report to the doctor. Because, tissue is even if you do a prostate biopsy, sometimes the biopsy is so small, after one test, the biopsy gets depleted. So we try to do a test which will be very, very comprehensive from a small tissue, which gives a comprehensive report. So this is what we do. We do a comprehensive genomic profiling where we have 523 genes, along with tumor mutation burden and MSI, as well as somatic BRCA and HRR. And this has 100% coverage of ESMO and NCCN guideline. How it helps? It helps in getting novel biomarkers, the known biomarkers, the mutational signatures as TMB, MSI, HRR, the resistance biomarkers. I would like to add a point here. We have done almost 100 prostate cancer patients, and these are all Indian cohort. 33% of our prostate cancer has some or the other alteration in androgen receptor pathway. Either it is AR splice variant or AR mutation or AR amplification. We all know having an AR resistant pathway might not be responsive to the hormonal therapy. So what we need to do is change the therapy at that point where there is a AR fusion or AR alterations. So I'll not get into all this. With this, we just come to some of the cancers, and I would request Dr. Sambit to talk about renal and the bladder cancer, what molecular biology or what genomic testing we do, and what is the result. Dr. Sambit, over to you, please.
Good afternoon. So thank you, Dr. Mutia. So we thought I was thinking to cover both kidney and bladder together, but that would be too much. And bladder, we are still at a very beginning stage of luminal basal double negative at the TP53 tribe. So I thought let's play with some of the kidney tumors. Yesterday we had a lot of discussion on the small kidney tumors and when do we do genomics. And I'll be specifically confined to the non-clear cell categories. With a little homogeneous and small tumors, do we need to, and these are the cases from my own consult. So as you all know, like the 5th edition, where I was very directly involved in the molecularly defined, I basically worked with 3 of my friends to complete your chapters, and Santosh is not here, he's also in the editorial board. So we basically tried to look more into this time. It took us almost 2 years to find out, to work on the pink tumors of the kidney, which is basically the molecularly defined tumors, and come up with a lot of terminologies. And majority of these, this time the 5th edition of WHO, which is very different from the 2016 WHO and the 4th edition, it is more molecular along with the phenotype, just not the phenotypic cell-based classification. So the kidney tumor, if you talk about these red ones, there is no, I mean, yesterday there was a talk on grading of the tumor. Ferment grading we are not using. We have an ISUB WHO grading. And we do not, no more we call it as a papillary type 1 or a type 2 tumor. Type 1 is basically a prototype, and type 2 is very, very heterogeneous. And similarly, the pink tumors of the kidney, the oncocytomas and other oncocytic tumors. So from a very morphology-based classification of pink versus white, we are into a more molecularly defined classification of the kidneys, so which I'm going to go over the cases. And as you all know, clear cell papillorenal cell carcinoma of the 2016 is now a clear cell papillorenal cell tumor because none of the cases in the last 11 years has undergone metastasis. And there is nothing called papillary type 2 RCC. It is a papillorenal cell carcinoma with type 2 histology, which needs multiple workup to come up. So, and this is, I think Upashana is going to cover when we basically need to do a genetic testing in a kidney tumor. So I won't be wasting my time and all of your time. So let's go to the first one. As a 60-year woman with an incidentally detected right kidney mass. It was 2 centimeter, and there was no significant history. A partial nephrectomy was performed. I think, yeah. So not a partial, it's a radical, so there's a typo. So there's a small tumor here, which has cyst and solid areas, not much of hemorrhage, and confined to the kidney. So if you see this, for anyone, I mean anyone with a little knowledge about the papilla, it looks like a papillary type 2 renal cell carcinoma as per the 2016 WHO. And so it's not a very good tumor to have a papillary type 2. I'll show you some areas in this tumor, again papillary type 2. Some areas they do have the nuclei, like a FH deficient RCC, which is definitely a very aggressive tumor with very prominent nucleoli. But in this case, this is from a classic FH. This case did not show FH deficiency. The FH was retained and there was no hyperaccumulation of a 2SC. So in summary, we have grade 3 nuclei and a papillary pink tumor. And there's a broad range of differential. Are we dealing with a papillary renal cell carcinoma or a FH deficient RCC? Because there are areas which look like FH with a prominent grade 3 nucleoli. So an immuno workup, it has CK7, keratin 7, which is positive in a lot of kidney tumor, including papillary type 2, but fumarate hydratase was positive, that means it is not lost. SDHB is also not lost, and it is negative for the clear cell marker. So we have a pink tumor with retention of FH, but it looks like FH deficient RCC on histology in a more than focal pattern. So what is the next step to be done? Then I did a GATA3. GATA3 showed a very strong positivity, and it is towards the papillary course on the top. And GATA3 can also be positive. It is never reported in the papillary type 2 histology RCC. So what I did, we went for a next generation sequencing using a targeted 324 gene panel, and this gene showed missense mutation in the KRAS exon 2 in codon 12 with a glycine to valine alteration. So this is a very indolent tumor. It doesn't have any behavior like a FH deficient RCC. Is a papillary renal cell tumor with reverse polarity, which is introduced this time in the WHO, and it shows the similar RAS mutations like colon cancer. And sometimes the looks are very deceptive on morphology. It looks like papillary type 2 morphology of a FH deficient, and sometimes they do resemble TFE3 rearranged RCC. In this case, TFE3 was negative, and they have a very good behavior, biologic behavior, and genetic markers are very different from papillary RCC. They only show RAS mutations, and they're negative for aggressive markers. So any question on this, or I'll go to the next one. So papillary, whenever you are getting a report of papillary type 2 RCC from your pathologist, please ask them, did they work it up for a few more things? Because papillary type 2 basically doesn't exist. It's a papillary architecture RCC, which needs further workup for other things. The next one is a 70-year man with a right renal mass with gross hematuria. It's a big mass, it's a 12.5 centimeter mass. And it is replacing the entire kidney. And it doesn't have any typical cystic areas, but it has a lot of hemorrhage, some areas which are a little friable. So whenever we see this kind of area, we are a little suspicious for papillary. Let's see what is happening. It has areas with clear cell. It has areas with papilla, with rhabdoid differentiation, sarcomatoid. So it's a heterogeneous morphology. So whenever we see heterogeneous morphology in a young patient, we think about a translocation RCC. But this patient is not young, the patient is in 70s, but we have a lot of heterogeneous histology with sarcomatoid and rhabdoid features. So again, the differential is broad, papillary, clear. We did not think about the clear cell because the clear cell area is very focal. It was majority is a pink tumor, which high-grade histology, and some areas, we did not have a FH kind of nuclei, but the areas with rhabdoid features. This tumor was positive for the clear cell marker. It was patchy though, and it is CA9-1 positive. So currently in 2023, we take CA9, carbonic anhydrase 9, which is a downstream pathway worker in a molecule in the VHL pathway as the marker for clear cell renal cell carcinoma. CD10 can be positive in anything, and vimentin. So those are the markers which are more like a backbencher. And CK7 was negative, 20 negative, so it's kind of ruled out a papillary renal cell carcinoma. FH, SDH, they are all written. INI1 is written, so it's not like an RMC CDC group of tumor, though the histology was a little bit reminiscent, and it has a high proliferation index. So what we are dealing at. And this tumor was negative for TFE3 and translocation related markers like melanocyte derived markers. So we are kind of a little skeptical. So what we are dealing at, is it a clear cell or a non-clear cell tumor? Because we are exhausted with majority of the marker, but definitely CA9 was positive. So this is what I'm saying. This is your CA9, which was beautifully positive with some AMACAR and CD10. Then I went ahead and did a BAP1. BAP1 is a tumor, it's like kind of a tumor suppressor gene which helps in chromatin remodeling, checkpoint for the cell cycle, and the tumor showed complete loss of BAP1 with positivity in the control. And on a genomics, this tumor had a VHL gene alteration. Along with that, about 30% of the tumor cells showed a BAP1 gene mutation. And I mean, it is less than 50%. The first day, Dr. Mithu has already discussed, if a VAF is more than 50%, we take it as a germline mutation and confirm it by a germline study. And there was no other significant mutation. The TMB was high, and it was microsatellite stable. So it is a BAP1 mutated clear cell renal cell carcinoma and with focal high-grade features. So next, going to the next one.
Dr. Samit, sorry, I'm sorry to interrupt you. Maybe it will be a good idea to discuss, because this is a VHL case as well. So how was it managed, and did you or your clinician counsel the patient for further germline testing for others? And maybe you can talk about the VHL syndrome.
Yeah, in this, what is happening, because this patient has VHL along with BAP1. So though the VHL is, you want to have a question? Yeah, please.
It's fine.
Yeah.
It's fine. You just finish and then
you
want to make a comment?
Yeah.
Basically, I think this is interesting. I was just engrossed with sort of all the markers what you're showing. Now, the question what you're asking is it something like a VHL? It's not a classical VHL because it's all solid, necrotic, heterogeneous tumor, not like a typical solid and cystic typical VHL tumors. I was asking BAP1, did he have any lung or mediastinal tumors?
No, there was nothing in the UVI. The ocular examination was normal. There's nothing in the chest.
Yes.
Because that case I saw that Nediad and DBA was also, that has a lung mesothelioma and the kidney thing, but this was an isolated. And as you said, the VHL tumors are very, very uniformly clear cell. Here, the clear cell focus is probably be like 20%. The majority was a non-clear cell, very, very heterogeneous, ugly-looking tumor.
Yeah, and that's the point I wanted to make. I mean, we do get that sort of VHL information, but clinically it doesn't fit into. Now, usually these patients would have bilateral tumors, low grade, low stage, cyst in the pancreas, cyst in the epididymis and testes. So whatever comes out in report, because now we see so many reports as such, not necessarily it would fit into the clinical category.
Yeah.
To answer your question, I think he had a radical nephrectomy done. Probably what the report is going to tell us, what's his future is like. I mean, probably is not so good looking tumor. That's the only thing you can.
I mean, the patient later on has a metastasis, and it was a case about a year and a half ago, and the patient is dead now. I mean, it was a widespread metastasis later on.
Sure.
And secondly, what you said very clearly, we do see VHL mutations in the cases in the non-classic histologies of clear cell, but the biologic behavior is very different from the classic VHL with the bilaterality and multicystic nature in the other organs.
So that means the interpretation in the laboratory report, but doesn't correlate clinically with the
And we are not using, so classically in a clear, so the take home for this case is whenever I get a core biopsy with a clear cell histology, any clear cell histology core biopsy, I am putting a CK7, CA9 and a BAP1. I have a BAP1 antibody now in my lab. So because we are picking up cases, we haven't published, we sent this year for SCAP, it's going to present in March in Baltimore. So what we're seeing, like what we thought the classic histology of a BAP1, but in a core biopsy, you may have just the clear cell focus. So if you saw BAP1 is deficient, those tumors, they behave aggressively than the tumors with a proficient, BAP1 proficient histology with a clear cut. So we put that, we have like a 4-marker panel. I mean, Rajiv Gandhi is also doing the same thing. They have a 7, PAX8, CA9, and a BAP1 combo for all clear cells.
Do you
So
get
I
back
think
to
the
your...
multidisciplinary, sorry, sir.
Yeah.
Sorry. I think that's why the multidisciplinary collaboration and the discussion, because as molecular biologists, maybe I will not know what you are seeing histologically
Exactly.
or what clinician is seeing a patient, right? So
Because-
that this is a reason why we should have a
Yeah, exactly.
multidisciplinary discussion.
My question, sir, is do you contact the surgeon and tell him this is what you're suspecting, so that the surgeon goes back to the family history of anybody else having this particular thing?
Yeah. So we talk to the clinicians like I mean I always believe in like this thing the telephone stand concept.
We have a series of VHL, about 5 or 7 families, and I've been doing partial here, that again doing something else in the same kidney, and because these are going to keep forming. So these are the patients where, as far as possible, do partial, as far as possible, if you don't have those scans nicely, do a ultrasound, what's it called? An ultrasound with dye, which means with air. So you can pick up these small lesions which are cystic, which have some solid component in it.
Right.
So we have these series yet, not yet published.
The VHL, I mean the typical VHS cases are small clear cell things. So let's go to the third one.
Dr. Samvit, I'll ask
Right,
one.
sure.
Sorry. So if there's any medical oncologist there in the forum, I have one question as a molecular biologist. VHL, yes. VHL, as we know, there is a recent drug, belzutifan, which has been FDA approved for somatic VHL, right? So we were very happy because in the report, VHL was tier 2, now it is becoming tier 1. So whenever there is a somatic VHL, we are writing tier 1, and we really feel great when we write tier 1. So doctor, question to you, if you see VHL mutation somatic, in what conditions and what scenario you will go for this FDA approved drug?
Quite interesting. The guy called Patrick Doyle in Cambridge, where he had done a large amount of work on a VHL. And that the journey from 30 years onwards, we have kept our interest continuous with VHL. And we are fascinated with this. The treatment for VHL is basically these, again I repeat and say, they are low-grade, low-stage tumors. So either sort of, you do something like, nephron sparing surgeries, sometimes an ablative therapies, sometimes, focal therapies. Unless it is something entire kidney is destroyed, you do a nephrectomy. The drugs which have been used, we don't have any personal experience, but the drugs which have been used by our colleagues, they say that, the rate at which the tumors develop, I think that slows down. But I don't think it has been useful in completely ablating the tumors as such.
And those are applicable to the isolated VHL mutated tumor.
Yes.
No SET-D2
Yes.
or BAP1 or
Yes.
anything.
So probably it avoids repeated surgeries, number one, and secondly, it may slow down the growth kinetics. That's what I would say.
Right.
Yeah, beltuzifan is now available, not in India, but yeah, it has shown activity post failures of immunotherapy and then VEGF inhibitors. So it's not yet any adjuvant setting. We don't have any data to use such drugs upfront, but we are sure that we would be seeing such kind of data, especially in familial cases where we have such mutations.
And the side effect profile, I think side effect profile is reasonably bad. It's not good.
That was initially to begin with. I also had such things. So we also learn using the drug, re-titrating the dose. It's not a very user-friendly drug for sure as of now, but I think with time we'll learn more about it.
And the trial which was conducted on that drug, the cases have a very homogeneous clear cell histology. They haven't taken the cases with sarcomatoid, rhabdoid, or papillary mixed histology. They are more like a homogeneous clear cell histology. So, as Dr. Ghosh said, we need to have a lot of dialogue between each other, among us, otherwise it's difficult. I mean, as my mentor, Macron knows about him, Dr. Amin, he always says we need to have telephone stain all the time. That is the best stain to have rather than just working in a silo approach. So the case 3 again, You all see it looks like an oncocytoma probably, is a very well circumscribed tumor, homogeneous, non-clear cell kind of growth, but there is no scar. And so grossly we can, at least as a pathologist, I can say it is a non-clear cell kidney tumor, not very high grade, could be anything. If I say oncocytoma, the patient is going to be completely out of the hook, not doesn't going to come for a follow-up, but if I say something else from the big basket of oncocytic tumor, I may do something, a little bit of something for the patient. Okay. So this is a pink tumor. Everything looks pink with a small nucleus, and there is no aggressive feature. Typical oncocytoma-like areas, but there are some odd areas. Oncocytoma doesn't show this halo, but the nuclear membrane, the nuclear envelope is very clear. So it has features which is between an oncocytoma and a chromophobe renal cell carcinoma, like a HOCT, hybrid oncocytic tumor. This patient doesn't have any history of Barhave-Dubé or bilateral oncocytosis or anything else. So CD117 of the c-KIT is the defining stain to differentiate for onco and chromo. So CD117 has to be positive to call it oncocytoma or chromophobe renal cell carcinoma. It was completely negative. And just to tell my clinical colleagues, CD117 is, KIT is not mutated in kidney tumors. We do not have KIT mutation in kidney tumors like gastrointestinal stromal tumor. This is because our interconnected ducts of the kidney, they normally express CD117. So any tumor which is arising from the interconnected duct would be CD117 positive, but it was dead negative. So possibly we are not dealing with a chromo or an onco. CK7 is usually strongly and diffusely positive in chromophobe renal cell carcinoma, and you see hardly 1 to 2% of cells in oncocytoma to be positive. But this tumor is keratin 7 like Christmas tree. So what we are dealing with? We are dealing with a diffuse keratin 7 positive, CD117 negative pink tumor, neither fitting into an onco or a chromo. Is it benign or it is malignant? The patient should come for a follow-up, or we can let him or her go. It was GATA3 positive again, strongly. This is the normal tubules which has controls. Ki67 is very low, SDH is retained, no FH deficiency. So this is a new entity in the last WHO, but this WHO, it has gotten into a place. It is, LOT is a low-grade oncocytic tumor of the kidney with a diffuse keratin 7 positivity and negative CD117. It is a low-grade malignant potential tumor. It is not a benign tumor. And they resemble oncocytoma. So in a core biopsy, if you are getting a report of oncocytoma, please ask your pathologist whether they have done these two stains or not. Because if in the core biopsy, we had a consensus meeting in the ISAP last year on these pink tumors, like whether we should, in a core biopsy, the majority of the uropathologists across the globe, they voted we should not give a diagnosis of oncocytoma on a core biopsy unless it is 117 positive with few cells showing 7 positivity and non-chromophobe histology. So, and we kind of molecularly characterized for the first time, it was done in India in our lab. So we found a TSC-mTOR defect in these tumors. Though they do not need any therapy to begin with, they are organ-confined, small tumor, non-metastatic, but in the future, if they show metastasis, at least we have something to offer. The fourth one is a left kidney tumor, 5 centimeter, and this is very, very homogeneous. It looks like a soft tissue sarcoma. This tumor looks like a soft tissue sarcoma, like a non-kidney tumor. It has the histology of something which is unusual. It has tubules, pink cells, and myxoid change. So I can say it looks like a mucinous tubular spindle cell carcinoma of the kidney on morphology. I was on the verge of signing it out as a mucinous tubular spindle cell carcinoma, but I thought let me put some stains, how it is lighting it up. It has a uniform mucinous tubular spindle cell carcinoma histology. This tumor has, patient had lymph node metastasis at the time. I received the specimen, and one of the lymph node was positive. It was keratin 7 and PAX8 positive, which is kind of little odd for mucinous tubular. So I thought probably I'm dealing with something else. Clear cell markers were negative. So do I need something or go for genomics straight up? So I thought I still have few markers in my lab, let's utilize those. I presented this case on 2021 European College of Pathologists, so they gave me some idea. So one of the participants in the conference pointed out, did you went for an ALK rearrangement? I mean, other people were not very supportive. So after coming back to India, so what I thought, we do the ALK stain, the one we used for non-small cell carcinoma. This tumor was ALK positive, and there were TPM3 and ALK fusion by RNA sequencing. So this is the ALK protein which was positive in this tumor, and there is the ALK break apart fish. You see the broken apart orange signals. This is a ALK rearranged renal cell carcinoma. And the patient is on anti-ALK therapy and is on follow-up. And the last case is a any question on this, on experience on the ALK? Because we do see last year I had 3 cases of ALK, one with this histology and others as a typical histology described. The third one is a small tumor, 1.3 centimeter in the upper pole. I'm emphasizing some history here. There was no features to support tuberous sclerosis in the family or in the patient. It has something to do later on in the images. And it was a small tumor. So what you see, it is a clear cell tumor, but what are these pink bands doing in the clear cell? Normally, we do not see this smooth muscle getting into the clear cell tumor. They're very homogeneous, they have a thin capsule, hemorrhage and all. So we see a lot of fibromuscular stroma, what we call RCC FMS in this tumor. And this tumor was keratin 7 diffuse positive. Clear cells would never show you keratin 7 diffuse. Clear cells are either completely negative or show a little bit of positivity. They have CA9 positivity like clear cells. So it has some features we do not know. Other stains were kind of positive, negative. So what we have a clear cell tumor with fibroleiomymatous stroma. It is a fibromuscular stroma. Is it the same VHL clear cell or it is something else going on? So we sequence a set of tumors. This is one from that series. It shows ELOC mutation, elongin C mutation, and this is the third case, and this patient also had a nonsense mutations involving the TSC1 gene. And these are indolent tumors again, small clear tumors. So this ELOC is something which is involved in the VHL inactivation pathway, and it further activates the mTOR and upregulates the hypoxia-inducible factor followed by angiogenesis, cell proliferation, and a cancer. So this is again a new entity in the recent WHO on ELOC mutated RCCs, and unless you think, and they have a typical histology of this. So within the clear cell categories, what we have different categories also. This one is a difficult case for me. It took me almost a month to finalize, so I'll end with this case. It was a 7.5 centimeter big tumor in the kidney in 2018. I do not have the 2018 case to begin with. What I received is as a consult case in 2022 with a retroperitoneal node and the previous slides and blocks for review. The first diagnosis in 2018 by the pathologist was a collecting duct carcinoma, and the patient who is surviving with a collecting duct for 4 years. So that was very, very surprising for me. So I thought, let me review all the slides. Morphologically, the tumor has clear cell, necrosis, everything like a collecting duct. Morphology is like a collecting duct carcinoma. So it was not very much like whoever has done a great job with the morphology. It was like a collecting duct RCC with lot of things. What I saw, there are areas which are these vacuolated areas. So we'll chase after those vacuolated areas. Lot of vacuoles. So when I see a lot of these vacuoles and the patient is surviving for 4 years with just a nodal metastasis, I thought probably I'm dealing with something RCC NOS which needs to be further worked up. And it has some nesting areas and all these oncocytics. So it was like a very aggressive looking tumor, but the patient is doing fine. So, yeah, I'll wrap it up in this. So what we have, so this consistent vacuoles prompted me to do a FH stain, SDH. So the tumor showed loss of SDHB. So it's a SDHB loss, And when we molecularly worked it up, in 2018 there was a VOS involving PTEN and Iridia 1B, and in the immunostain wise there's a loss of SDH A and B, and NGS done and the recent biopsy showed a pathogenic variant involving SDH-A, and there's a VOS in FS gene. So this is basically SDH-A deficient renal cell carcinoma. So we do, not very often, but we do get these kind of cases. So our current classification is kind of attempting to introduce new knowledge into the classification and further integrating molecular with the structural biology of the cell with advanced IHCs and molecular technique. The only thing we need to have a multidisciplinary tumor board setting to discuss about things considering the financial and the benefit to the patient to use those into clinical practice. Thank you very much for your time.
Thank you, Dr. Sambit. I think that was fabulous. I think we have convinced the clinicians that we need to do a genetic testing. We need to have a molecular tumor board. We need to have a collaboration with clinician pathologists. The major question is how to interpret the report. I mean, you should consult or you should have a collaboration with molecular and geneticists to interpret the report. And another question is, should you refer your patient to genetic counselor? Because many of the times you are so busy that you might not be able to take the detailed family history, understand or identify the syndromes. So do we have 2 minutes of time for Upasana? Yeah. So, yeah.
I'm interrupting this talk, just there are 20 vote pads are short. If you have not returned it yet, please could you do so. Thank you very much.
Thank you. So it's a very important question that the patient should be referred to genetic counselors or not. And I request Upasana to take your few minutes and talk about it. Thank you.
I don't know why the dais is always so tall for us. Good evening. I think here as a genetic counselor, I won't take much time because genetic counselors talk a lot and their job is to talk basically. So today, but to cut it short, I'll just quickly introduce about what are the components of genetic counseling when we it is a multidisciplinary approach for all the hospitals or the centers here, even in India and in Kolkata also. So what we do as with the clinicians, we do have our clinics, we do have our sessions, and the genetic counseling basically, as we all know, might be knowing that it has 2 parts. One is the pre-test genetic counseling, and then we sit with the reports during the post-test counseling session. So a lot of us have these questions that what we do, when to send the patient to the genetic counselor, when do we, what they can do as a non-medico, because we are the non-medico and we are not having the doctor degrees. So as a genetic counselor, our job is to psychosocially assess the patient's clinical history, personal medical history, as well as the family history, and identify if they are at risk of developing or having a genetic syndrome, which can be classically inherited or can be an acquired syndrome as well. And also to understand the family ratios and to identify the at-risk family members, help them to understand the disease prognosis, courses, and the further the surveillance and the prevention measurements. So as my slide says, that what we do the cancer risk assessment by taking the histories, by taking the particular type of cancer, like for the renal cell. The last workshop we showed that what are the types of, when we suspect the VHL, when we suspect the different kinds of prostate genetic inherited syndromes. So we do the cancer risk assessment, then finally we prepare the patient if they are exposed to a genetic testing further. Then we choose a major important part of genetic counseling is choose the right test for the particular individual. So in this era, we know that there are a lot of testing, NGS, Sanger, then we know about HRD right now. So what particular test the patient should undergo, that is the role of a geneticist and a genetic counselor, and that is the component of the first pre-test genetic counseling, and the next part comes to the post-test genetic counseling. So these are the things what we do for the cancer assessments. So I have showed the guidelines the last day, but I would just like to repeat: for any person who has an early onset of disorder, having any family history of first degree relative or second degree 2 relatives having the disease, any kind of genetic, any kind of cancer syndrome, for specifically when we talk about the kidney cancers. There are a lot of other markers, like for breast, as we all know about the TNBCs, we have the bilateral involvement of the organs, we have multifocal tumors. Then if there is a clustering, different types of, same type of cancer in close relatives, cancer occurs in the multiple generation in the family, and occurrence of the rare tumors like the retinoblastoma, adrenocortical or carcinoma, etc. This is for a general assessment of a cancer patient. So these are the components which I already have explained in the pre-test counseling session. The post-test counseling, it is basically to disclosing what kind of syndrome, if at all it is present in the patient, or if they are not having any kind of disease, any kind of genetic syndrome there. Now if we find any kind of genetic syndrome and the report is there, now we basically have a lot of responsibilities here. First is the report interpretation. Why? Because you must have seen that the reports comes up with this kind of classifications: pathogenic, likely pathogenic, variant of uncertain significance. Usually this, benign, the labs don't report. So if it is a pathogenic, if it is a likely pathogenic variant, then our job is very simple. We know what are the guidelines are available, what are the surveillance patterns are there. But when it comes to variant of uncertain significance, then the challenges start. So what we do as a genetic counselor, we have a lot of different, we first of all, we maintain the ACMG guideline recommendations to reclassify any variant which we are seeing in the patient who is already affected. If not affected, then we have to hold and reanalyze the report in some biennial time or in a couple of years more. But if the patient is already affected, then there are a lot of other methods, and there are available softwares where we put the variants. Like here I have shown the flosses for the BRCA cases. There are BRCA Pro, where you can even put the VHL gene, cancer MAD. There are a lot of other variant annotation databases are there where we can actually put and understand what is the mutation, how the mutation is impacting on the protein structure, how it is important, which domain it is filling, and based on that we understand how much it is important in our patient. Also give a very good patient care support, psychologically essential when we don't have much time in our OPDs, but as a genetic counselor, it is our job to support them psychosocially, psychologically and medically. And also the family counseling takes a very major part here. With this, I won't take much time, but I would just like to open up the session for a collaboration. I'm a genetic counselor, consultant genetic counselor for Apollo Multispeciality Hospital. We are about to start our first cancer genetic clinic in the hospital itself, and I would like to collaborate with multiple other centers. So if any opportunity comes up to open up, because what we need is right now, we need to have our own variant database, because whatever the likely pathogenic variants or whatever the guidelines we see, it is majorly for the Western population, and the Asian population doesn't have all those particular guidelines. So with this more and more clinic, more and more exposure to the patients and findings and results, I think we can build up the variant database for our own population. Thank you. I'm open for any question.
Thank you so much, Upasana. We would like to conclude the session, but before we conclude, I would like to ask the esteemed panelists, my last presentation, please. Sir, do you think that genomics should be the standard of care in the treatment or in management of a patient? Anybody from the panelists as well as from the forum?
it's a standard of care to include this, the panels, and as much as we learn more, we will see that we are becoming more specific to cancer. So you can see the BRCA is a very good example as the beginning, and you showed in your slides that there is a slew of things coming up. I think it's a standard of care, and I think what you said about collaboration and education is the most important aspect.
Yeah. Yeah, I think, we guidelines tell us already that in the castration-resistant prostate cancer, you should get a genetic information. For the hormone-sensitive prostate cancer, be it metastatic or non-metastatic, nice to have, but it's not in the guidelines, and it costs a lot of money, and I'm not sure whether that is really justified. That's from the bladder cancer. You tell me. I have not seen any real sign except for the second, third line metastatic disease. We'll see what the Tombola and the atezolizumab trial with the liquid markers are going to show.
Thank you. Thank you so much. So,
excuse me, can I ask a question?
Yeah.
So now, in our clinical practice, generally we do genetic analysis for metastatic prostate cancer in hormone sensitive and resistant setting. But in which condition in bladder and kidney cancer you want us to send the sample? Because we generally don't do it routinely. In which situation you want us to, and which tissue you want? You want blood tissue or a tumor tissue or both? But you want to tell us what exactly, we don't know the answers for these things.
yeah. So I had some slides, but because of time and all, we are just skipping those slides. Sir, it totally depends on what you want to do. For example, so I told you, right, there are two aspects of genetic testing. One is somatic sporadic, which a patient acquires over a lifetime because of multiple external factors. Other is inherited. Now, if you want to do any inherited cancer testing because there is a family history or patient is very young, because now inherited cancer testing also has a therapeutic implication, right? BRCA and all have PARP inhibitors. Then it should be a normal sample, a blood sample or a saliva, if it is inherited, because those genes are there in the germ cells, in the reproductive germ cells or sperm cell. But if it is a somatic testing, like you want to use it for your therapy selection or treatment, then it has to be the tumor tissue with enough tumor burden.
If the patient has genetic mutation in prostate cancer, BRCA1, BRCA2, does it mean that it's always somatic mutation will show BRCA1, BRCA2?
If it is there in the germ line, it should be there in the somatic also. But only doing germ line might miss out 7 to 8% of somatic mutations. So I have a case.
But you told that you do some 500 genes for
Yeah.
prostate cancer, but generally we get 14 genes. But in
Yuraj, but I think I think his question is different. His question is that, do we send for something? But you answered your question that you don't have anything in bladder. I think Arnav said that. And then also for kidney, there is obviously evidence coming out. What you really have practically right now is prostate. Clear. But then obviously you go in advanced stage and you're now looking at the variability where you're sending tissue now to kind of separate it. But for regular counseling, I think for prostate, like bladder, these are like the common things. I think that's what
Sir, to answer your question, please see this data. I just want to, because it's an evidence-based medicine, you need to have evidence to prove or convince you. This is 200 patients what we had done. We had done in this 200 patient a small panel as well as a comprehensive genomic profiling. Your question was, we can do a just 14 gene. Yes, you can do. But look at this data, and this is the data presented, has been done in Indian lab by us. So when we do a focus panel, the actionable gene mutation is only 14%. And if you remember my slide, actionable mutations are those for which FDA approved drugs are available. But when we do a CGP that is comprehensive, that 14% becomes 47%. So you get more information, more actionable. So I think, considering your insurance provider pays and all, you should decide based on lot of parameters. You should not be just deciding on a smaller or bigger panel. If the patient is affordable, you should always do comprehensive, and if it's a metastatic case, you will always do a comprehensive. But if you cannot, you should do a small panel to see the targeted genes like BRCA, AR fusions, or AR mutations like that.
Can you put the mic? Hi. I may have missed it, but did you refer to the length of the tissue that has been in paraffin and the outcome of your results? In other words, when I talk to colleagues from pathology, they tell me that after a couple of years, especially 5 years and more, the gene alterations tend to fade away.
Yes, very valid question, sir. Tumor evolves, tumor is very dynamic. So it's always, and this is the guideline which is followed all over. If there is a tumor metastasis or relapse, a fresh biopsy needs to be done, and the genetic testing has to be done from the new biopsy, not from the 5 years old. Although the FFPE tissue remains good for 3 to 4 years, but if you have to get a reliable data, you cannot trust on the integrity of DNA and RNA, specifically RNA sequencing. So it's better to do a fresh biopsy. If fresh biopsy is not possible, the new technology of liquid biopsy is available. You can take the blood sample and just sequence it. Yes, doctor.
Yes, that's exactly the same point I was mentioning, that often the site of metastasis is bone, and you don't have the primary, and bone decalcification causes a lot of problem in DNA, and you cannot use. And more than 5 years back, if there was an initial biopsy, we see an attrition rate of around 40 to 50% that the sample does not pass the QC. So that is a big problem. And I think it's important to discussing your point. There are two things that we need in prostate cancer when we are talking about genetics. One is the germline that the guidelines recommend to do even at the castrate sensitive stage, at high risk localized state, which includes node positivity and T4. And then the somatic one actually needs to be done on tissues only when it is castrate resistance. So that time we would need a tissue if it's available. If it's not available, then do a liquid biopsy, but there are very few commercial labs that are offering doing a complete HRR panel. So that is a big problem that 20 to 30% of patients would be miss out on.
Yes, so those are the challenges. And sir, to answer again your question, this is further data I want to show. Small panel, they are not able to detect the pan-agnostic markers of tumor signature. So in our cohort of 1200 patients, this is the data we got. We got 14% of the cohort has TMB high, and this includes prostate, renal, urothelial, a mix of cancers. We got 14% HRR gene mutated, and that is from somatic, which you would have missed if you had done only the germline cases, right? So yes, these are the challenges, definitely. Cost is a challenge, TAT is a challenge, getting or availability of the lab is a challenge, and then utility of the test is a challenge, and most important is availability of the drugs is a challenge in India. But definitely, as Upasana said, that with more of collaboration, more of diverse intersectoral multi-stakeholder collaboration with the following deliverables, that we will generate more of India-specific data. We are very poor in our India-specific data. We don't have a consortium of data in India. So if we have this deliverable, and this conference is to develop consensus, so I present this consensus in front of you, that if we collaborate and if we develop an India-based consortium, data consortium, with collaboration, definitely there will be more adoption, more utility, and more help to the patients when we do genomics for the patient. With this, I end this session with a final note that not only doctors, clinicians, geneticists, I think we have to involve the patients more. We have to educate them so that if patients are aware that how their genetic test is helping them, and they are involved from the beginning, it helps in the adoption more. With this, I thank you all for your patient hearing, and I thank the speakers and the panelists. Thank you, sir.
Thank you so much to all the panelists, to all the speakers. I believe now we are certainly more enlightened about when to use genomic sequencing and how to use it for the betterment of our patient outcome. For the next very interesting session, I would like to call Dr. Abhishek Singh from Nadiad, who would be discussing some very interesting case. Dr. Abhishek Singh, can you please invite your panel? Thank you.
Thank you, Dr. Tarun. Now, we are coming to the end of this meeting, but there's always a debate between generalist and specialist. And there is a fine line between being a generalist and specialist. There is obviously a large brigade of cases that fall between the purview of generalist and specialist. And we are here to discuss what needs to be done when we are met with such a situation. I am awaiting my co-moderator, Dr. Amitabh Singh, and may I invite my esteemed panel, Dr. Khurshid Guru, Dr. Harpreet Singh, Dr. Kim Maman, Dr. Saurav Kumar Mishra, Dr. Mayank Agrawal, Dr. Vidur Bhalla, and because we are a small group remaining towards the evening, we'll take this forward as a group discussion. So, starting with my first case. So, I'll begin the discussion with my first case. So, Dr. Khurshid sir, this is a 68-year-old male presented with LUTS, was worked up for cancer prostate. And may I invite my co-moderator, Dr. Amitabh? He has a history of laparoscopic hernia repair. On a multiparametric MRI, he was found to have a T2 lesion, biopsy proven. So he was diagnosed to have a localized cancer prostate. Preoperative investigation showed an incidental lower polar stone. So here is a 68-year-old gentleman, no comorbidities, history of hernia repair, PSA 8.7, biopsy proven localized cancer prostate. Sir, my question to you, Dr. Guru, when you see a situation like this, patient has opted for a radical prostatectomy and there is a lower polar stone of about 9 millimeters. What would be the next best course of action in your opinion?
So it also depends when the scan is. So is this scan right away after the biopsy? So what is the pathology of the biopsy? So for example, let's say if the biopsy was done now and the scan was done right away, usually if this is a surgical candidate, we have to wait for 6 to 8 weeks after a biopsy for doing a prostatectomy, right?
Right.
So if you have this stone and the patient gives a history of having symptomatic stones and all that, now I haven't done a stone disease in probably 100 years, so I'm not the right guy, but if this patient was in my clinic and I picked this up like this, I would then send him to my colleague while I'm waiting for the prostatectomy to get the stone taken care of. Now, if the patient says that he's a recurrent stone former and this is an issue with him constantly and all that, I would still get this taken care of, but it wouldn't be higher up in the priority. And if he's completely asymptomatic, I mean, I think I would let my colleague who's doing kidney disease decide, but I would send it to them right away. Because if they want to intervene, they can intervene now. If they don't want to intervene, they can wait.
So this is an asymptomatic patient and he's come for surgery to me. He's a planned case, biopsy done 4 weeks back. This is the situation. So would you still refer him to an endourologist for stone management or keep the stone under observation?
If the patient is, so
asymptomatic.
What is the Gleason score?
His Gleason is 3+4, absolute surgical, favorable intermediate risk, has opted for surgical option.
So I think here I would go into probably kidney guidelines because it might be an asymptomatic 8 millimeter which is in the lower pole not moving, you might just watch it. That's what I would. If
So-
I was the urologist making the decision for his kidney disease, for his stone disease, I would just watch him if he was asymptomatic.
So I'm a urologist with my area of interest being uro-oncology at a stone center, and I decided to observe this patient. Yes, we can have your comment.
Yeah, the kidney is not looking that great. Bilateral kidney in this CT scan is looking like contracted.
No, it's perfectly fine. It's just a.
He wants to do a nephrectomy.
No.
That is just a motion artifact or a reconstruction artifact. He's perfectly fine. But so I learned my few early. I was just coming to sir. I learned my few early lessons of prostatectomy from you, so I chose to keep this patient under observation. Kim sir, would you have done anything differently?
Since he's asymptomatic and it's a lower polar stone and he's not bothered about it much, this was incidentally found, I would encourage him to get the treatment done for the prostate cancer first and then tackle the stone later if required.
We can invite a comment from Sabnis sir. Sir, 9 millimeter lower polar stone, would you recommend management or?
See, this stone is not going to remain asymptomatic forever. It is going to cause some symptoms. And treating 9 mm stone is not a very big deal. It's just a matter of few days, even if you keep a stent, do RIRS or mini PCNL. It is a matter of few days. The stone can be cleared so that later on, if there are any interventions which are required, are not required when the prostatectomy is already done. And bad luck, if this comes down immediately in the post-operative period, you are in a big mess. So that is what is the whole thing.
I 100% agree because why I would send him earlier on before I wait for the prostatectomy is because let's say if we wait and do nothing, I would go with that option. Send it to my colleague in the kidney disease, stone disease, take the stone. Why? Because now let's say I did the prostatectomy, the stone moves. Now I have anastomosis which is not here. And the person has to go from below. Now we have only one approach.
Absolutely, I agree 100% with both the thoughts. Sir, if you are doing prostatectomy, you do the anterior bladder neck incision, and incidentally you find a stone at the right VUJ, pouting stone. What is the next best course of action? Your investigation has clearly missed this.
If it's pouting at the right VUJ, you can just pull out the stone.
You'll stent or not?
No, I wouldn't stent.
All right.
Yeah, I think I would pull out the stone, shoot a retrograde to make sure there's nothing, and then not leave a stone.
Sure. So let's see what unfolded. I chose to observe this patient, and I'm doing the prostatectomy over left PLND. During the left PLND, I injure the ureter. Because the ureter is lateralized, this patient had a hernia repair, so the ureter was lateralized. So I put in a stent, took a few stitches. So the question is, if I injure the left, any of the ureter, marginally, not circumferentially, then is it appropriate to put in a stent and take few stitches? Or you should refreshen and do everything?
Yeah, that's a. So I'll tell you what I would do, and I'll ask Professor Maman. Basically, thermal injury to the ureter, even half, I would basically reimplant. I would, because I would assure you that with half of thermal injury, and even if you put a stent and you put a few stitches, this is going to stenoze, especially this thing.
Yeah, I fully agree that if it's a thermal injury, it's better to freshen the edges and reimplant the ureter, because that ureteric injury is bound to stenose at some point in time.
Other thing which is very important to remember is what was the etiology, what was the cause of the iatrogenic injury. So, you know, if you're dissecting something and you find the ureter and you have a cold scissor and you make a cut. Cold scissor cut in the ureter, you can just be forgiven. Maybe if it's less than 20% of the circumference, you can just put a stitch and you can get away with a stent. If you have a thermal injury, usually you have done way more circumferential damage because of the thermal injury than you think you have. And this injury is going to stenose 100%. So that's why I would reimplant the ureter completely.
Fortunately for me, the injury healed. I could take the stent out. There was no hydronephrosis on the left side. Now, at this stage, would I treat the stone?
Well, first is I would do a renal scan in about a month to make sure that it is not. So I would do a renal scan, but what would I do for the stone? Well, I mean, you have me doing stone disease. If my colleagues hear about this, they'll be like up in arms. I'd probably go through PCNL then and do a PCNL and take it out. I don't know.
So the rationale still holds that this is also an opportunity to treat the stone, as Dr. Subnis sir just told us. But we chose to keep him under observation. Time passed by, and 1 year later, he came with a ureteric colic and infection. So now we were pushed to the wall to treat him. We started to do ureteroscopy in this patient. You can see the tackers, and the ureter is just mobilized laterally because of the tackers. The dilator would not dilate beyond the point at which the stitches were taken. So we took the semi-rigid ureteroscope inside. Mind you, this was not a stricture, as in there was no hydronephrosis on the left side, but your ureteroscope would not go. So there was a lot of rigmarole. We had to dilate the ureter using a balloon dilator, finally to get to the stone. And here you see, this is the point of sutures. We had to dilate this mechanically using a balloon dilator, and then eventually there you can see that's the retrograde, that's the balloon dilator, and then eventually we could get.
So I have to say this to you, that why did I ask you for a renal scan? Because I can assure you that even though you always say, not you, I mean anybody of us goes through this experience that, oh, you know what, the stent was fine, I looked in and it was good. Usually it is functional, it has dropped function by about 50-60%. And this is kind of evidence for that. And you see this in a lot of reconstructive cystectomy patients. You put up a nephrostomy tube and you inject contrast, and you see the contrast come down, and you're like, why? You pull the stent off, you close the nephrostomy tube, patient comes with sepsis. And why? Because even the stasis and the slowdown of urine ultimately leads to this, and I think a lot of people will testify to that.
So I think there are two important take-home messages in any oncology case. Surgeon should not be like an absolute Arjun looking towards only the fish's eye. You have to look at the broader picture. Something that is potentially going to create an hazard tomorrow should be tackled today. Yes. Moving on to the second case, I hand over the mic to my colleague, Dr. Amitabh.
There's a question, sir.
Yeah. Sir, during radical prostatectomy, suppose patient having bilateral hernia, will finish same sitting with mesh or will wait, sir?
Sorry, I didn't get it.
During radical prostatectomy, robotic, yes, patient having hernia bilateral, will finish same sitting because it requires mesh foreign body. It will be finishing same sitting or will be postponed later?
So it depends on so for example, bilateral hernias, and if they are pretty extensive, I usually send them to my general surgery colleagues. If it is a minor, smaller hernia, which I think I can plug with a plug and then can put a little mesh, I usually take care of it. A lot of times what I've done is, if I feel that with the pneumoperitoneum and the hernia space and the opening is bigger, I prefer to send them to my colleagues.
Okay, so good evening everyone. So thanks boss. Actually these cases are from other institutes, from Search Institute only. So, but I have seen the stone diseases are the most common cases which are associated with the oncology and some other urological malignancies. So this is the next case. He is a 45-year gentleman having no comorbidity, having a history of tobacco chewing. So he had a complaint of hematuria without clot passes, and it was 10 days back. So he had no history of any fever, low urinary tract symptom, no personal history, examination was normal, and evaluated outside and was found to have a right renal mass. So on CCT, the mass looked like well capsulated exoendophytic tumor at the anterior aspect of the kidney, probably upper pole and mid pole. The size of the tumor was 5.2 centimeter into 4.4 centimeter, but he had one 6 mm calculus also at the lower polar calyx along with the right renal mass also. So on the hematological investigation, CBC and creatinine both were normal. So the question is, how would you manage the stone? Because we see a lot of cases, especially for small renal masses, because these are being diagnosed on the ultrasound right now, because most of them, they are asymptomatic, so you may get also a stone along with the small renal masses also. And I have faced the same problem at my institute also. So sometimes we get like confused whether to manage kidney tumor also, or the stone first. Because on the CT scan, this tumor looked like capsulated. So he had history of hematuria, so probably this could be because of the stone also.
Yeah, but it didn't look like a small renal mass.
Yeah.
If you go back, I think, wasn't it involving the renal pelvis?
No, sir, it was 7A because we only
7A.
put the representative images.
Yeah. So it capsulated on the other imaging, it didn't show like there is a PCS breach or involvement of the PCS. So there was dilemma that whether to manage the kidney first or the stone first. So what would be your choice, especially in these cases?
I mean, to be honest, I would first go take care of the tumor because
Tumor
the tumor is small, and I have because I don't have the full images, and maybe Dr. Seth is here and Dr. Mehmet is here, and what they would do. I personally would manage the kidney tumor, and maybe while I'm there, and I would basically get access to the pelvis and take the stone.
So it's a 6 centimeter lower polar stone.
Oh,
So
it's
it's
a lower
far away from the site
I
of
would still
operation.
go. I would still go with the partial.
I just want to share two cases I have done like this. One was like lower polar stone and upper polar mass. So I have done a RIRS on the same patient. In the same setting, I have done a partial nephrectomy. So I broken the stones and then I changed to robotic partial nephrectomy. And other cases, there was a pelvic stone with a mid-polar mass, and there was a upper uteric stone. So I have done a pyelolithotomy with uterolithotomy and the mass partial nephrectomy. Simultaneously, so it can be done simultaneously or it can be done in separate sitting. But I would say that if you are doing some reconstruction after partial nephrectomy, then sometimes the calyx may be deformed, the infundibulum may be angulated. So dealing with the stones, in my understanding, sometimes may be difficult. So if you can do it in the same setting, a small stone, you can do RIRS, break it down, and you can go for a partial nephrectomy in the same setting. That I have done.
So I feel, Dr. Sanjay, it is not generalizable and replicable.
Yeah, it
Problem is when you take the flexible ureteroscope inside, everything becomes extremely soggy. And even with simple diagnostic ureteroscopy, the whole retroperitoneum becomes soggy. And the dissection unnecessarily becomes difficult. So though in expert hands it is possible, but it just makes the whole thing more difficult.
So Dr. Seth,
sir.
Why not leave a stent, do the partial nephrectomy, that's a priority, and come back in with RIR after 2 months, 3 months?
Sure.
So in your case, you did RIRS first, then partial nephrectomy, or like in the same setting also?
Yeah, same setting. In the same setting, I have done RIRS and partial nephrectomy.
RIRS and partial.
And in one case, pyelolithotomy, partial nephrectomy, uterolithotomy. Both.
What was your approach, open or robotic?
All robotic.
All robotic?
Yes.
Okay. So here actually the stone was kept under observation, and robotic analysis was done in 28th of September. Procedure 1 uneventful, patient was discharged in stable condition on post-op day 3. At the time of discharge, his hemoglobin, this kidney function test, platelet were all perfectly normal. But patient came on POT 7 with acute urinary retention, POC was placed. Then again, he came on POT 9 with gross hematuria. So he had almost 800 gross hematuria in his uro bag. So patient was admitted, clot evacuation done with the irrigation, and irrigation was started. So now what is your approach? Do you do conventional angiography or CCT angiography in these cases? On which investigation do you rely, especially in these cases at your institute? Sir.
Usual way would be to do a CT angiography, but this patient is in hypotension. And since he is in hypotension, he has obviously had a significant bleed and he will need angioembolization, and therefore in this situation best would be to go with conventional angiography and do an embolization in the same setting. CT you do if you have a doubt whether there is a aneurysm or AV fistula or not. If you want to settle that, then plan the angioembolization or forget about angioembolization. That is, if you want a diagnostic, then CT. But if you want a therapeutic one, then straight away angiography. Conventional.
Okay. So this patient underwent conventional angiography, but surprisingly, actually, we could not find any lesion on the conventional imaging. So you can see there is a defect which can be appreciated in the rhinogram image, and there is no pseudoaneurysm or any leak of the contrast in the from the PCS or any AV malformation. But he again developed hematuria, so you can see the color of urine in his uro bag. So what would be your next step, sir?
So I would like to make a comment. I have published an article with why the angiography and this digital subtraction and DSA failed to detect AV malformation or AV fistula in post-PCNL or sometime partial nephrectomy bleed. And we found those patients who are hypotensive, who had hypotension episodes, and on inotrop, they got vasoconstriction. And sometimes you can miss the pseudoaneurysm because of the vasospasm. So I don't know what happened in this case, but this is a very known situation.
Didn't show any AV malformation, right?
On this
distal subsection, right?
DSA, or they didn't show any?
Did you do the angiography at the time of the bleed?
So no, actually when he came to casualty, he had hypotension, but it was managed conservatively, and after that he this angiography.
So he was better.
Yes.
And then suddenly came back with new onset.
Yeah, exactly.
So basically you'll have to bulk up the track because now it might be something else which you might have missed. Versus a vascular, because you already did angio, right?
Yes.
Again, and it's nothing. So it's something else.
The timing of the angio is also important. Like if he's bleeding and then you're doing angio, the positivity would be much better.
But what could be else in this case? Because stone would not lead to this sort of cross-hematuria.
I don't think it's a stone.
And the color of the bag is pretty
Anybody
red.
else has thoughts? What would you do?
Unusual enough. You haven't done a CT angio, have you? So we would have done a CT angio probably as the first investigation, and then conventional angio if they're going to embolize it. Most likely he's got an arterial bleed related to his partial nephrectomy, you just haven't seen it.
So because I agree, because you have only done a conventional angio, you haven't done a CT. I think that is the next step I would do.
So exactly, we did the same.
We have seen this problem quite often. That patient's first angiography, conventional angiography comes normal, and later on, again, if you do it, then you find some aneurysm or fistula formation. As he rightly said, that there is likelihood of a spasm, and that does not fill up the aneurysm or the fistula, and therefore it is passed as normal. But if you do it properly, or if you do CT angiography with this, then quite often it becomes positive and you can identify the problem.
So I think that's very, very good points. A vessel, you can't identify the blood pressure, if they are in spasm, and the timing of the bleed, go ahead.
I think you should do a CT angio first to identify. That will identify it nicely. You can do the conventional angio because you push it much more down in a conventional angio. Then if your CT angio shows, you can embolize it with a conventional angio. But to diagnose something like this, which keeps recurring, I think CT angio is a bust.
So here you go. I think the lesson is CT angio.
Yes, sir.
Yes, sir. That's what you were trying to get.
Yeah, exactly.
Basically, we have made our protocol that in this kind of scenario, when you have a very strong suspicion that there is some vascular issues, so we used to give injection deltiazem, calcium channel blocker, for the vasospasm to relieve and probably, and we have identified subsequent with giving calcium channel blockers.
Okay, good. So on this CT angio, sir, actually we could find the index lesion. So it was a focal aneurysm dilatation of segmental branch of right upper polar, and the size of pseudoaneurysm was 7 mm. And along with that, he had a perinephric collection also. So on the CT, it was a mixed like hypo and hyperdense also. So there was suspicion that there could be urinoma also, and there could be clot also in the perinephric collection. And surprisingly, that stone which was at the lower calyx got migrated, and it came to lower part of ureter at the SI joint. So because of that, there was obstruction and there was hydroureteronephrosis in this image, and that's why he had a urine leak also from the defect, renal defect also, and he had the pseudoaneurysm also. So that's why he had a mixed content of urine and blood in the perinephric space. But on the next, actually, this angioembolization was done, but the patient settled, hematuria settled. But the next question is, would you stent this patient, and or you can take this patient for upfront URS at that time? What would you like to do? Stent, yes, exactly. I think most of us would agree on the stent only. Then the next question is, like after DJ stenting, what would be the ideal timing for the URSL, next URSL? Would you like to wait for 1-2 months, like 1 to 2 months, most likely 2 months?
I think at this point the stability is and the hematoma has to resolve and everything else. You have to wait for that. So like we were discussing earlier, like I think you have to, the CT angio is kind of that message probably for everybody.
Yes,
right?
sir.
Because you're just going for angio, you're going to miss a lot of other things. I think Dr. Seth was saying this earlier also. You have to worry about the hematoma and the collection and everything else.
So the patient is fine, doing fine. So right reversal was done, stone was picked up, and now patient is doing well. Case number 3. Sir, Dr. Abhishek.
So I think the take-home message is that whenever a stone, deal with the stone, don't leave stone for tomorrow. Whenever appropriate, image the patient first, do a CT angio first. Before removing a stone in a stented patient whose upper tract has been reconstructed, re-image the patient with a plain CT and then only go ahead and do things.
I also suggest to do a RGP beforehand, because that will help you, because sometimes understanding the anatomy may be difficult.
Needless to say, when you are going in to remove a stone, all endourologists will do an RGP, but point very well taken. Case 3, this is a story of a 40-year-old gentleman who presented with a right iliac fossa pain, had vomiting tenderness, rebound tenderness, typical hot abdomen. On ultrasound, the right kidney showed prominent pyramids. The sonologist was not able to differentiate it from a mass. Left side showed gross hydronephrosis, and there was a collection in the right iliac fossa. The patient was toxic and septic. CT was done. There were 3 important findings. 1, there was a right-sided renal mass. Maximum diameter was 41 millimeter. Left side had gross hydronephrosis. This was secondary to a stone which was about 11 millimeters in the lower ureter. And on the right side, there was a thick-walled collection around the appendix. Basically, it was an appendicular perforation. So 3 issues to manage: appendicular perforation, left-sided obstructive uropathy with a poorly functioning kidney, and a not so small renal mass on the right side.
I must not have been nice to you when you came to visit me. You should have shown these cases to Prokar Das. You made sure that he left and then you gave me these cases, the tough ones. Go ahead.
Amit sir had ordered me to get cases which will be most dilemmatous.
I knew Dr. Ghosh was behind all of this problem.
So sir, needless to say, we'll have to address the appendix first. So appendectomy was done with a lavage. The question that I want to ask you, will you divert the left side at this particular time? This is gross hydronephrosis.
So where was the stone? Can you go back the images for us? Yeah. What's that?
Yes, sir.
Why not? Would be
Why
my
not?
question. I suspect he's going to lose that left kidney. It's non-functioning. The reason to stent him or drain it will be to prevent it getting infected before that happens.
Yes.
And if you can, under the same anesthesia, why not drain that kidney?
Absolutely.
Would be my
So
question.
he's asking next step. So you're going to stent it or you're going to put up work? That's what the
Well, I would, if we could get it stented under the same anaesthetic
So we
as the
go stent first
appendicectomy,
and then
Stent.
work.
and then
if
you
not-
evaluate.
Yes, Dr. Rajesh, you have a comment.
Hold on. Dr. Say, you want a stent or a plug?
I would do a renal dynamic scan. The likelihood is that it would show a very
So he's
poorly
very sick
functioning.
at this time. He's really sick.
No, you have done an appendicectomy and he has not improved.
No, so we were planning appendectomy for this
Okay.
patient.
Okay.
So would you? My question was, would you divert the left side when you're doing
So
appendectomy?
you are doing appendectomy and that's what his question is. not
Look,
waiting for what's going to happen.
the main issue is whether the left side is infected or not. If you
Yes.
think the patient is very sick and there is infection at both the sides, then doing a PCN is definitely warranted. Yes, because that is, because until you drain the last collection of pus, the patient is not going to improve.
Absolutely. Dr. Raj, please.
I'm the youngest one in this discussion, and I'm telling all you old guys, have you forgotten your clinical examination? I mean, the clinical examination may tell you exactly what's the leading pathology in someone that's ill here. He's got severe right iliac fossa pain, and and not particularly tender left kidney, then maybe it is the appendicular mass. There's no stranding around that kidney.
So you are a little, so they removed, so let me repeat the scenario. They have a different question. So you went in, you have cleaned the appendicular mass, it's an appendicular abscess which is perforated. They cleaned it up. Now their question is very simple. You see hydronephrosis on the other side of the kidney. What would you like to do? Do you leave it alone? Do you put a stent or do you do a perk? Am I right?
Right, absolutely.
So my thinking is this kidney doesn't have any stranding around it. It doesn't look particularly infected. The collection in the pelvis, though, has a lot of stranding, is encapsulated. I would deal with the appendix. I'd leave the kidney if he doesn't.
So they dealt with the appendix.
Deal with leave the kidney if they're getting better.
So your answer is you don't want to do anything with the kidney?
No.
Hold on, let's do a vote.
Yes.
Everybody here. Who would want to?
I will agree with Rajesh. There is the chances of this kidney being infected are low. And we can do the perk at any time. Supposing it does not improve after appendectomy, then we can do the perk.
Okay, so hold on. So one choice is observing it. Let's see how many people want to observe it right now. Okay, how many people want to stent it? Percutaneous, okay. Yeah, well, wait.
Retrograde.
Next is perk. How many people want to perk it?
Perk.
So it's kind of almost 50-50 here in the crowd, which is surprising, but they might be thinking no perk because it's not infected and the risk is low. They want to get away with the appendicular thing and then come back. But I would honestly, I'm already there. The patient is on the table, or you can kind of get the perk or intervention to a perk. And now you have that problem solved. What do you do?
So we did perk this kidney. We put appendectomy with left perk, observed the output from the left side, allowed the patient to settle down and cleared the stone on the left side. To see, because the left percutaneous nephrostomy allowed us to measure his outputs and renal functions, his GFR was coming to be around 15, 16. So that's what we did.
Yeah, I'm just giving you the corollary. See, he has been having this obstructed kidney for a long time. And if he's stable, hemodynamically stable, and the appendectomy has been done, and if he's not symptomatic on that obstructed side, why not leave him alone, wait, and then do the URS?
Yes. So basically, retrospectively, all thoughts are perfectly fine. But that time we were thinking that let us stabilize his left side so that, because the right side would be a challenging partial nephrectomy. So let us get whatever is possible out of the left side was the thought that time. But retrospectively, yes, we could have waited and did the same thing. I think clinically it would not have made an outcome. But let's see how the case progressed. It is interesting to note. So now, can you just keep the patient on percutaneous nephrostomy and manage both the sides simultaneously is an option. And I think many of the people in the house would agree that URS with partial nephrectomy either on the same day or a few days apart in the same admission can be done. But the story of this patient is slightly different. The patient was discharged with a creatinine of 1.2, left side completely cleared and stent on the left side. He came back to us 3 weeks later while he was waiting for a partial nephrectomy on the right side with symptoms of uremia, nausea, vomiting, weakness. Obviously left side had hydronephrosis, but the right side also developed hydronephrosis. And this time his creatinine was 5.96. Therefore, the CT is a plain CT. So 5.5 centimeter mass abetting the upper ureter and the renal pelvis, and there is hydronephrosis on the right side. left side is already stented. And we know by our previous scans that the right kidney is only the functioning kidney or majoritarily functioning kidney. I will just show his previous scan. So this is the mass. This is scan 1 month back. No hydronephrosis here. I'll play it again. No hydronephrosis in this scan. About 4.4 centimeters mass, midpolar anterior, overlying the renal vein and the pelvis. But when you see the scan right here, it seems that it is in the area of the upper ureter. But the hydronephrosis is barely like 10 mm, 12 mm.
So because he bled, he basically obstructed his whole system on that side?
No, sir, there is no evidence of bleeding because you see the urine in the pelvic ileal system is obviously of the water density.
And the hydro on the other side is still persistent?
So yes, the hydro is like what it was.
Despite the stent?
Despite the stent.
So what's going on below?
Yes. So sir, we decided the lower tracts are perfectly fine. It has nothing to do with lower tract. That has been ruled out, evaluated, no chronic retention, no hydroureter at the VUJ level on the right side. That has been taken care of.
Was it a retrocecal appendix? Did it go up and maybe till the ureter?
No, sir. The lower ureters are perfectly fine. It is only upper 2-3 centimeters of the ureter that this mass is hanging on. You cannot say that it is engulfed. It's a clearly enhancing mass, well encapsulated, as we saw.
So what's the trick?
So we put in stents, sir. We did not know what to do at this time. We put in stents. As we put in stents, the creatinine came down to 1.08. Bilateral stents. So basically the exact chronology of event is, we thought only the left side is responsible, so we only changed the left stent. Nothing changed. We waited for 2 days, we put a stent on the right side, creatinine started to drop precipitously. Within 4 days, it was 1.08. Diwali week, nobody wanted to do anything, so we let everything be by, and we revisited this patient after Diwali. So now the scenario was the patient was on stent, bilaterally, right-sided, mid-polar mass, 4.5 centimeters, abutting the pelvis. We did not repeat the radiology, it was just done a month back. So we embarked on a partial nephrectomy. Is it appropriate to do right partial nephrectomy at this stage?
Man, you are moving a little fast for me. Because I think there's a few unsolved problems there. Okay, let's see what the partial did.
Would you have done anything different?
No. What was the RGP finding? Because when you put in the stent on
Yes,
the right
sir,
side.
it was only upper ureter that was exactly the CT findings. Upper, you could see the pelvic ileal system dilated. You could see beyond that, everything was fine.
So as per the
something we are missing. I don't know what it is.
So,
there is something.
so as per the RGP, it was because of the pressure of the tumor.
The mass hanging on the ureter. Yes, that is what it appeared on the RGP.
Yeah, that's the only thing we could.
Yeah, and the dilemma was that you never see RCCs causing hydronephrosis. That is the last you can consider as a.
Are you setting us up for something? I think you're setting us up on a different track. There is something else in the finding.
Shrikant? No,
Yeah.
I'm not, sir.
So my question is whether in these 3 weeks the mass has grown in the size or it's the same size?
So if you look at the plain film, the irony is that the last CT was a contrast CT. Now he just recovered out of AKI. His creatinine is 5.6 and then came down to 1.08. So the only repeat scan is a plain scan, and on plain scan there is a 0.5 centimeter growth.
So how would a mass which is not causing any hydronephrosis 3 weeks ago would cause an hydronephrosis and AKI? How would that explain?
So the only evidence is that there is a growth of the mass which is 0.5 centimeters. That is what we know.
Sir, it may be the sloughed out mass which is obstructing the ureter.
There is no intraluminal filling defect on RGP.
Any other change, like a lot of weight loss after his appendectomy? Or, yeah.
So this is not quantified. This is not quantified. It should have been, but it was not quantified.
It's very odd, isn't it? That he should suddenly obstruct that
Yeah.
ureter with a
Yes.
tumor.
So what about retroperitoneal fibrosis or something?
So only upper 2 centimeters, lower, everything is fine. So we thought everything is fine. We embarked on a partial nephrectomy, thinking that it's a 4.5 centimeter mass, amenable to partial nephrectomy. Obviously, we had consented this patient for a radical nephrectomy. And on table, what we found was that the whole mass was engulfing the ureter, to an extent that you had to do ureterolysis of upper 1 centimeter of the ureter, and you just sent the ureteric wall for frozen section, which was positive. Because the ureteric wall was positive for frozen section, we did not have a choice but to convert it into radical nephrectomy. To a point that at a point we put a hole in the ureter, took out the entire punch of the ureter and sent it for frozen. All were positive. 3 frozens, all positive for malignancy. So that we came to know in the final histology. It was a clear cell renal cell carcinoma, grade 3, extensive perinephric and periureteric involvement and sinus involvement, and eventual margins were negative. I have some literature to suggest that the clear cell RCCs with sarcomatoid differentiation have been rarely known to cause hydronephrosis and obstructive uropathy. And this is one case report. I looked at our institutional data. We have 3 patients of relatively small size renal masses, that is between 4 and 7 centimeters, which have caused ureteric obstruction unilaterally. And this was one of them. So moving ahead.
Just one more thought. What surprised me was that the sudden onset, because before, I can understand, but the sudden onset, that's why everybody was looking for some acute reason.
And this probably, sir, happened within a course of 1 month, because 1 month back, he clearly had no hydronephrosis on the right side. And looking at the histology, he does not have any sarcomatoid differentiation, so it actually does not justify the growth that we could. And radiologically, we have an evidence that it grew by about 0.5 centimeters in 1 month.
Can you come back to NCCT image for a minute? Yeah, show the NCCT image.
Dr. Sanjay, I'll have to proceed with the next case. We can discuss this after. You can have your comment.
My comment is whether could have excised that part of the ureter because it's solitary kidney and do a ureteropilostomy or something like that. Maybe little kidney descent, whatever residual. Doing a radical nephrectomy in a solitary kidney. Of course, if I feel there is no other option, I'll go. But I'll definitely could have tried in my
So this is absolutely debatable.
Well, oncologically, it's not the same.
So it's not it's an oncological operation. Sir, ultimately what happened is this patient landed up with a creatinine of 4.43 and is not on dialysis today. He's CKD 4 to 5. My question to you again is, should we pitch adjuvant pembrolizumab to him? He's CKD 4.
Pembrolizumab is also nephrotoxic.
So it is not nephrotoxic. Actually, this is what I was looking. This piece of discussion that we have data. Just Shrikant, I'll come to it in a minute. We have data from lung cancer where pembrolizumab has been used in CKD 4 and 5, and there was remission in these patients for about 40-45 months. So it is safe. If you look at the pharmacokinetic studies, pembrolizumab can be used and even if you look at the leaflet of pembrolizumab, it can be used in the same dose in CKD 4 and 5 patients. So that was another point.
That's what you did.
No, he's awaiting the DMG decision now. So over to Dr. Amitabh for next case.
While you're starting the next case, quick comment. Did you have a comment?
Being a solitary kidney, you really think that you could have saved this kidney somehow? Or you said, okay, solitary kidney, chalo.
I think it was, I haven't seen the scans, but the way they are mentioning the whole ureter is encased and the renal pelvis is, I don't think you could do a partial.
We did a ureterolysis for about 2 centimeters.
Yeah.
Silhouettes of ureter, one after the another, exposed the ureteric catheter below.
I suppose
of about 45 minutes on that area.
And it was infiltrating the wall of the ureter.
Yes,
infiltrating the wall and then encasing.
Three frozen sections.
So this is a pretty aggressive disease. I don't think he's going to be do very well.
Yeah, only comment, Pembro, we can give it in CKD stage 4-5. I agree with you, and it's a pretty aggressive disease, so he qualifies for pembrolizumab. That's what I was talking to.
Yeah, thank you. Yeah, that may be the.
Just I would like to add one point, because immunosuppression basically is a known risk factor for the disease progression. So because this patient had a appendicular abscess, so he was under severe stress, so this could be a reason behind this rapid progression of the right renal mass actually. Yeah, exactly. So it happens even after surgery also. If after like any oncological surgery we do actually face a lot of complications, suppose like hematuria and other things, repeated blood transfusion, then it has been seen that they develop a systemic fluid metastasis also. It is very well known fact.
When did you remove the left PCL?
So that was after URSL only.
Okay. So next fourth case is especially for you, sir, because it is having a bladder cancer, bladder tumor, as well as a stone also, urinary bladder stone also.
Okay.
So
I mean, I think I got enough beating. You want to keep on going?
okay, sir. So this gentleman was 45-year-old man, same, had a history of tobacco smoking. So he had lower retract symptom, obstructive as well as irritative also for 3 months. And he had a hematuria, total gross with passes of clots for last 15 days. So primary investigation was ultrasound. We all do ultrasound as a first investigation. So it was found to have a right kidney having a 5 centimeter stone actually. So it was a Staghorn calculus on the right kidney. Left kidney had a 5 mm calculus with mild to moderate hydronephrosis, ureter dilated, tortuous due to a bladder calculus of 6 centimeter. So bladder has a 6 centimeter calculus along with 8.1 centimeter bladder mass also, which was situated at the right posterolateral wall in this patient. So you can see on the ultrasound images, he is having bladder mass also, Staghorn calculus also, and hydronephrosis on the left side. So IVP, CT, IVU also was done at the same sequentially. So patient was found to have a right Staghorn calculus with same 6 mm right VUJ calculus down the line. So left kidney was normal. There was hydronephrosis because of the stone, and urinary bladder has 7.5 centimeter mass. So my question to sir, like how would you like to proceed in this case? He is having bladder mass also, 7 centimeter bladder stone also, right side Staghorn calculus also, and right side VUJ calculus also.
So I'll go first, but we should take opinion because this is bladder cancer and this is more aggressive and it's different. So I would basically go with the TURBT first. That's what I would go to know exactly what I'm dealing with. I don't know if anybody else wants to comment.
So any role of urine cytology, because on the CT this
Cytology is too little to get an answer here. Let's see if anybody has
because
any other
tumor is big, stone is big, so it is
such a big tumor. You just need to take a biopsy. You cannot do a TURBT in this tumor. I feel it's more than 6 centimeter tumor. You will take a biopsy, you prove it is a TCC. Probably you will end up in doing a cystectomy. The concern remains when to deal with the left right renal stone. That may be a concern, but of course, with such a big mass and such a big bladder stone, ultimately we'll end up with a cystectomy, and subsequently probably I'll.
You want to take straight to cystectomy?
No, I'll definitely take a biopsy.
Oh, yeah.
Of course, I'll take a biopsy, but TURBT probably not feasible in this tumor.
Well, I mean, you have to get a biopsy.
I would take it differently. Since he is a kidney disease, also we are forgetting that it's a big stone on the right side. So I would put a PCN on both sides to buy time, and then we do a TURBT. In 2 stages, we can completely do the job. We can take a biopsy from the muscle, and in 3rd stage, this is a difficult case, I agree with that. We remove the stone, see what the biopsy comes, then we have to make the patient stone free before we embark on any definitive therapy for the patient. So we make the patient stone free, and then we can take a call what we need to do for the patient.
So the left side is not obstructed. Left side is not obstructed.
But there is a
he
stone
has
in the-
hydronephrosis, agreed.
Exactly.
The
So-
mass is on the right side and there is no stone on the left
I agree with you. So what is we can do, see if we can see the ureteric orifice, we can. Sometimes with this big mass, you put a scope, it all becomes red. It is very difficult. So my issue is if you see the right kidney, it's not looking very healthy. So you have to save 1 kidney for the patient for the future also. Whatever you plan to do, diversion, whichever diversion, you have to have one good healthy kidney.
So
and that to me looks like the left side kidney. So just to buy time.
By choices for everybody. So one choice is you go for TURBT biopsy, consider as one thing. One choice is divert the upper tracts and then do it. Are these the 2 choices?
Yes, I would do the second choice.
Wait. Let's first identify the choices. So we got 2 choices. Anybody have any other choice to throw in? No. Okay. Who wants the first choice and who wants the second choice? First choice. TURBT first.
Along with the stone, it's not a hard stone. You can get the stone of the thulium laser, any lithoplast. You get this.
Wait a second. So even biopsy we are saying. So hold on. We are, I think the choices are only two. Am I right?
Yes.
Yes, sir. So get rid of the TURBT along if the stone is blocking. Do something with that. Push it out.
TURBT doesn't mean that you have to take everything. It means you have to take one swipe of the muscle and you're done. So that could be called biopsy, whatever. So
Transurethral biopsy, diversion.
okay, which are the two choices, right? So who's going for transurethral biopsy first?
You can go for both at the same time. Yeah, it's a diversion on the right kidney.
Diversion on the right kidney. So why would you want diversion on the right kidney?
Because
right
there is a
away?
ureteric stone.
Ureteric stone, 8.
Because there is a ureteric stone.
Okay.
So
What about the bladder stone, which is quite big?
Where is the ureteric stone?
Okay, so hold
The
on.
ureteric stone is
Where
not.
is the ureteric stone?
So ureteric stone is not in this particular picture because he came to us with.
So what is the level of ureteric stone?
VUJ.
Which side?
Right.
Right side. So I think we have to just take the biopsy, establish the diagnosis. Once you establish the diagnosis, finish the right PCNL. In that time, it will be finished in few days' time. Keep PCN after a PCNL and then do cystectomy. This is very clear.
So choice is very simple. First choice is
Yes.
TURBT or a biopsy, whatever you call it, right?
Right. Yeah, it is well excreting, sir. It's well excreting. See the urogram.
Yeah, that's a good point, right? But right
You
now.
can't get a enogram done for every case.
Okay, so hold on. I think we are getting stuck at this. Let's go to the next.
Okay.
You did a TUR.
So we did a.
Yeah. So we did TUR biopsy actually. Histopathology was T1, high grade, grade 3 actually. So muscle included, but it was negative, but it was a incomplete resection actually, because tumor was big and it could not be possible to do TURBT at a single. So what would be your next step, PCNL or just go and do re-TURBT?
Let's see what the world says.
That is what I said, because it's such a big tumor, it's not feasible and not advisable to go in one stage and finish it off with that big a stone inside. So just to buy time, you have to divert the kidney because the functions deteriorate very fast.
It is diverted, sir.
It's already diverted. Then it's fine. So then it's fine. Then you complete the TURBT. You have to complete the TURBT. If you find, see, we have seen, we may feel that the patient is will do
He
diverted, and TURBT has to be completed. You have to include the muscle and then see what
So
happens.
basically, would you first do the PC? The question is whether you will do the right PCNL first or you'll go for a muscle biopsy. That is the only question
No,
we are
you
trying to
have
ask.
to go for the muscle. PCNL
Muscle.
has to be done.
How many say that we'll take the muscle first or PCNL first? So there are only. This is an endless discussion. We need to finish this.
No. I would go muscle because I
Muscle.
want to know exactly what. That is my opinion.
In presence of such a big stone, bladder is bound to be very small. It is going to have all red vision. It is not possible to do complete TURBT and take everything. There is a big
It means
stone.
we want muscle
It is
samples.
very likely that this is likely to be squamous cell because such a big stone with the squamous differentiation, and therefore in all probability, when you see the appearance of a tumor on the cystoscopy, you have to see how sort of that tumor is. Whether it is sessile, whether it is flat tumor, is appearing very big tumor, very likely squamous differentiation. Once you do PCNL, in all likelihood, this is unlikely that it will be managed by endoscopic treatment and TURBT and subsequent intravesical chemotherapy. Even though it is high-grade T1, it is likely to end up with cystectomy. With
So,
such a
so
big
you
stone.
want basically in simple answer.
There is
you
no
want
point in
to
wasting
take care
time.
of the
Finish
upper
it off
tract.
PCNL, and you have this sort of a histology which is proved, and you have seen the appearance of the tumor, and then you plan for cystectomy later on with ileal
So
conduit.
hang on, yes.
Right PCNL.
Sir, I will do is biopsy because this is a big tumor. So I do not require a muscle deep biopsy to prove that I have to do cystectomy. So, and I will manage the bladder tumor first rather than going and doing PCNL. So then one more thing, the same question, that if there is a bladder tumor and I'm resecting the tumor, then I will be skeptical about putting a DJ stent. Won't put a DJ stent very easily,
Well, let's not go into details. You wanted to resect the tumor first. That's your
No,
choice.
he wants to only biopsy and cystectomy, removing that stone.
So you want to do cystectomy first.
So, how many agree that cystectomy followed by right PCNL? Does anybody on the house, just opinion, raise a show of hands, people who would do cystectomy first followed by right PCNL?
Okay,
And you
so
then-
hold on. Let's do it properly now that we are here. Cystectomy and right PCNL. How many people want to do that? Yeah, cystectomy. Because the question is, there is no muscle involvement. Some people might argue, I can resect everything and it's going to be only T1. Why did you do a cystectomy? In some systems, it is a legal issue. So let's say, how many people want to do a cystectomy at this stage and get the bladder out?
Doing,
PCNL followed by cystectomy.
PCNL and cystectomy is one choice. PCNL followed by cystectomy. Yes, sir.
so doing PCNL after cystectomy is quite difficult.
Yes, I agree.
Okay.
So why can't we do a pyelolithotomy during the cystectomy?
Pyelolithotomy during a cystectomy is an ardent task. Your incision is going to be different if you are going to
With
do
with a robotic
robot.
approach.
You have to redog the robot. You can't get to the
That's
renal
fine.
pelvis. It's a full-blown stag-on.
Okay, Dr. Stenzel. Dr. Stenzel. We need your opinion. You are the judge here. No. We want to see what you are going to do. Okay, while we are waiting for you, let's hear the opinion here.
Sorry, I'm really enjoying this, but I went to the loo when you were presenting the case, and I didn't see whether the CT confirmed muscle invasion, and if it didn't...
It did.
So, by the way,
sorry, I
You
missed
want to
that bit.
confirm muscle invasive. Would you do a cystectomy?
Well, I was going to ask, did you think about doing an MRI scan to establish whether...
okay.
Okay.
I'm taking it back a step.
Okay, you
Because
want to
if,
image it. You
if,
want
it's,
to image it.
if it's G3T1, surely you want to try and preserve his bladder if you can.
Okay, hang on. Can you go back for Dr. Stenzel to look at the scan for a second? Because he was busy with something else. We want to bring him back.
No, I agree with most of the people here that we should have an MRI if we are doubting about that. But that looks like you can't do anything but doing a cystectomy to cure that
So
patient.
you would go for a cystectomy?
Yeah, I would
even
go.
though
How old was he?
He is a young guy.
45.
45.
Oh, shoot. And it's a high grade T3.
It's high grade ECC, no
Yeah.
muscle.
No muscle.
No muscle. The muscle resected,
Yeah.
but it was not involved.
Yeah,
Could be a
okay.
squamous cell also.
But they didn't do the full resection.
What I would like to know is from the endoscopy, did it look like that or could that have been coagular? You know, we have to be careful about what Alan was saying, that this could be coagular. The masses you see here in the bladder.
Yeah,
So I'd make
Stone.
It's a stone.
It's a stone.
Visualized stone.
in the bladder.
In the stone and tumor both.
Yeah, but that, no, wait a minute. I'm not talking about that. I'm talking about the dark gray stuff, not the stone. The dark gray. Is that blood or is
It's a mass.
It's a mass.
it's a mass
It's a bladder mass.
out?
It's not a clot.
Out, and then a nice orthotopic neobladder with no sparing of the cystectomy. If it's not that, you can nicely do that, and he will be cured, and otherwise will have a risk.
Dr. Dasgupta, you are next. What would you do?
I would
Bring everybody up here.
I would refer the patient from here to you.
No, seriously, what would you do? Would you do a cystectomy?
After you have had my butt for so many years, it's time for payback. Look, I would do a nuclear medicine scan. I think we need to know the function of that right kidney, because if that right kidney is non-functioning, then I would do a cystectomy and a right nephrouretrectomy at the same time.
Good point. Okay, so what we did?
So we did right standard PCNL with the ureteric placement, ureteric catheter placement. The post-operative patient was fine actually. CT thorax for staging was done, so there was no metastasis. And followed by patient was planned for radical cystectomy with ileal conduit. And surprisingly, yeah.
Why Lily Conrad?
Patient okay, because he is young. He could have.
There is a story to this.
So this patient is from his institution. He will explain.
You did not sell a neobladder to him well enough.
Yes.
Even after I have shown you data from this beautiful land that the patients have a better quality of life with a neobladder. I mean, this guy is 45, for God's sake. Come on.
All right.
So he got a cystectomy and Manu failed the two surgeons who are your guests because they're upset. Let's go to the next step. I'm okay. I'm still looking.
You're still okay?
Because I'm not the surgeon.
So his residual stones.
Everything can be changed. I mean, he can have an underversion also, you know.
Yeah.
Just
So after 1 or 2 years, you can make a neobladder. Like you can convert conduit to neobladder. Okay.
So what was the kidney function? Because I know you decided that the neobladder was not a good idea because the kidney was bad.
No, it is perfect. I'm not trying to justify
So final staging was T2 and 0, TCC, focal squamous differentiation, as sir has pointed out. So after surgery, actually he developed obstructive uropathy secondary to residual stone post PCNL
on the right side.
on the right side.
So then you manage it endourology. Left side was fine. So he actually was, his creatinine, everything was fine. With the stent, you had to go in and take out the stone.
It is 61.
Thank you. Next.
So last case, quickly. Yeah. So this is a story of a 42-year-old gentleman who underwent transplant, a living-related transplant. He presented with hematuria and clots. An ultrasound suggested a mid-polar mass in the graft kidney. So this is his graft kidney, 8.5 centimeters mass at the level of mid-pole in the graft. My questions to the panel. Partial nephrectomy in a graft, when feasible, should it be done?
I have done a few of them, no partial.
Basically, if this graft, after transplantation, anything you are going to do after 6 months, all the hilum and everything is plastered. It's very difficult to find out.
Needless to say, it is difficult. Should it be done? Should it be attempted when the mass is amiable to partial? Is the question?
Yeah, it can be attempted. Of course, it can be. Literature says it can be attempted, but it's such a big mass. It's of course difficult.
Leave apart the scan. Can it be attempted?
Can be attempted.
Should it be attempted in this
No.
case? Is another
No.
second question.
No.
No,
This
it should
no.
not be attempted in this question.
So wait, let's ask the expert. So let's start from, what do you think? Would you do, if you got a transplant kidney with a tumor, would you do a partial, or if you had a chance to do a partial?
I mean, if it's a transplant, this is his only chance, and I'd probably take it. Yeah. Okay. I would
You take
try.
the whole kidney,
No. I
Partial.
take the chance to try it.
a partial.
Partial. Yeah. I mean, how long ago was a transplant?
It was about 3 years, I think, 3 years.
Oh, okay, so it must be very scarred. So a retransplant, taking it out and doing a bench thing,
And then
I don't like it because there's too much risk in there. But I would go in there. It's in the pelvis.
Yeah.
Yeah. I would go for a partial. It's easier there because you got more room and more space.
Let us hear it from a transplant surgeon now.
Because technically, I completely agree. Technically, it is extremely difficult because even doing the graft nephrectomy itself is a very hazardous operation. On top of that, you find the margins and you find out the area. Technically, it is very, very challenging.
Yeah, if you see
Nevertheless, with 3 years of transplant, if it is long, many years, it is all right. But 3 years, you have to change the immunosuppression completely. Because with the tacrolimus, with MMF, and I don't know what sort of immunosuppression he is on, you have to stop many immunosuppressions after if you do partial nephrectomy. And in that, the graft eventually is going to get compromised, and you end up just adding few months, and the graft eventually is going to
And now you
fail.
have to go back
And now you have not done oncological appropriate treatment. So you have to accept that there is a tumor in the kidney. It is quite endophytic tumor. It is better to remove it, wait for 1 or 2 years, and then consider retransplant if it is feasible.
I am a lot in agreement. The reason is I have had a few of these transplant patients who, even though they have very small tumors, but the immunosuppression, and I think that was the question which was being asked.
Yeah.
How far out? Because immediately within the first 3-4 years, they are in high immunosuppression. And I can tell you, they come back like wildfire. You remove it, everything is clean in the renal pelvis, ablate everything, and then you come back 6 months later, now we have a bigger tumor sitting right there. That's why I kind of do that. Prokar, any other comments on this?
We have a large transplant unit, as you know, at Guy's, and I'm fairly certain that after discussion in the MDT, transplant MDT, this poor patient would have a transplant nephrectomy.
You would have a transplant nephrectomy. Transplant nephrectomy, that's what about you?
So I would do a graft nephrectomy first and put the patient back on dialysis.
So, as regards to the immunosuppression, one thing that you should be, 2 minutes, sir, so 2 minutes, that you should be knowing is that are these patients on CNIs? In today's day and age, the number of patients on CNIs after 3 years are less, but if the patient is on calcineurin inhibitors, then the risk is a little more. Important question is the risk of RCC in transplant patients more than the general population? It is in fact about 10 times more. If you look at the statistics, it is about 0.1 to 0.5%, and in the general population it is 0.01%. So it is a tenfold increased risk if you look at that. Another question, that is partial as safe in graft as in the normal population? Yes, it is. The technicalities are far more difficult, but if you are able to achieve the end goals, then the outcomes are similar. Because I have to close this session in another 2 minutes, 2 things that we should be wary of in this particular subset of the patients is that these patients have far more number of papillary cancers as compared to the clear cell cancers. So these cancers can be imbibed from the donor. So a very important thing is that donor of this patient needs to be screened for papillary RCC. That is an important take-home point. The incidence of papillary RCC in this subgroup of patients is about 45%, and the incidence of clear cell drops down from 75% to 42%. So this is an important information that we should know. Once we have done a nephrectomy for this patient, you score these patients as per the Leibovitz criteria, which includes your TNM staging, the size, the grade, and put a score to it. If the score is less than 1 or 2, then this patient can go for transplant immediately. Any score of 4 to 5, you need to do due diligence in the DMG. If the score is more than 6, it's an absolute contraindication for transplant. With that, we close this session. Thank you very much. Sir, we'll take the comment.
How many people here who do transplants have done partial nephrectomy in a transplant kidney? They're all transplant. I'm one of them. They're all transplant surgeons here. How many have done partial nephrectomy in a transplant kidney? And when did you get the tumor after the transplant?
So I have done a partial nephrectomy in a very tiny small tumor, maybe 2 centimeters. So I didn't even go to the hilum. I opened up transperitoneally and just hold the kidney and take it out and switch it back. And that patient did very good in the follow-up. And it was probably, what I can remember, maybe 3.5 and 4 years after the transplant. But it was a very small tumor.
So there's very interesting.
So did you do an angiography before you did this transplant, partial nephrectomy?
Of course, we have done a CT angiography conventional.
Thank you very much.
We have 3 cases.
One of the most
attempted partial, ended up with a radical, because there's a lot of fibrosis around. Unless you got one right on top or one below, but if you got it anywhere near the midpole or anything of that sort, there's so much of fibrosis, whether they take calcium inhibitors or not, It's absolutely stuck.
Absolutely.
You
Very
can't even
wonderful
find the
model.
vessels. Thank you.
Thank you very much. I think this was one of the well-designed, provocative sessions that we had deliberately planned. It was lovely. I think everybody's waiting for the hero Simon to declare the consensus, and let us see what he has to say.
Thanks, Amit. I must say, it's day 3, final session, and we're starting bang on time. I don't know about these rumours about India Standard Time. This is like Switzerland. This is running spot on. So thank you to Bav at the back and to Raj as well for helping collate this data. And we've got a couple of other people going to come up and present the data as well. Just get our slide. What? I'm just doing the remote. Have you got the... on that one? Oh, thank you. Is it that one?
Hello, check.
Right. Excellent. Okay, so it's like the award ceremony announcements, isn't it? So I'm going to take you through the consensus statement for small renal masses. First comment, looking at all the statements, is I think this is going to provide a useful foundation for further statements, further refinements, further guidelines, so you have India-centric statements. There are also a number of statements where it's very close to getting to our significance level, so they're not included in here, but they may be statements where we can nuance it a little bit further in future and get further statements out. And the third thing we noticed looking at all the statements was that there's some factors where there's a big 50-50 division in opinion. And that actually might be a useful sort of source for trials or real-world evidence to try and support which way we go. But just starting off with the small renal masses, so less than 4 centimetres in diameter, the first bit we looked at was optimal diagnostic imaging. And if you look at the graph here, what we've got in the dark green is sort of the strongly agree, and the light green is agree. And then further down, we've got the dark red is strongly disagree, and the light red is disagree. And we've got 75% there as our cutoff, so you can see how far over the 75% we were. So the first consensus statement is that patients with a small renal mass should have systemic imaging to complete their clinical staging. The second agreement was the optimal systemic imaging modality for patients with a small renal mass is a CT chest, abdomen, pelvis. And then there was disagreement, so I think we can flip this and say that FDG PET-CT is not the optimal systemic imaging modality for patients with a small renal mass. Looking at the role of renal mass biopsy, there was consensus that patients with a small renal mass should undergo percutaneous biopsy prior to considering active surveillance, prior to considering non-ablative or non-ionizing ablative therapy, and prior to considering SABR. What there was strong disagreement with were the comments that patients with a small renal mass should undergo percutaneous biopsy prior to a partial nephrectomy or a radical nephrectomy. So the consensus among our audience was that if you're doing a non-surgical approach, they would recommend a biopsy. If you're doing a surgical approach, they wouldn't. Looking at the role of active surveillance, patients with a small renal mass can be offered active surveillance as a management option, unless they're firm and grade 3. And also there was strong opposition to using ultrasound as an imaging modality for optimal surveillance. What there was agreement, though, was the optimal surveillance imaging modality for patients with a small renal mass is a dedicated kidney CT. And then the final bit on this active surveillance, the patients undergoing active surveillance should have with first small renal mass should have the frequency of imaging determined by the grade of tumour on biopsy. Moving on then to non-ionising ablative therapy, there are a lot of agreements here. So non-ionising ablative therapy for small renal masses should only be offered in high volume centres. We think there should be work to determine a minimal level of expertise or experience. And then we could offer non-ionising ablative therapy in patients with a surgically resectable mass if they decline surgery, or if they're high risk for surgery, or if they're inoperable due to medical reasons, or if they're in high risk of needing dialysis, which are pretty much the standard reasons why we refer. We also said that RFA was the preferred non-ionising ablative therapy, and that patients undergo non-ionising ablative therapy for small renal mass should have a biopsy performed at the time of procedure, if not performed in advance. Obviously, we've got the earlier statement saying it should have been performed in advance. And then patients suitable for cryotherapy should be offered this percutaneously. Looking at SABRE, SBRT, very similar, that it should be delivered in high volume centres. It can be used in patients who have a surgically resectable mass but who decline surgery, are high risk for surgery due to medical reasons, are inoperable due to medical reasons, or in high risk of needing dialysis post-resection. Looking at radical nephrectomy, so patients with a CT1A complex, so i.e. the potential to be PT3, small renal mass, can be offered a radical nephrectomy as a management option. Patients with a T3A small renal mass can be offered radical nephrectomy as a management option. Patients with a central small renal mass close to the hilum can be offered a radical nephrectomy, and patients with a central small renal mass close to the collecting system can be offered a radical nephrectomy. Looking at nephron sparing surgery, the consensus was that that should be offered where technically possible. Patients with a CT1A small renal mass can be offered nephron sparing surgery as a management option. And patients with extensive positive margins following nephron sparing surgery should be offered a completion nephrectomy. And then finally, future research themes. There's interest in the genomic profiling of small renal masses undergoing active surveillance. And also, does the treatment of small renal masses improve outcomes? So they were the statements for the renal masses. Now we're going to have Dr. Atluri come up and talk to, excellent, this side. He's going to take you through the non-muscle invasive bladder cancer consensus.
At the outset, I would like to thank the organizers for giving me the opportunity and congratulate them for the excellent, fantastic meeting which is about to conclude. So, in the non-muscle invasive bladder cancer, regarding the optimal diagnostic imaging, there was a agreement on this optical enhancement techniques like blue light, narrowband imaging should be used to guide a TURBT recurrent and multifocal. And there was a strong disagreement that MRI and pitch biopsy can replace TURBT for suspected NMIBC. En-bloc resection of the bladder tumor should be attempted at a TURBT. 61% had an agreement and 17% had a strong agreement for this. The goal of the TURBT should be to identify muscle in the resection specimen. Strong agreement about more than 75%. A single dose of intravesical chemotherapy should be delivered following resection of a new NMIBC. Everyone agreed upon this. And what is the preferred intravesical chemotherapy following resection of a new NMIBC, mitomycin C? Going ahead for the optimal TURBT, in the context of a normal cystoscopy and CT IVU and a positive urine cytology should be investigated with a mapping bladder biopsies. Most of them agreed. They also agreed for bilateral ureteric washings should be done in the same context, and prostatic urethral biopsy should also be taken in those. There was a disagreement that random biopsy should be taken for all patients with new bladder cancer to exclude carcinoma in situ. Prostatic urethral biopsy should be taken in all patients suspected of requiring radical cystectomy and cystoprostatectomy prior to consideration of orthotopic neobladder. There was a strong agreement here. I would like to ask the esteemed luminaries here, would you prefer to do a prostatic urethral biopsy prior to contemplating a cystectomy for orthotopic neobladder? Dr. Prabhakar Das, any comments on the last consensus? Finish it? Okay. For the first line intravesical therapy, BCG plus or minus other agents, most of the consensus we have an agreement here. Maintenance intravesical BCG therapy should be continued for 3 years in total in all high-risk NMIBC patients seeking bladder preservation was agreed upon. If BCG is unavailable or in presence of a significant BCG-related toxicity, intravesical gemcitabine can be offered to the patients seeking bladder preservation. Similarly, if BCG is unavailable, you can also use intravesical docetaxel chemotherapy, and mitomycin C hyperthermia can also be offered. Concomitant steroids should be prescribed for patients with BCG cystitis to improve tolerance and reduce symptoms to improve compliance was disagreed. And fluoroquinolone administration should be avoided in patients receiving intravesical BCG therapy was strongly agreed. Intravesical therapy for high-grade recurrence or persistent disease. BCG in combination with intravesical chemotherapy can be offered for recurrent high-grade NMIBC post-BCG therapy for patients seeking bladder preservation. There was a strong disagreement. Intravesical chemotherapy in the form of gemcitabine, doxorubicin, docetaxel, gemdosi can be offered for recurrent high-grade NMIBC post-BCG therapy for patients seeking bladder preservation was strongly agreed upon. BCG in combination with intravesical chemo, example mitomycin, can be offered for persistent high-grade PT1 TCC post-induction BCG for patients seeking bladder preservation was strongly disagreed. Coming to systemic therapy for high-grade recurrence, we have most of them have strong agreements. Systemic immunotherapy can be offered to patients with persistent recurrent CIS post-BCG therapy if seeking bladder preservation or unfit for cystectomy. Similarly, systemic immunotherapy, example Pembro, can be offered to patients with persistent or recurrent high-grade PT1 TCC post-BCG therapy if seeking bladder preservation or unfit for cystectomy. Alternative non-BCG intravesical chemotherapy can be offered to patients with persistent or recurrent CIS post-BCG therapy within a clinical trial if seeking bladder preservation or unfit for cystectomy. And alternative non-BCG intravesical immunotherapy can be offered to patients with persistent or recurrent high-grade PT1 TCC post-BCG therapy within a clinical trial if seeking bladder preservation or unfit for cystectomy. Coming to radical cystectomy for high-grade recurrence, we had a strong agreement on the consensus for this. Radical cystectomy should be offered for persistent CIS post-induction BCG, which was strongly agreed. And radical cystectomy should be offered for persistent high-grade PT1 TCC post-induction BCG was also agreed upon. Coming to variant histology, radical cystectomy should be offered first line to patients with NMIBC and micropapillary changes was agreed. Similarly, it should be offered to patients with NMIBC and extensive sarcomatous changes was agreed upon. Also with the plasma sarcomatous changes, and it was agreed that we should go ahead with a radical cystectomy. Neoadjuvant chemotherapy should be offered to patients with NMIBC with small cell neuroendocrine variant histology was agreed. Coming to future research themes, there was for the genomic profiling of non-muscle invasive bladder cancer, which was strongly agreed. This was the only one which we have got a consensus. So I would like to ask next speaker to talk upon prostate cancer. Thank you.
Thank you, the organizers, for inviting me for this. So I'll start with the optimal diagnostic imaging for prostate carcinoma. We had consensus on optimal staging investigation strategy for MRI pelvis, nuclear medicine bone scan, and the CT chest or abdomen or pelvis. It had an agreement. MRI pelvis and PSMA PET CT scan, we had an agreement. I think that's all. I don't think we had agreement on anything else. That's all, right? I think title is different. Okay, sorry. Okay. So I think the title is different here. So it's regarding transperineal versus transrectal biopsy. The optimal prostate biopsy technique is transrectal ultrasound and transperineal needle biopsy. So we had an agreement. Whole prostate gland mapping biopsies are required to diagnose prostate cancer and guide management decisions. We had an agreement. MRI software guided fusion biopsy is superior to cognitive fusion biopsy to diagnose prostate cancer and guide management decisions. We are in agreement. All patients undergoing transrectal needle biopsies of the prostate should receive prophylactic antibiotic. We are in strong agreement. All patients undergoing transperineal biopsies of the prostate should receive prophylactic antibiotic. We are in agreement on it. Then the role of radical prostatectomy with or without pelvic lymph node dissection. Patients with high risk or locally advanced prostate carcinoma can be considered for radical prostatectomy. We had an agreement. Patients with T3A prostate cancer can be considered for radical prostatectomy. We had an agreement. Patients with T3B prostate cancer can be considered for radical prostatectomy. We had an agreement. The patients with T4 for radical prostatectomy, all of us disagreed. Patients with low volume N1 on PET imaging only for prostate cancer can be considered for radical prostatectomy. We had an agreement. Regarding role of radical prostatectomy plus or minus pelvic lymph node dissection, patients with low volume N1 can be considered for radical prostatectomy. It's a 70% agreement was there. Bulky N1 on any imaging modality for radical prostatectomy, whether can be considered for radical prostatectomy, we had strongly disagreed. Patients with Gleason score 4 can be considered for radical prostatectomy, agreed. Patients with Gleason grades group 5 prostate cancer can be considered for radical prostatectomy, agreed. Patients with a PSA more than 20 and prostate cancer can be considered for radical prostatectomy, agreed. Then patients with N0 on PET imaging, prostate cancer undergoing radical prostatectomy should have a lymph node dissection or not, agreed. Everybody wanted to have a good agreement for lymph node dissection. Patients with low volume N1 on PET imaging only, prostate cancer undergoing radical prostatectomy should have a pelvic node dissection. Almost everybody agreed for that. Patients with low volume N1 on MRI, prostate cancer undergoing radical prostatectomy should have a pelvic lymph node dissection or not. Everybody agreed. Patients with bulky N1 on any imaging modality undergoing radical prostatectomy should have a pelvic lymph node dissection or not. Everybody agreed. So role of radical radiotherapy plus minus pelvic lymph node radiotherapy with or without brachytherapy boost. So patients with high risk or locally advanced N0 prostate cancer receiving radical hormone radiotherapy should have their prostate, seminal vesicles and pelvic lymph nodes irradiated. I think it had a good agreement. Agreed. Patients with high risk or locally advanced N1 prostate cancer receiving radical hormone radiotherapy should have their prostate, seminal vesicle and pelvic lymph node irradiated. Almost everybody agreed for that. The optimal radiotherapy schedule for high risk or locally advanced prostate cancer is conventional fractionated 2 grade. Everybody agreed on it. The optimal radiotherapy schedule for high risk locally advanced prostate cancer is extreme hyperfractionated, N equal. So there also 81% had agreement. Patients with high risk or locally advanced prostate cancer should be considered for ADT plus radical radiotherapy plus brachytherapy boost. Almost everybody agreed upon that. Role of ADT plus with or without novel androgen receptor targeted agents. Patients receiving radical radiotherapy for very high risk or locally advanced prostate cancer should receive 24 months of abiraterone plus prednisolone. Almost everybody agreed on it. What duration of ADT should receive radical radiotherapy for high risk or locally advanced prostate cancer? 24 to 36 months. Almost everybody agreed on it. Patients with multiple comorbidities receiving radical radiotherapy for high risk or locally advanced prostate cancer should still receive ADT. Everybody agreed on it. adjuvant ADT can be given to patients with locally advanced prostate cancer post-radical prostatectomy if N1 disease was found. Everybody agreed on it. Regarding prostate cancer survivorship, living with incontinence and erectile dysfunction. So patients receiving ADT should have a structured exercise program. I think almost everybody agreed on it. Patient receiving ADT should receive vitamin D and calcium supplementation. Almost everybody agreed on it. Patients receiving ADT should have a baseline DEXA bone scan. It's a good agreement. Penile rehabilitation therapy should be offered to all patients undergoing radical prostatectomy. I had also had an agreement. Dedicated pelvic floor physiotherapy should be offered to all patients before and after radical prostatectomy. Everybody agreed on it. Regarding prostate cancer survivorship, patients with erectile dysfunction following radical treatment for high-risk prostate cancer should be offered specialist advice on management. Everybody agreed on it. All patients should have access to a key worker to coordinate their holistic care needs. Absolutely everybody agreed on it. Regarding the future research themes in prostate cancer, the role of trimodality therapy for high-risk or locally advanced prostate cancer, agreement is there. The impact of PET-guided management decisions, agreement is there. Genomic profiling of high-risk prostate cancer, is an agreement. That's all. Thank you. I'm Dr. Chirag from Pondicherry.
Good evening. I'm delighted that the consensus statement, which was the main objective of this whole exercise of Global Uro-Oncology Congress, has been successful. This was a dream come true as far as our council is concerned. Well, it is probably the beginning of a new journey in a new way of conferencing in Calcutta. I have had tremendous cooperation from the council members themselves, many people all over the nation, but I particularly want to thank the foreign faculty, including Prabhat Dasgupta, Alan McNeil, Simon Hughes, Arnold Stenzel, and Khurshid Guru for taking so much trouble, and particularly with the very, very frequent phone calls that I have been making all throughout this year to make this entire thing a great success. After all the efforts can only be enjoyed if it is success, and there's nothing better than success. And I think this is unqualified success because everybody came. We had nearly touching 400 registrations, which I never imagined. We were prepared for 200. It doubled the figure. And I think everybody stayed back until the last, which was a big achievement by our Kolkata standards. I think people have got very high expectations now. The biggest thing was we could stimulate the junior consultant group who are new consultants or maybe 5 or 10 years into their consultancy, have really had a stimulation thanks to the presence of international faculty and the very stalwart faculties from all over the nation. This, I think, will drive us forward. We would still continue to expect cooperation from every quarter. We have had not only this consensus statement, we've now got a commitment as far as the journal is concerned. We need to elevate the standard and be actually as punctual as we have been. This was a challenge that I took, as I say, absurd challenge. Again, the second dream come true. I was hell-bent on actually launching it on the 24th of November, so we did. Finally, it was a great privilege, I think, to have involved real stalwarts of the world in urology. Icing on the cake was Mani Menon receiving the Tagore Award. It was our pleasure. We're indebted to everybody who made this possible, and we should not conclude before we thank the industry. If it was not for the industry, we could not have mobilized this force. In fact, campaigning to come was also done by the industry, and also the budget that we started with, you wouldn't imagine, has actually doubled. We're in a deficit by 50%, but they have promised that they will fulfill this gap. And I think we must all remember their contribution and not actually look down upon them saying that they're not the medics, we are the ones who are the boss. It is not. If we have to continue medical education, particularly in this country, we really need the help of the industry, and we should recognize them as equals rather than second grades. Thank you very much. I hope you've all enjoyed Kolkata, and I hope you will come back to us if and when we call you. Not if, we will call you. So be prepared to be bothered more and more. Thank you very much.
Well, I'll stay in touch. I'll also send you. Okay, Rob,